Hello, good morning all. Welcome to today's workshop, an introduction to Kinovia. That's a software for analyzing movements and other things. Professor Sam will be the one that is going to take us through Kinovia. So we are waiting for him to start the lectures. Before then, I will make some certain announcements. For those of us that are having difficulties in uploading their, what is it called, their ephemeral receipts, I think I have spoken about it. So later, after we are done with this workshop, we are going to sort it out. And as we all know, for you to get your certificates for this hands-on, you must attend the workshop. That is one. After attending the workshop, you must submit your assignments. That you must participate in the group assignment that was given to you, because that is the essence of the council. That you must practicalize it together with your together with your facilitator, because each and every state has its own facilitator. So you have to interact, do the assignment that you get before you will be given certificates. Otherwise, we can't give you hands-on certificates. Thank you very much. I don't know if there's any question. If you have any question, you can raise up your virtual hands before Professor Sam joins us, so that we can interact before he comes in. As you can see now, we are already 100. We already reached 100 participants. So just check our general group. The link to the Zoom is there. So you can just join us. Thank you. If you have any question, you can unmute. You can raise up your hand, then I will unmute you and give you the chance to ask your question. Thank you very much.
Please, can you come again on the announcement? I missed the first part of the announcement. Please, can you come again, sir?
What I have just said, for someone to be eligible for this certificate, he must be present during the hands-on workshop. That is one. He must actively participate, not just attending. That is two. He must submit all the assignments given to him by his facilitator. Otherwise, there is no certificate for him. As we all know, each and every state has different facilitator. So you have to interact with the facilitator, carry out the assignment given to you, and any other tasks given to you. So that's it. Thank you all. So once again, as I have said, as we can see, our Zoom is already at its full capacity. So for those of us that were not able to join, you can join I have sent the Zoom link. Sorry, I have sent what is it called? The YouTube link. So you can use that one and watch us through the Zoom, through the through the YouTube. Thank you. It's all the same. We are still waiting for our facilitator, Professor Sam, to join us. Once he joins, we'll start. As I have said, if you have any question, you are free to unmute yourself and ask. If you can't unmute, just raise up your virtual hand. Then I will unmute you so that you can ask your question. Thank you very much. The link to our YouTube channel is there on our general group. So, in case if anyone is asking you that he couldn't access he couldn't access our Zoom, so you can ask him to go there. Thank you. We are very sorry for all the inconveniences. Our facilitator will soon join us. So let us exercise some patience, please. In a few minutes to come, we will be with you. Thank you for your patience and understanding. No, yeah, we are yet to start. That's why you can't hear anything. But in the next few minutes, we'll commence. Thank you very much. Just give us some minutes. We are waiting for the facilitator. He said that he's having some challenges, but we will soon overcome it. Sorry for the inconveniences. Yes, sir, you can unmute yourself and ask your question. I have unmuted you. You can go ahead. Someone has raised his hand. You can unmute.
Hello, good morning. Hello, good morning.
Go ahead, but raise your voice.
Please, I want to get some clarification. When is a hands-on for participants in the Southeast, especially Enugu? Have the date for the hands-on been scheduled?
Sir, I think if you are in the general platform, it's just a community. There are specific platforms for each state. So you can join Enugu and raise your question there, sir. Are you in the general platform?
I don't think so. This is the platform for the webinar. I've not seen any such
So just
invitation like that.
after we are done, just log into the general platform. You will see Enugu and the other states. Just ask them. I know the facilitator there will attend to you, sir.
Okay, welcome. Thank you.
You're welcome, sir. For those of us that couldn't join the Zoom, you can join us through the YouTube. I have already sent the YouTube link. I have already sent the YouTube link to our general platform. So you can go there and join us through the YouTube link. So it's all the same. Please, for those of us in the waiting room, let's go to the, what is it called? Let's go and use the YouTube link. Let's use the YouTube link. Let's use, because I'm even trying to admit the facilitator because the link is already, the house is already full. So let's use the Zoom link, please. Sorry, not the Zoom link, the YouTube link, please. Let's go there and join. Thank you.
So many we should exit from Zoom. I use only YouTube.
Hello, good evening. One of the facilitators is around. So I think our lectures can start. You should advise those that were not able to join to go and use the YouTube link. Let them go and use the YouTube link. Eh? Let them go and use the YouTube link because the maximum capacity here is 100 and we have already reached that. So let's go and use that one. Hello, sir. I think you can start, sir, because we are already behind schedule. So you can start. You can unmute yourself, sir, and start.
Hello. Good morning, everyone.
Hello, yeah, I can hear you.
Can you hear me?
Yes, I can hear you.
Okay, please, I want to beg your indulgence. Can you just give me like 5 minutes? Let me just set up and just 5 minutes. Just 5 minutes. Let me just quickly set up one or two things. I will be having a network challenge and other issues surrounding. So please just 5 minutes. I will be with us shortly. I'm not leaving the meeting.
Okay, sir. No, Allah. We are waiting, sir. Oga, an tashi lafiya. Kai ne zaka bige mana makulli? Please, I'm very, very sorry for the. I'm very, very sorry on behalf of the facilitators because we were not able to start on time. The facilitator asks us to give him 5 minutes. Sorry, the facilitator asks us to give you 5 minutes. He will be back. So let us be patient and give him 5 minutes to join us back. Thank you all. So maybe if there is someone that will enlighten us about something, I think, so that we won't just stay quiet. Hmm? If there is someone that wants to enlighten us about something, I think the door is open. You can unmute or raise your hand so that I can unmute you to maybe enlighten us about something. Thank you very much. Hello, please. Is there anyone? Is there anyone that can? Hello? If there is anyone that will volunteer, the door is open. Please, we are about to start. Just be patient with us. Hello, our facilitator is here with us in the name of Professor Sam. So without much waste of your time, because we have been waiting for more than 30 minutes, I think Prof has already settled down. As I've told you, that it's network issues that they have been battling with. I know that they have overcome it now. So, Prof, sir, I think we can start, sir. Sir, you can unmute. You can unmute, sir. Prof, sir, you can unmute, sir.
Okay, Yusuf, just a minute. I'm trying to share the slide.
Hello, sir.
Can you hear me? Just a minute. I'm trying to share the slide, Yusuf.
Yes, I can hear you. Okay, Mr. Dayo.
Just a minute. I'm trying to share the slide. Just a minute.
Okay, thank you.
So.
Yes, we can see the slides.
Yes, can you hear me?
Yes, sir, we can hear you, sir.
Yes, so please just give us a minute. We had some very serious challenges this morning.
Okay, sir.
Virtually all that we have in our system was wiped off.
Sorry, sir.
And so everything we had crashed all of a sudden. So it's not been very palatable. So we are trying to overcome the system, and we are almost there. I want to apologize to everyone who has been here. Sometimes when God wants to do something marvelous, sometimes these type of things happen. That is always my belief. So I believe that at the end, we will have a very fantastic outing that everybody will gain something from. And so let's not be discouraged by this initial setback. And quite frankly, what we plan to do today and in this series is to give you a totally different insight about movement science that you may never know, have come across before. But this will help the practitioners, the clinicians, to have the insight into the value of what we have, but which we have not been using. Normally, the tendency is for us to always see movement science from the perspective of, and especially analysis part of it is from the perspective of, okay, that's fine, we can record it and we can, handle it this way or that way, as if to say that is the beginning and the end. Sometimes we look at it from the perspective of, once we can analyze the movement, we will now know. I hope you can all hear me. Yusuf, can you please help me move?
Sharif.
Yes, sir.
Yusuf, please. Yusuf, put yourself. Who is making this noise?
Gabaki ɗaya waɗannan abubuwan a sake goge su. Kin gani? Waɗannan ni waɗannan abubuwan da ke kin gani. Ba ki samu mu ba.
All right. So normally what we are used to is we are used to framing movement science around interpreting movement and understanding what it says, and then using that to make clinical decisions and judgments. But it is limited. Our knowledge of it is limited, and that poses a lot of challenge. And so, it becomes quite very important that we understand the basics of movement science. It is not really common to see what we want to present today and what we want to share with you. And we will share it in two different segments. In the first segment, I will bring you to speed with the physiological basis of what we do in movement science. And then thereafter, I will also come back. You're not going to have some kind of hands-on session. And after that, I'll come back again to speak more, now beyond physiological, tying it to kinesiological and biomechanical imperatives, so that you also begin to understand the nature of the movement apparatus itself. If you don't understand the nature of the movement apparatus, if you don't understand its physiological nature, its properties and components, you can never ascribe to it what it will do and what it cannot do under different dimensions and the experiences. And so this is one of the key parts of our presentation today, that we hope we bring some innovation and insight and make this workshop meaningful, so that in the subsequent week, when you now begin to have a hands-on, you will understand the whys in what you are going to be seeing in the actual analysis itself. And so if you lack this basic insight, you will miss the mark. Normally, one of the things that people do disregard is that in practice, you cannot study the body system and mechanisms without understanding the physiology of it. Health and diseases are properly defined in the context of physiology. And most people think that health and disease are defined in the context of pathology. Yes, pathology is fine, but it derives from physiology. So this is some aspect that is being neglected, and globally, right now, you cannot practice medicine, you cannot practice biomedical sciences in Europe, even in South Africa, and in other countries are relatively more advanced without being grounded in physiology. And so even in the clinic, it is the physiology that takes precedence and gives you the anchors you need in making clinical decisions, because you go from the function, not just how the body is constituted and structured, but how it functions, because that is what physiology does. How does it function? And if you understand that function, then you can delineate other components of health as regards to its expression in either in disease condition or in normal condition. And so today, we are kicking off this workshop on movement science, understanding the human movement system as is the foundation of movement analysis and rehabilitation. That is the key message that you need to understand. And then we're now going to provide insights. And then you see how we apply that insight properly in the clinics. So good morning, colleagues, and thank you for really investing your time in this workshop. So today, I want to challenge something many of us have unconsciously accepted throughout our professional lives. Well, most clinicians, we are trained to look at movement from the outside. We observe gait, we observe posture, we observe balance, we observe functional tasks in different dimensions of activities of daily living. And then we try to explain what we see. Based on what we have observed, we try to explain what we see. Today, I want us really to reverse the process. That process must be reversed. So instead of beginning with movement, I will just jump you into movement. So you observe movement, you deal with it, you explain it, you document it, you look at gait, you look at posture, you look at balance, and then functional task and so on. I want to reverse that process. So instead of beginning with movement, I want us to begin with physiology. That is the foundation, because movement is not the starting point at all. It is not the starting point. And if you start from movement, you lose the mark. Movement is the end product of the process. Movement is the visible expression of everything that is happening inside the human body. So movement is the visible expression of everything happening within your body and within the patient's body. So throughout this session, I would like you to repeatedly ask yourself one question, and that question is very important and pertinent. And that is, what physiology am I seeing? Stop seeing the movement as the origin of what you are dealing with. See movement as an emergent property of the physiological makeup, of the physiological configuration of the movement apparatus, of the whole healthy system. Okay? So if it is an emergent property of health as expressed in each individual. So I don't want you anymore to see movement as what you normally see it to be. I don't want you to see movement as the starting point of your investigation about health of a patient who has dysfunction related to activities of daily living and being able to remain ambulant. I want you to see movement as the end product. It is an expression of everything that is happening in the human body. And it is communicated. The body communicates everything that is happening within it. It communicates it through the language of movement. So you need to understand the language of movement. What is it saying? What is it communicating? If you understand what movement is communicating about the health of an individual, you will see that movement is the most powerful tool, because the moment you stop moving, is the moment you begin to die. That is how the human body is configured. And so if we do not understand that health is tied to movement, then we will not even understand the essence of ambulatory health. So we see movement as an emergent property, as an end product, not as the starting point of a phenomena that we wish to investigate. If movement is the end property, it means we have to track back now to the components that give rise to it. What components of health give rise to it? So it means also that when we speak, therefore, to movement, we are speaking to those components that give rise to it. And so we must go back to those components and understand them. Otherwise, we'll be building something on nothing. And therefore, there may be a faulty foundation. Remember, I told you I'm going to challenge some of the things you already know. And we're going to challenge that with facts. And you're going to see the insights. And that is why it becomes important and peculiar that in our various practices and in our various hospitals, a movement section and unit, a movement science unit must be integrated as a very vital component that drives everything we do. Because remember, physiotherapy deals essentially with restoration of movement function. That is what the ICF model does. The ICF models helps us to describe movement and describe it in certain domains, in the participating domain, in social participation domain, cognitive domain, that is essentially looking at a functional domain, and so on and so forth. So because it describes, it does not really explain why the movement is that way. And therefore, the ICF model is not the consummate model that physiotherapists should rely in diagnosis or in providing insight. It does give us a heroic responsibility and does give us an insight into understanding how to describe movement in those 5 key domains, but does not tell more story beyond that. Therefore, you can't rely on it in making a diagnosis. You can't rely on it in getting an insight or clinical reasoning that is complete. You now have to track back to the physiological basis and then other frameworks that emerge from thereof, and then combine that with ICF in order to gain the insight and the knowledge that you need for clinical reasoning and is applicable in the context of a pathological condition you are dealing with. And that will make your result more effective, more impactful, and then more, contextualized. So the point
Yes,
we are trying to make.
yes. Anytime you have to set off and I'm watching it.
Please, can somebody just mute yourselves for crying out loud? Please. MRTB, can you mute everybody? Yusuf, can you hear me? Yusuf, are you here?
I've done that. You can continue, sir. I've done that, sir.
Please.
Thank you, sir. Sorry about that.
So, like I said before, more clinicians are trained to look at movement from outside. And so what they observe is gait, what they observe is posture, what they observe is balance and functional task. So what we want you to do in all of these things is that we want you to understand that what you should be observing is not movement, because you're not observing gait, you're not observing, posture, you're not observing balance, you're not observing function. We want you to retrain it, to retract now. We want you to, instead of beginning with movement, we want you to begin with physiology. Okay? So we want you to now have this idea that movement is the visible expression of everything that is inside your body or inside the patient's body. So if in this session you can just rearrange your psyche, I want you to be asking one question. Instead of what gait are you seeing? What posture are you seeing? Or what balance, function are you seeing? I want you to begin to ask this question. What physiology are you seeing? I want you to ask the question, what physiology am I seeing? Not what movement am I seeing, but what physiology am I seeing? Because if we leave this room thinking differently about that question, then this workshop has succeeded. And that is the most important point, and that's the challenge I want to put forth from the beginning. Let us begin with something very simple. And that thing that is very simple is this. I want you to just, ask yourself that question. Take a moment and think about it. How many movements have you performed since you woke up this morning? That is very important and key. Just reflect on it. Take a moment and think about it. Of course, you sat up from the bed. Then from the bed, you stood up. Then you walked. You brushed your teeth. You dressed up. You climbed the stairs. You entered a vehicle. You carried a bag. You greeted someone and tried to check up on them. You sat down again. Hundreds of movements has happened. Now, here is the more interesting question I want to ask you. And that question is this: how many of those movements did you consciously think about when you were executing them? How many of them? If you really reflect on it, you will see that probably you didn't think about any. None. So movement is one of those most remarkable things that human beings do. And they do that effortlessly. They do that unconsciously. Not because it is difficult to execute those movements. That is not what makes it remarkable. But because it is effortless in the way we execute them. And therefore, it is most importantly not thought about. We did not think about them because they don't matter. We didn't think about them because they do not have value. We thought about them because we are able and have trained our system to do them effortlessly. And we do it effortlessly until we are not able to do so anymore. So most people do not appreciate movement until movement becomes painful, until movement becomes difficult, until movement becomes exhausting. Mind my words, I chose them carefully. Until movement becomes painful, until they become difficult, until they become exhausting, until they become slow, until they become impossible. This is why movement is such a powerful clinical indicator. You see, until they become painful, until they become exhausting, until they become difficult, until they become slow, until they become impossible. You see, it is only when these scenarios play out that we begin to appreciate that movement, after all, is a remarkable event. It's a remarkable experience. This is why movement is such a powerful clinician and the clinical indicator of health itself. Movement often falls and it always tells us that something is wrong before laboratory values will tell us that. Okay, before the laboratory values will change dramatically, movement will tell us. And you see, before imaging and imaging findings become obvious about a pathology, movement already has told us that something is wrong. Before disability is even severe, movement has told us that there is something coming. So movement becomes an early warning system in itself. That is why movement analysis matters a lot. Because if we are able to analyze movement, we can pick up those early warning systems that defines health parameters, that define the health boundaries, that gives us insight what to expect in future before we fall victims of them. But do we have the tools? Do we have the capacity and the expertise to understand the language of movement? Yes, we do. But some of us lack it. And that is why this workshop is important. Because if you have that capacity now, then we begin to play in that turf we now begin to understand what language movement is communicating. And therefore, we become very vital in the preventive health sector, as much as we are very much vital in the rehabilitative, curative, and in the treatment sectors. Now, what is important is I want to ask you, all participants, when was the last time you became aware of your own movement? I want to know. Can somebody tell me, when was the last time you became aware of your own movement and of your own capacity? I'm driving at something. Can somebody answer? Because this is going to be a two-way thing. I need your involvement and support so that everything becomes very clear at the end. Can somebody just tell me, when was the last time you became aware of your own movement? Or when was the last time anything made you to be aware of your own movement? Can somebody tell me? When were you aware?
Hello, sir. Can I speak?
Yes. Please go ahead.
Hello, sir.
Yes, go ahead, please. Go ahead. Go ahead and speak. Can you hear me?
Hello, sir.
Yes, I said you can go ahead and speak. Can you hear me?
Please, am I audible?
Yes, you are audible. We can hear you. I don't know. Can somebody tell him to speak? Anybody who can speak better than me? I don't know. I hope
Suleiman, you can speak. We can hear you.
Okay. Yes.
Suleiman, you can speak.
I think I can remember just almost a month ago when I had knee pain.
Oh, when you had knee pain. That's interesting. So when you had knee pain was when you became aware of your own movement. That is fantastic. Can somebody else give us an insight? And I like that insight. Please take note of what he said. Can somebody also give us an insight? When last you were aware of your own movement?
Hello, sir. Can I speak?
Yes. Go ahead. Speak, please.
Okay. So, Sami, actually, sometimes if I wake up in the morning before I start doing anything, immediately I wake up. That's when I used to become aware of my bodily movement. I don't know if it makes sense.
That's fine. It makes sense because after a period you were lying still in bed, no movement, no movement in quote, no upright stance movement. So the moment you woke up, you became aware. And when once you wake up and start engaging in activities of living, you become aware of your movement. And that is important. Yes. Can somebody else, one more person who have observed his movement the last time you were aware?
Yes, sir.
Yes.
So it happens to me when I wake up midnight, like I'm very pressed and I wake up immediately. I jump from the bed trying to go and urinate. Sometimes my legs cannot even carry me. So it takes me some time after I wake up before I can move. So that makes me to get aware of my movements.
This is a fantastic one. You see that something has really made her to become aware of movement. And that became, that thing that created that awareness was a discomfort. The urge to urinate, a natural urge to urinate, a natural need that creates discomfort, of which if that never happened, you would never have experienced it. So this is what I was actually expecting from. I know that most people will say that they became conscious of their movement after an injury, like our brother has mentioned, when he had knee pain, or during an illness, or during a surgery, or when he experiences pain, or when he experiences a discomfort, or when you just woke up from bed after being still for too long, and then, oh, for goodness sake, you then begin to appreciate that you are beginning to move. So exactly. So we notice movement when physiology is no longer supporting movement efficiency. We notice it more. So when our body physiology is no longer supporting movement efficiency, when our body physiology is no longer supporting comfort, we begin to notice movement. And this is what you have seen in all the observations people have made. You know, that observation itself is the foundation of everything that we will discuss today. And that is just the simple truth. Because it is only when our physiology is no longer supporting movement efficiently, when we are no longer comfortable, when there is a change in the internal calibrations of the system, that is when we begin to observe movement. Does it tell you something? It tells you, therefore, that movement is an emergent property. Movement is the outcome of a physiological change within. And therefore, you become more aware when there is a change in the physiology. And if there is no change in the physiology from the comfort one that you're used to a discomfort, you won't become aware. So it means that that change in the physiology, which was expressed in movement, tells a story about the changes that warranted that movement. And so that pattern of movement or that situation and scenario is explained and predicated on an experience. And that experience is an experience that brings discomfort, that brings a change in the physiology. And that is not very palatable. So movement system, I want you to see it as an orchestra, as a musical band, not a solo performance where somebody is doing whatever doing his thing and all of that. It's a mix. In a band, in a musical band, you have the lead guitar, you have the bass, you have the drums, you have the lead singer, you have the alto singer, you have the blends of instruments. So many clinicians still think of movement primarily in a different way. And that is what we want to challenge, so that you understand it primarily. Many clinicians think of movement as musculoskeletal phenomena only. Muscles contract, bones move, joints rotate. That is the end of the story. And movement is done. So they see movement as a musculoskeletal phenomena. And it is predicated on the fact that, oh, yes, there's musculoskeletal phenomena, muscles will contract, bones will move, joints will rotate. And once that happens, end of story, movement has happened. But movement is far more complex than that. It is not exactly the situation. Let us imagine an orchestra. Let us imagine a musical band. An orchestra does not produce beautiful music. A musical band does not produce beautiful music because one violinist or one lead guitarist is talented, or because the drummer is talented, or because the singer only is talented, whereas the other musicians are, the other players, the lead guitar, the bass guitarist, and they are all doing something awful. It doesn't become beautiful because the soloist is doing a fantastic job. Rather, an orchestra doing something produces beautiful music because every section of the band, they work together. The strings, the percussion, the brass, the conductor, the timing, the coordination, everything comes together to create a perfect harmony that stirs the soul, that makes for good and sweet listening and lifts the spirit and stirs the heart. Movement works exactly the same way. The nervous system normally plans that movement, but the sensory system informs us about the movement. The cardiovascular system provides support for the movement. The respiratory system now provides the fuel that you need, the energy that you need to do the movement itself. And the musculoskeletal system also plays their own part. What am I saying in effect? You will see that movement is a combination of all systems coming together, which you may not appreciate. Now, otherwise, if you do appreciate them, you will start thinking of movement, not from the musculoskeletal point of view, where muscles contract, and the bones begin to move, and then joints begin to rotate, and movement is completed. In fact, the musculoskeletal system, the respiratory system fuels that movement. The musculoskeletal system executes the movement quite all right. But you have seen other inputs that come before the execution. But the endocrine system influences adaptation and recovery when you now begin to execute that movement, so that if you, for instance, get pushed, or if you slip your foot on something slippery, the endocrine system comes in. Of course, we all know about the flight and fright, the release of adrenaline, and what it does. So it helps to modify and creates adaptation for recovery. And then the cognitive system directs your attention and confidence and your behavior. So movement is therefore not the product by one system, the musculoskeletal system. And that is why when patients who have movement dysfunction come to your clinic, what do you assess? You only assess the musculoskeletal system. And your first question is, where is the pain? What can you not do that you used to do before? That is the end of story. And as you're asking that question, you are fixated on the musculoskeletal system. And that is why we make a lot of mistakes. Because you are looking at something that executes, but not what informs. The musculoskeletal system executes, but does it inform what it executes? No. There are other things that inform that execution, what is being executed, and you lose sight of them. Then how can you provide an effective intervention? This is why some of our interventions are blind spot. We come from a position of blind spots. We are blind spotted in a sense in making our judgments and our clinical reasoning. We don't have sufficient input, because clinical reasoning is the quality of clinical reasoning is as good as the input that goes into it. So if we do not make sufficient input into the clinical reasoning process, the outcome in terms of diagnosis, in terms of rehabilitation planning and goals, and of course in projection and planning, we also fall short. So movement is therefore not the product by one system. That is just what it means. Movement emerges from system integration. So if you don't understand system integration, you have no business in movement analysis. You must integrate all the systems. And so if a patient comes into your clinic and you just assess the musculoskeletal system, you have not assessed the cognitive system, you've not assessed the endocrine system, you've not assessed, what do you call it? You have not assessed the cardiovascular system, you've not assessed the respiratory system, you've not assessed the supportive psychological system. At the end of the day, the sensory information system, nervous system itself, if not assess all of these things and integrate them, your final diagnosis will be limited. So you would have made a diagnosis that is based only on one system. And the system you are looking at is even the system that executes, not the system that informs. And so the movement emerges from a system integration. And once you understand that a movement emerges from a system integration, you now begin to see not movement when a patient comes. You see the physiology. You see the physiology behind it. And this is why patients with entirely different diseases may demonstrate similar movement patterns, but they have different diseases, yet they demonstrate similar movement pattern. A patient with chronic obstructive pulmonary disease, or a patient with stroke, a patient with knee osteoarthritis, a patient with cancer-related fatigue, all may move slowly. All of them will move slowly. But they will move slowly for completely different physiological reasons. The movement may look similar, but the physiology is different. That is the art of movement analysis. The movement analysis does not start from the movement itself. The movement analysis now starts from the physiology. Because if you start from the movement, you will now produce one shoe that fits all, one shoe size that fits all. You will be wrong. No one shoe size will fit all. They all move slowly. So let us give intervention that we address this slow movement. But the physiology that warranted the slow movement, are they the same? No. So you should be seeing the physiology, not the movement. Whenever you are in the clinic looking at issues, let me give you a Nigerian clinical example that may buttress this point. Consider two individuals walking slowly in a hospital corridor in your own hospital or in your own practice. One has severe knee osteoarthritis, while the other one has heart failure. To an inexperienced observer, an inexperienced movement scientist, you will see that they look similar. One has knee osteoarthritis, the other one has cardiac failure. If you look at their movement, they will look similar. But the first patient is limited primarily by joint loading and pain. That is what limits him. Joint loading and pain. And that's what makes him walk slowly. Whereas the second patient is actually limited primarily by oxygen delivery and cardiovascular reserve. It is the cardiovascular reserve that has been diminished, and the oxygen delivery, which is required to provide energy for muscle activity, that are challenged in the second person. But if you look at the emergent movement property, you will see that the product of that physiological change is slow movement. And all of these people are referred to you for rehabilitation, for physiotherapy rehabilitation. And a movement scientist will look at it. If you look at it from the point of view of the movement you are seeing, and then you write your analysis, and they are all slow, they move slowly, they slowly walked into the clinic, and that is the end, then you haven't understood the language of movement. It is telling a story that is informed by diverse physiological background. So begin to see physiology. Do not see movement as the beginning. See it as the end product. Therefore, look at the beginning. The beginning is the change in physiology, the primary physiological changes that warranted that movement, which is the end product. And that is the way to go about it. What are we really observing? That is a question we must be asking ourselves when we watch movement. What are we really observing? Why I ask that question, it's very germane. If I ask my students or any of you, what do you see when a patient walks? What do you see whenever a patient walks? I want you to tell me in sincerity in your clinic what you see before now. Can somebody open up and tell me? I want 3 or 4 answers so that we can just learn from it. What do we really see when a patient walks that you have recorded in your folder before? Can we share?
The gait, the posture.
Yes, the gait and the posture. We see the gait, we see the posture. Can somebody else tell me what he has seen?
Balance also. Balance.
Yes, we see balance. We see balance. And these answers you have given are not wrong at all. They are not wrong, but they are incomplete. That is where the issue is. And that is why we are having this conversation. When you watch someone move, you are actually watching a physiological event. You are watching the brain generating motor commands, because it is the brain that generates motor command from the primary motor cortex. And then you watch the spinal cord transmitting information. because the spinal cord will transmit information from the sensory to the brain and from the brain down to the muscles. So the sensory comes from the muscle receptors through the spinal cord, they move to the brain. The brain generates the command and transmit the same again through the spinal cord to the effector organs, which are also musculoskeletal organs. So you see, the spinal cord transmits information. The peripheral nerves themselves will activate the muscles that will execute the command. And the muscles themselves will generate the force that will pull the bones and pull the joints. But in doing so, the muscles themselves are not attached to the joint directly. They do so through to the bones. They do so through the tendons. And so the tendons will transmit that force to the bones. And then when the bones move, the joints of the bones will absorb the load. They absorb the weight of the body. So whenever you hear the word load, we're talking about the weight of the body or body parts. Okay? So the heart itself will begin to deliver oxygen to the muscles to enable them to combust and break down the phosphorylation processes and then release in the metabolic processes ATP. So they will deliver oxygen. And then the lungs will support that metabolism itself by breathing, increasing the volume of intake of air in order to sustain the muscular activity. And then the sensory systems begin to provide consistent feedback to the system. Either a feedback of we need more oxygen, or we need more energy, or we need more of this. And the sensory system looks at the internal environment and the external environment. They look at the movement task and they also look at the internal environment, the challenges that the feedback they are getting from different organs, and they feed the same to the brain to either continue to increase the command for the muscles to work harder, or to slow down because maybe the internal environment, the organs are not responding adequately. So the movement that is executed is therefore predicated by physiological origin, physiological variations. This is perhaps the most important sentence in this entire workshop. And the most important sentence is this: all of these things occur simultaneously because movement is biology made visible. Movement is biology made visible. This is the most important sentence in the entire workshop I want you to take home. Movement is biology made visible. What we have just described across all the systems that interact and are interwoven and interlinked is just the human biology of movement. So movement is biology made visible. And movement in itself simply speaks to the pattern in which you translate yourself from one point to the other. So every movement pattern tells a physiological story. Every movement pattern tells a physiological story. So it is the biology made visible that you can see. So those internal milieu, those changes, those interactions, they produce movement. So actually what you are watching in movement is actually the biology. You're actually watching the biology. You're actually watching the physiology, the emerging physiology, the implications of the emerging physiology. That's what you watch. So the point is this: if every pattern tells a physiological story, the challenge is now learning how to read that story. That's why we are here. How to read the story that the physiological system is telling through every movement pattern. So every movement pattern is a physiological story that is told by the biological system, because movement is biology made visible. So the key question, the key challenge is learning how to read that story. There was a time you never knew how to read English. And then you were taught, and over the years you became able to read and communicate. This is the same thing in movement science. If you do not know how to read the story that the body is telling, you will never get the information you need to solve the problem that story has actually captured. That is the challenge of physiotherapists. And that is why, if you understand it and you understand the broad definition that physiotherapy is a branch of health profession focused on movement restoration and functional restoration, where there is a disruption or where there is a change that led to it, then the question will be, how do you now make intervention if you don't understand what the story different movement patterns are telling? The implication of this is that movement analysis is at the heart of physiotherapy practice. We are very quick to make interventions that are related to movement. But sometimes we are oblivious of the fact that we need to first of all understand the story. And we do try to understand it from one system alone, the musculoskeletal system. But we do not understand it from the human biology, which now is more holistic, from the physiology, which is more holistic, which entails an interaction of the entire system, these entire systems that support that movement. And that is the narrative that this workshop will open your eyes to. So let us reflect on something. I want you to answer me and share your opinion. When a patient limps, what physiology might you be seeing? If we now begin to think in the dimension I'm bringing you into, I want you to reflect and answer. When a patient is limping, can you tell me what physiology you might be seeing? Can somebody give me an answer? You just saw a patient walk into your clinic limping. And remember, I have told you now to begin to see physiology. Okay? Now, can you tell me what physiology you think you might be seeing?
You know you are going to press.
Can somebody?
At least minimum.
Can you mute the people talking so that we can get the MLTB, can you please mute other people? Now, can somebody please answer? Just feel free. It's a learning environment. We are not experts. We are here to learn. But it has to be two-way. If anybody walks into your clinic limping, can you just tell me what physiology you might be seeing?
Sir?
Yes?
Sir? I
Go
may
ahead.
think there is... Okay, can you hear me?
I can hear you.
I may think there is decrease in blood supply to the particular joint. That cause the accumulation of waste product, which can lead to pain for the person to live.
Exactly. That is fantastic. Thank you so much for that input. Can somebody else also tell me what physiology are you seeing?
Sir,
Yes?
I may think of the feedback from the sensory system, feedback mechanism from the sensory system. When the person moves, maybe through the movement pattern.
Exactly. That is also very insightful. I love one thing that you people are doing now. Are you seeing you are beginning to think of physiology and not the movement? You now begin to think of, okay, this could be from the blood circulation, and because the blood circulation is impaired, there's accumulation of irritant metabolites, and these may accumulate to a threshold that they induce pain. So the pain I'm seeing now is actually the body telling me a story that there is something wrong in the cardiovascular system or in the vasculature, there is accumulation of metabolites that are irritating in nature that could, lead to what I'm seeing now. And another person is also looking at it from the perspective that, okay, there is a possibility that we are dealing with, some kind of challenges related to what do you call it? To sensory integration. And because there is poor sensory integration or maladaptation in the system, we are dealing with something like this, and the implications will result in this limp. Are you seeing the beauty of not starting from the movement? You are starting from the physiology. Because each movement pattern tells a story. The same movement pattern, but are you seeing two stories now behind it? So which one is correct? It means until you are able to identify which one is correct, you can't give the best intervention. Can somebody also give me one more perspective to it, to this scenario? What physiology also do you think you are seeing? And I hope as I'm saying this, you are beginning to realize something. Can somebody also give me an idea? What perspective you think you may have? What you think you may be seeing when a patient walks in, to your clinic with a limp? What physiology might you be seeing? We have had two of them. Can somebody give me another one?
Sir, it can also be due to cognition problem. Maybe the patient adopted some movement.
Good. So it could also be a cognition problem. That is to say, it could be neurally driven, could be in processing and executive function. So now, you see, when you are now looking at your patient, you are not looking at the movement as the starting point. You are looking at movement as the end product of a physiological process. Now, which one is which? You see? So you no longer come, when the person now comes into your clinic, before you will simply measure the muscle strength, measure the, if possible, you can measure the bone mineral density, because these are the musculoskeletal issues. And maybe you can even measure the sensory integrity of the muscles. Everything is revolved around the musculoskeletal system. And at the end, you now decide to either strengthen the muscles, fire the system, put fire there, put IR there, fire it, and Now, when you now come for assessment 2 weeks after, you will look at the movement and say, this person is still working somehow. Yes, you're not satisfied. The reason is that you are treating the symptom. You have not treated the problem. And of course, the problem may even involve multidisciplinary approach. So you play your own role, others will play theirs. But in your assessment, you need to understand which is which. And until you begin to see movement as an integration of system biology that tells a story, you will never get it right. And that is what the point we are bringing in this workshop. And if you integrate that into your reasoning process, you will now begin to see a change. Because, yes, you can say that when a patient walks with a limp into the clinic, it could be from pain, it could be from muscle weakness, it could be from fatigue, it could be from motor control issues, it could be from even fear of falling, which is cognitive in nature. It could be from reduced balance, which could be from the vestibular apparatus. The limp itself is not the diagnosis. That is the point of everything you have said. The limp itself is not a diagnosis. The limp is the clue. It's what gives you a clue to what is wrong. So it tells the story. It is not the cause. It is the outcome. So you don't begin with it. It is the end product. You begin from the system that produced it. You unravel it before you can solve it. And when you solve it, the emergent end product will now change. And that is the point we are trying to make. I want to give you a simple example. And one of those simple examples is what we do every day and what your patients also do in your clinic. Standing from a chair. Just to portray the point we are making. Let's take a moment to look at the movement that seems completely ordinary. They seem ordinary to us because we do it every day, and our patients also do it every day. Standing from a chair. And most people will always think, I simply stood up from that chair and I walked out on him. I simply stood up on that chair and I went to have my lunch. I simply stood up from the bed and I went to ease myself. I simply, you will hear that sort of language. But what actually happened when you stood up from a chair, stood up from a bed? Did you simply actually stood up and walked away? So before movement even began, that thing you see as you simply stood up and walked to this, you stood up, and before it even began, the brain had decided to move. And when it decides to move, it doesn't just decide and movement will happen. When it decides to move, it will switch to the next level, just like a builder. When you decide to build a house, you don't just, okay, I want to build a house. Straight away, you bring cement, you bring sand, you mix it, you pour it, and then you start building. And then halfway, you will remember, am I even supposed to build a bungalow? Or am I even supposed to build a duplex? You already halfway done with the materials are already finished before you remembered, what am I supposed to be building? Is it a bungalow or a castle? I don't know anybody who has done that before. But if anybody has done that, that person will win an award. But that is what we do every day in our clinics. Because it's once the patient comes and complains of pain, he has pain. No. Oh yeah, give him TENS, fire. You begin to, However, you forgot that before whatever led to those pains happened, certain physiological centers played a role. The brain normally decides to move. When the brain decides to move, either to crawl, or to sit, or to stand, or to run, once he makes that decision, the next thing that happens is that motor planning begins. Just like when you decide to build, the next thing that you do is to plan how to build it. And then you bring the architect who will help you to draw the plan, the building plan. So also it is with the human body. When you decide to move, motor planning starts. When you decide to start up from that chair, the brain decides to move from that chair. Your brain has taken that decision. For whatever reason, the next thing that happens is that motor planning starts. And when motor planning starts, it starts in the brain, especially in the area we call the primary motor cortex. And then it signals. It generates signals, command signals that we now travel through the nervous system. Now, if those signals travel through the nervous system, and at some point they are no longer able to, they are impeded, they are slowed down. Not all of them come with the same full current of flow. So also shall be the final movement. So you see, it travels through the nervous system, and its integrity, assuming it has full integrity, that entire signal will go through it, retaining the original command. And then the trunk is activated to provide stability. And then the hips themselves will generate the extension torque you need, because when you are sitting on a chair, the hip is flexed. But you need to stand. It means you need to have an extension torque. The turning effect of the muscles around the hip joint, effect of the force around the hip joint, has to be in the favor of the extension torque. And then the knees themselves will generate also an extension torque in order to give you the stance you are desiring. And then the ankle have to adjust itself to provide balance and a firm grip on the surface on which you will stand. The vestibular system, from the ear through the cochlea, the otolith system, they will also provide you the necessary balancing that you need in order to prevent you from falling. So they give you orientation and they help you to identify where you stand, where your head is located in space. And then you see also that the vision monitors the environment to tell you whether the environment is changing, is becoming slippery, is becoming rugged, it tells you about the environment in which you want to stand from the seat. And that gives you information you need to either modify or to strengthen the program that executes the movement. And then you have also the heart itself. It increases the circulatory support because it needs to pump more blood to take more oxygen to the muscles. And therefore, it increases the circulatory support. The lungs will support this oxygen delivery by increasing the respiratory rate. Now, ATP, which is energy, will be unlocked. It will be unlocked from the muscle phosphorylation of the fuel and then released. And it is consumed. The ATP that is released is consumed by the muscles, all within a few seconds. Now imagine that one component of the system I have just described becomes impaired. Perhaps the patient has stroke. Perhaps the patient has knee pain. Perhaps the patient has Parkinson's disease. Perhaps the patient has heart failure. Perhaps he has diabetic neuropathy. Perhaps he has cancer-related fatigue. The movement immediately changes. Not because standing from a chair has changed, though. It is the same standing from a chair. But because one of these components have changed. It could be that the delivery of oxygen has changed. It could be that the delivery of the respiratory rate has changed. It could be that the vestibular apparatus has changed. When there is a change in any of these components, you will now see that the emerging property, the movement pattern, is altered. So the patient may have any of these conditions I have listed, but they will have the same movement pattern. And even in these same patients, the immediate changes that have occurred in specific component systems may not be the same. So the movement, immediately changes because of a change in any of these components. Not because standing from a chair has changed, no, but because the components that is required to enable you stand from a chair has changed. So because the physiology has changed, that is why you begin to see a change also in movement. This is why movement analysis is so powerful, because movement analysis tells you a language that the body biology has spoken in a given movement pattern. It allows us, therefore, to observe the consequences of the physiological dysfunction before we fully understand the pathology itself. So before any pathology that we can see and verify in the laboratory, either in the laboratory sciences using blood work or using diagnostic imaging, The movement pattern has already released the vital information. It normally comes ahead of all of them. And that places physiotherapy ahead of every other one. What we have not done, we have not developed that science so that we can utilize movement to predict diverse diseases. I mean it, diverse diseases. Movement can predict all of them because the body physiology tells the stories in each and every one of them. But this is a tool we have so much neglected. We want to rely on body work, on blood work, and rely also on imaging before we can make predictive diagnosis. No, we have what it takes to do it, but we need to understand the language the body is speaking. And if we understand, then we unlock a whole new world of innovation. This is why this workshop is important. And that is why the registrar places emphasis on all physiotherapy departments having a movement laboratory. This is who we are. We need to strengthen that and build on that, and then put a very fantastic, quality to our profession, a fantastic distinction that over time, other professionals will rely on our input to make their own diagnosis and to guide their prognosis and projections for recovery, especially not just for the system, not just for the emerging properties. You can now use movement to tell when something is wrong in the brain. You can even tell which part of the brain. You can now use movement to make a prediction of what is happening in the vasculature. You can now use movements to make a prediction of what is happening in the cardiovascular or cardiopulmonary system. That is the implication of what we are saying. So movement itself should be analyzed from the context of the biological changes. It is simply the visible biology. Movement is biology made visible. And that is the point we are driving. So what is the clinical challenge? If a patient struggles to stand from a chair, what is the problem? I want to hear your contribution. If you observe a patient that struggles to stand from a chair, which we now have seen the components that goes into it, before now, what do you normally think is the problem before we had this discussion? Can somebody give me an insight? As they were coming to your clinic in the past and you were assessing them and you found out that they struggle to stand, what usually came to your mind in the past when you assessed them? Can somebody share with me?
Muscle weakness, sir.
Exactly. We always look at muscle weakness. Which muscles do we normally look at?
The lower limb muscles, most of the times.
Yeah, the lower limb muscles. We look at the quadriceps. We want to know whether the quadriceps are in good shape. Want to know what the hamstrings is doing. You see? Because when you talk about the extensor torque, which you need to stand, you are looking at, of course, the hamstrings and also the gluteus. Perhaps this could be true. But it could also be that apart from muscle pain, there are other things. There could be pain inhibition. Because if you have muscle weakness, yes, but what causes that weakness could be pain inhibition, because pain can inhibit muscle activation. There could be poor balance, because if you lack balance and there is balance dysfunction, standing up becomes a challenge. There could be reduced aerobic reserve. If the cardiometabolic processes, the reserve you need, the physiological reserve, and we will come to that, which most of you may not know. If the reserve is depleted by other issues, then you have that challenge. It could be impaired motor planning, which means that the motor cortex is not able to plan because either the blood perfusion is not sufficient, or because maybe there is a reduction in the flow of blood in the brain, which enables it to plan effectively. And this can happen as mean there is transient ischemic attack, or as mean there a reduction in the lumen of the tiny or the microvasculature of the brain. You can now begin to see that this may also impair the motor planning processes. Or if there is fear of falling, which has a psychosocial dimension, fear of falling, even mood disorders, or if there is a sensory deficit. These are all possibilities that could be linked to that singular act, difficulty in standing from sitting. So you see, movement analysis begins when we stop assuming and start investigating physiology. So when we start assuming that this is muscle weakness, this is muscle weakness, there is muscle weakness, because that is what we do every day in our clinic. The patient is not able to stand from say, the muscles are weak. Check the muscles. The quadriceps. Now, nobody thinks in the system dimension. There is no system review. There is no system integration. Clinical reasoning is fragmented. And therefore, how can we analyze motion? It's impossible. So movement analysis begins when we stop assuming that this is muscle weakness, when we stop assuming that this is muscle this or that, and we stop assuming. And when we start investigating physiology, I didn't say when we start investigating movement, when we start investigating physiology. That is something we don't do in physiotherapy. And that makes our practice limited. It makes our practice in some circumstances look like technicians, because we give the same reason for almost all conditions. He has stroke, unable to sit from standing, muscle weakness. He has heart failure, unable to sit from standing, muscle weakness. He has this one, unable to do, muscle weakness. He has this one, muscle weakness. So we always incriminate one thing. But even if muscle weakness is emergent pattern, we pay no attention to the physiology. We never investigate it. We never investigate them. We never say, okay, can we take a look at the cardiovascular system? We never say, can we take a look at the VO2 max? We never say, can we take a look at the MET, the calorie consumption? We never take a look at, so all these systems that are relevant, we never take a look. We never take a look at the cognitive system. We never take a look at the balance system. We never take a look at all the other dimensions. If you go to your analysis of mobility, analysis of gait in your hospital, if you open up the patient folder, you will shake your head. All you will see there is muscle strength. The best you can see is a complete muscle chart. That is the end. And on the basis of that, we make a provisional diagnosis and make our treatment planning. And of course, woefully, sometimes we fail. And that is why other medical practitioners sometimes don't see us as deep. Our clinical reasoning is so limited. And they don't see us as having a grasp. Because we must connect these dimensions, and we never do. And if we say we cannot make a diagnosis on this patient and cannot treat, because we need to know these dimensions. We need to know a platelet count. Let us even look at the platelet activity and know whether there is a tendency for coagulation somewhere. Let us look at it and make sure there is no deep vein thrombosis. What is the vasculature? What is the flow of blood? Let us look at the flow rate of blood. Can we do some echo to know what is happening in the cardiac chamber? If the heart is able to supply, what is the reserve rate of the cardiopulmonary system? Is it able to sustain? What is the fatigue rate? What can I see the lactate profile? you are doing movement analysis. You are starting from the origin, from the physiology. So when we do not speak like scientists, we appear like technicians. The only thing that the technicians are those who have gone through the university, whereas in the actual sense, technicians are found in the polytechnics. So when we do not have the complete harnessing of the potentials we have to practice, we reduce our practice to the practice of technicians. And this is coming at a point when we are having diverse discussions about diploma in our profession. So you will see that we still operate at the level of diplomats, diploma holders even. So without clinical reasoning, without understanding the components, without going to this basic physiology, without seeing what the problem is, we reduce the entire practice to what technicians will do. This is actually what makes us clinician scientists. This is what makes us physiotherapists. Remember, physiotherapy is riveted on movement. We are specialists in movement dysfunction and movement restoration, in addition to the impact we create across the systems. But even that one now, we seem to have neglected the profound basis of the emerging movement pattern as originating from these diverse systems. This is the essence of this workshop. And this is language we intend to speak. Now, if we are moving in this direction, it means we need to understand that movement reflects physiology. The next question becomes, why do people perform a task effortlessly while others struggle with that same task? And if you need to answer that question, you must understand the concept of movement reserve and physiological thresholds. This is something you may not know or may not have come across. But I want to open our eyes to it. I want us to understand it as movement scientists. So we need to understand this simple parameter, this simple insight that can change how we perceive things, how we do things, and possibly even our position, how important it is, and how profound our practice ought to be in this dimension. So let us look at movement reserve as the hidden protector of function. We are looking first of all at movement as an energy-dependent process, which is very key. But let us, in doing so, understand the basic physiologies that are important and reflected in them. Now, I want us to reflect on something. Now that we have actually established that movement is the visible expression of physiology, I would like us to consider another concept that may completely change how we think about function. And that concept is called movement reserve. Most people assume that because they can perform a task, they are functioning normally. That is not true. That your patient can perform a task does not mean that your patient is functioning normally. And that is what movement analysis makes you to know. But function is not simply about whether you can perform a task. That is not function. You can perform a task, but you're not functioning normally. The more important question is how much physiological capacity remains after performing the task. I don't know whether you have asked that question when you are examining your patient. Perform this task and the patient is able to perform a movement task. And then you ask yourself, how much physiological capacity remains after performing that task? That is what actually speaks to function. You may perform a task, but you're not functioning normally. That remaining capacity is what we call movement reserve. How much physiological capacity remains after performing a task? That remaining capacity is what we call movement reserve. Please register that in your mind. I want you to take time to jot it down, to register it in your brain, and because this will help your practice. How many of us have heard about movement reserve? So when you talk about task accomplishment and you equate it to function, that is wrong. It is not true. You may perform a task, but you are not functioning normally. What gives you insight on who functions normally is the insight you get from the physiological capacity that remains after performing that task. And you will understand what I'm saying shortly. Think about climbing a flight of stairs, or when you ask your patient to climb a flight of stairs. For a healthy young adult, climbing those stairs may require only for 30 to 40% of available capacity, your physiological capacity. I mean, climb a stair, somebody will just climb it, and at the end of climbing it, is still able to lift a whole box and do all sorts of things. And that person will climb the same stair, that is complete the same task, but is not able to do any other thing after. Have you observed that before? That speaks to functioning. So somebody may climb 3-story building. After climbing it, he will do press up, he will move, he carry one box, bring it down from that upstairs, and climb up again, and then bring it down again. Then you see that after climbing the step, he still has the capacity to do other things. But somebody will climb that stair and finish the task completely, but cannot do any other thing after. It is because of the movement reserve, the physiological reserve. That is what is important. The physiological capacity that remains after performing the task. That physiological capacity varies in movement task. That is what defines functioning. The moment that reserve begins to reduce, functioning becomes affected. Movement, remember I told you, is a language that speaks about the underlying physiological context, the physiological processes that warranted that movement, that supports that movement. It tells you a story. And one of the stories that movement tells us is physiological capacity to function. You can complete a task, but your physiological capacity to function is limited. Therefore, functioning and task completion, they are not the same thing. Pay attention to physiological capacity to function. That movement reserve is what tells you about that physiological capacity. So the remaining capacity is what we call movement reserve. So if you climb a flight of stairs and still can do a whole lot, you may actually, as a young man, climb the stair with only 30 to 40% of available capacity you have. Whereas it means that 70 to 60% of your capacity is still intact to do other things, to function. So individuals, the individual actually may reach the top and continue talking comfortably. An individual may climb 3-story building, but cannot continue talking comfortably. He will start panting. He will start talking with difficulty. Let me catch my breath. Let me catch my breath. Some of you see that a lot. What does it tell you? He completed the task, but the capacity, the reserve, the movement reserve has diminished. The functioning is challenged. So the individual will reach that top, but have challenges doing other things. Talking comfortably becomes challenge. So there is a plenty of reserve remaining when the individual is able to talk without challenges. Now, imagine an older person with a heart failure, or somebody with obesity, or somebody with osteoarthritis, or even with cancer-related fatigue. The same staircase may require 80 to 90% of their available capacity. So the task is the same. The movement reserve has diminished. The physiology is not the same. The task is the same, but the physiology is not the same. Because in the person who is able to climb the stair with 30 to 40% of his capacity and still have 70 to 30, 40 to 60% of the movement reserve of the physiological capacity, that one has a different mechanism, a different setup, a different status, a different functioning status from others. So if you ask somebody who has cancer, fatigue, somebody who has heart failure, or an older adult, or somebody who is obese to still climb the staircase, it is the same task. They will complete it, but they may require 80 to 90% of their available capacity to do so. So what has changed? It is the same task, the same upstairs. So what has changed? What changed is the physiology. The physiology is not the same, even though the task is the same. The movement reserve has diminished. This is why two people can perform the same movement, yet experience it in very different ways. Imagine two women carrying 10 kg bucket of water. One carries it comfortably. The other stops repeatedly to rest as they carry it. You see that in school. And we call them Ajibota. This one is Ajibota. This one, it's not Ajibota. It's not a matter of Ajibota. There's a physiological limitation. There's a serious problem, which that movement pattern is telling you. You will see it in your patients. And I want to draw your attention to it because these are fundamentals of movement analysis. The other one stops repeatedly to rest. The bucket weighs the same. The difference lies in the movement reserve. The movement difference lies in the physiological capacity. Movement reserve determines whether activities feel easy or where they feel challenging or where they feel overwhelming. This is something you must take from here. The important insight is that many patients do not become disabled because they lose movement. That is not what makes them feel disabled. When you don't move, you lose it. Because they were in bed for too long, they lose it. No, they become disabled because they lose reserve. The movement is still possible, but the reserve is not there. It simply becomes too physiologically expensive to move for them. The distinction is extremely important in rehabilitation. And so this is something you need to reflect on. And that is why it's important that when we deal with different dimensions of people, and when we deal with different dimensions of cases that have need for movement restoration, we must think and we must see the physiology of movement. We should not see the movement as the issue of concern, but the physiology, because it is the physiology that gives rise. When the physiology changes, movement will follow in the same direction of its change. So we need to understand the language, and that language is the language of the human biology, the language of physiology, the physiology of movement. I want to ask you again, have you ever met a patient who could technically perform a task but avoided it because it was too tiring, or because it was too painful or too difficult? I don't know if you have seen that. Have you seen a patient in your clinic who can perform something technically but avoided it because it was too tiring, or it was too painful, or it's too difficult? Or even if you have seen your colleagues who have that experience, has anybody seen that? Have you ever seen that before? Or a patient tell you, or a colleague tell you, I can do this, but I don't like doing it because it is tiring, it's too painful, it's too difficult. Have you ever had that before? Can I have some response? It's important to me. I'm driving at something. Please unmute and talk. If you can still hear me.
Yes.
Yes. Very good. When you see things like this, this is a reserve problem. This is a movement reserve problem. This speaks to physiological capacity, not necessarily a movement problem. It is not a movement problem, or it is a movement reserve problem. That is, it is a functioning issue. Their ability to function, their capacity to function, their physiological capacity to function is the problem. And therefore, you must draw distinctions between a movement problem and a movement reserve problem. Because most of the conditions we see are movement reserve problem and not a movement problem. But the intervention we give them is a movement problem intervention and not a movement reserve intervention. And because we are not taking time to understand movement analysis, where it starts from, we fail. We analyze the symptom, we treat the symptom, but we don't address the cause of that symptom. This is what movement analysis is meant to do, to take your idea and your mind to the origin of the problem so that you can address it. Now, you see, what I was trying to say about the movement reserve as the hidden protector of function. You can see in this slide what happens in different situations. If you look at step 1, you see that healthy young adults, they can do step climbing with 30 to 40% of the available capacity they have. They have large reserve remaining to do other things. But as we move down the ladder, as we age, or when we begin to experience mild deconditioning, physiological deconditioning, the same task requires 50 to 60% reserve. And it means that our reserve is shrinking. Our 50 to 60% of our movement reserve. And it is now shrinking. And by the time we come to level 3, those in level 3 are those who have disease or injury or obesity. The task requires 70 to 80%. And the person begins to slow down and to, use handrails in climbing. So when you ask them to climb, they begin to hold handrails and they begin to climb to complete that task. It is not born out of injury. Sometimes it's just born out of what you are dealing with is movement reserve issue. But you may experience it in people who have disease condition, who have injury, who have obesity. But it is not the injury or the obesity that is placing that it is the physiological environment which led to the pathology that have actually affected the movement reserve. And so you need to understand the distinction. And then level 4, you begin to see severe deconditioning or advanced disease. The task may require 90% or more. And so the person avoids activity and fears movement completely. So these are the various levels that you will see. You begin to see that movement reserve is critical. How many of us have done analysis of movement reserve when the patient comes to our clinic? And when we have mobility issues, to know whether they are level 1, level 2, level 3, level 4. Think about it. So what we're trying to know, to lead you into, is the physiological thresholds that can now help you to put the proper analysis indices in the right perspective in making those decisions, in calibrating the system to look at the physiological thresholds that has implication for movement reserve and which you can deploy in this context to make the insight that you need as a movement analyst. Now, the thresholds of importance is what I will be discussing here. I want you to take a look at, maybe just a minute. Okay. I want you to take a look at what you have on this slide. You will see from this slide that this slide may be the single most important concept of today's workshop, because it speaks to something which has always been there, but which most of us do not know and rarely apply. I know you'll be disappointed because today you have been expecting me to start and then calling some jargons and then bring, the ones you are used to. No. The basics are the most critical part. And this particular slide could be the most important thing you will hear today. And you will also learn from. So it may be the most important concept in the entire workshop that you will receive. Because most clinicians think that movement changes because muscles become weak. They also think that movement changes because joints become painful, because people become old, because disease develops. These explanations are true in themselves, but they do not tell the whole story. That is the point we want to change. And that is what every true movement scientist knows. Movement do not change because muscles are weak alone. They do not change because joints are painful or stiff alone. They do not change because people get old alone. They do not change because diseases have developed alone. That is just one part of the story. Movement often changes because the body has crossed a physiological threshold. And therefore, you need to examine each body, each person that comes to your clinic to know where their physiological threshold is. No movement scientist will ever succeed without documenting physiological threshold. I have exposed you to two important dimensions. I have exposed you to movement reserve. I'm now exposing you to physiological threshold. I've exposed you to movement as a visible biology. I've exposed you to the understanding that movement is just a language of the human physiology. I've exposed you to the practicality that movement tells the story of changes in the systems that support it. Therefore, movement in itself is an indicator and a predictor of changes that happen in an integrated system. Movement occurs from integrated systems that support its emergence. You need to understand these systems. You need to integrate them the way they should. And you need to also analyze them in order to understand the basis for a change in each context. I have exposed you to all of that. But now we're going a step further to understand the physiological thresholds. These are the most important idea of this workshop, the physiological thresholds, which when they are crossed, movement changes must happen. So a physiological threshold is the point at which physiological demands exceeds physiological capacity. Because I have told you that from the concept of movement reserve, it simply says that you can complete a task and still have the physiological capacity to continue. You have the movement reserve to continue. And therefore, completing a task is not equivalent of functioning. And so if you bring up a tool that looks at activity of daily living and tells me that these people are able to complete this task and therefore they are functioning well, as a movement scientist, I do not agree. And this is why we make mistakes in the clinic. Because once they come, oh, you can use Beck's index of daily living. Is he able to come? Is he able to climb the stairs? Is he able to, oh yeah, physical functioning is good. It's not true. Yes, he can complete those tasks, but full functioning is a different dimension. It is taxed. It is tied to movement reserve. And what can give you an insight into physical functioning is the application of physiological thresholds. It tells you whether the movement, when being executed, has crossed certain points. A physiological point at which the physiological demand involved in executing that movement exceeds the individual's physiological capacity. So the physiological demands, when they exceed the physiological capacity of an individual, makes that movement impossible or difficult. Therefore, a movement scientist must always keep an eye on the physiological thresholds. You must analyze the individual physiological capacity, and then whether the physiological demand of any task or any situation and context, the demands, whether it exceeds that person's physiological capacity. The moment it does, movement must be impaired. There will be movement changes. And therefore, some of the intervention we provide have not addressed those physiological thresholds. Some of our interventions merely address the movement itself, without addressing the physiological thresholds, which, when diminished or when crossed, or when the physiological demand exceeds them, the capacity of the individual, you cross that point. And then it leads to movement change. It also means that if you have to reverse that movement change, you must go back to enhance the individual's capacity, the physiological capacity, to absorb those physiological demands in those task contexts or in those movement contexts. Otherwise, movement will continue to change. So when you now give me IR for a certain movement deficit, when you now give me infrafaradic current to strengthen my muscles, how does that affect the physiological threshold, which is actually the problem, but which we have failed to assess or failed to see as the basis for our movement analysis? So when we do this, we have challenges. So the point I'm trying to make is that a physiological threshold is that point at which physiological demand normally exceeds physiological capacity of an individual. When this occurs, when that point is crossed, the body will now adapt. It will adapt in a different way. Compensation emerges. You now begin to see compensatory movements because he has crossed that threshold and he lacks the physiological capacity. Movement changes occur. The body is not malfunctioning. You must understand that. The body is not malfunctioning, but the body is protecting itself because it can no longer execute those movement task demands because it lacks the physiological capacity to do so. So you will now begin to see the first thing, compensation. Compensation begins to emerge, and then movement changes begin to occur. And then the body itself is not malfunctioning. But when you look at the body without this understanding, you will say that the body is malfunctioning and begin to treat the person as somebody who has a malfunctioning body, whereas it is not true. What he's simply saying is that the body is protecting itself from its lack of capacity. Therefore, what you need to do is to address that lack of capacity as a movement scientist. I will give you a everyday example. Think about carrying groceries. Some of us go to carry groceries. Initially, our posture is upright when we carry groceries. Our walking is smooth. Our breathing is very comfortable. I mean, we go to the market. You can go to, the textile market in Kano, and we buy textiles from the market, and we put them in our grocery bags, in our shopping bags. And we can carry that to the car. And when we walk, we are excited. Our posture is upright. We are walking smoothly. We breathe comfortably, carrying our shopping bag. But you see, after several minutes, because we want to go to another shop to buy shoe, and we have been carrying this bag, our shoulders begin to slump. Our gait begins to slow down. Our breathing increases. Why is it so? It's not because walking has changed, though. Not because the grocery bag has changed in its weight. What has changed? The physiology has changed. A threshold was crossed. So if you look at yourself, you know how you feel when you buy some of these dresses you've been dreaming about. Or when you buy some of the shoes, you may want to buy 10 of them. And then you go to the market, you buy them, you put them in shopping bag, you're excited. You leave the shop fulfilled. You walk uprightly, you walk smoothly, you breathe normally. But of course, you have not gone to the market to buy only that. There are other things. And as you carry your shopping bag with all of this, you now begin to see. After some minutes, you begin to experience that your shoulders will now slump. Your gait will slow down. Your posture changes. Your breathing increases. Why is it so? It is so because not because your walking has changed. It is so not because your grocery bag or your shopping bag has changed. It is so not because your physiology has changed. It is so because a threshold was crossed. And crossing that threshold created a paradigm shift. The traditional movement analysis will normally ask a question. What movement anomaly do I see? When we do our analysis the traditional way, it will ask, what movement abnormality do I see in this person? Because it is now going to see a movement abnormality. But advanced movement analysis, informed movement analysis, will not ask the question, what movement abnormality am I seeing? It will ask the question, which physiological threshold is this person approaching or have exceeded? You see, a movement scientist does not see movement abnormality. A movement scientist sees physiology. He sees the physiology of movement. He sees the biology, the visible biology of the human body communicating to him. So what you see, if you are observing this person, if you are not a scientist, or if you go the traditional things we do that are not properly informed, you begin to become fixated on the movement abnormality that you are seeing. You are seeing abnormal movement. Whereas a more informed and advanced movement scientist does not see that. What he sees is physiological threshold and begins to ask the question, and what he asks and sees is which physiological threshold has this person exceeded or is this person approaching? So this question transforms observation into clinical reasoning. So we make observations in the traditional setting, in the traditional mindset, but those observations are not translated into clinical reasoning. What we reason with is limited because we only focus on the musculoskeletal system, abnormalities in them, structural abnormality. And we have no recourse to the physiology, which is the basis that informs all movement changes, all of them. There's no exception. And the physiology is an integration of different systems, including the musculoskeletal system. So it is a more integrated system. And that is the point we have been making. And that's the mark we have been missing and which we need to address. Now, let us visualize what happens as movement intensity increases. What really happens when movement intensity increases? Imagine moving from rest to walking, then to brisk walking, then to climbing stairs. Please give me a minute. Let me take a drink, drink some water. All right. So now I want to take your mind to something. Imagine moving from rest. Imagine moving from rest to walking, to brisk walking, to climbing stairs, then to running, and then to sprinting. As the intensity increases, what do you observe? You observe that several physiological systems will respond simultaneously. They don't respond one after the other. When this one has finished responding, the other one will respond. No, they will all respond simultaneously at the same time according to how that activity has impacted them. And really, they are the ones that actually impact the activity. They are the ones that alter in order to create that activity that movement activity you are seeing, and not the other way around. They inform it. So that activity reflects their change in behavior. So when you now make a decision with your brain to move from rest to walking, it has physiological consequences. It has physiological alterations that support it. When you now move from walking and say, let me do brisk walking, it has physiological variation that goes with it. And when you say, okay, not just brisk walking, I want to, in addition, now start doing step climbing, you also have physiological variation that also goes with it. And then you now say, no, let me go to running. It has its own, and say, no, I want to even be faster. You go to sprinting. As intensity increases, several physiological systems will respond simultaneously. One of those responses is this: METs will increase, metabolic equivalent threshold. The MET value will increase. The oxygen consumption will also increase. The heart rate will also increase. The breathing will also increase. The perceived effort will also increase. The ability to talk will decrease. Eventually, fatigue will develop. And importantly, movement quality will begin to change. If you run an analysis, a movement analysis, you will see that. What is the critical thing that you see in this scenario? What you see in this scenario, most clinicians will see movement deterioration as the end of a process. His movement or her movement has deteriorated. I've observed that this patient's movement has really deteriorated. They see it as the end of a process, and probably because of this or that. In reality, that movement deterioration is not the end of a process. In reality, it's a signal. Movement deterioration is evidence that physiology is approaching its limits. Anytime you see it, in whatever condition you see it, it tells you that physiology is approaching its limits. The physiological thresholds, we are approaching their limits. The body is telling us something. It's telling us that the movement, it's telling us something that reflects in the movement. So the movement is the symptom. The physiology is the cause, not the other way around. That movement duration you are seeing is the symptom. It's a symptom. It symptomizes a change in the body physiology. And if you track the physiological thresholds, you will see which dimension it is coming from. Let me give you another example. Consider a market trader carrying goods through a busy market. Early in the day, the posture is upright. The stride length is normal. The movement efficiency is perfect. Several hours later, after carrying his goods to and fro, you now begin to observe a forward trunk lean. He takes shorter steps. She now, engages in slower walking speed. What changed? Of course, the anatomy did not change. It is the same body anatomy. Not anatomy. What changes is the physiology. The same body anatomy. No injuries, no broken bone, nothing, no severance of this or that. What has changed is the physiology. Fatigue accumulated. The movement reserve, the physiological capacity declined. The thresholds were crossed, the physiological thresholds. And then movement adapted to those physiological changes. That is how movement scientist thinks. That is what movement scientist sees. That is the question movement scientist asks. What physiological threshold has been crossed, has been exceeded, or is about to be exceeded? when he sees such a person. And the same in the clinic. Movement compensation is often a physiological adaptation before it becomes a biomechanical problem, which now manifests itself. So, it does not become a biomechanical problem before it becomes a physiological adaptation. No. Movement compensation is normally a physiological adaptation before it becomes a biomechanical problem if you do not address it. So, but when a movement scientist sees it and sees that there is a movement compensation, automatically he knows that there is a physiological adaptation in that context that needs to be dealt with before it becomes a biomechanical problem. What you have seen on this slide are the thresholds that you need to examine as a movement scientist and how they are connected to each other. If you look at the first column, it tells you the intensity zone of that movement task when you are at rest. What is the metabolic equivalent? What is the energy expenditure when you are at rest? It's 1. What is the perceived exertion rate on if you use the RPE? That is the perceived exertion. It is 6. If you now calculate the heart rate, the maximum heart rate in percentage, it is between less than 50%. And if you conduct a talk test, you will see that the individual is able to talk normally. And what does it mean in terms of movement appearance? You will see that in such situation, there is no change in the movement. The movement is at baseline. Just like the person who have gone to buy a dress in the market. Initially, the movement is normal. Everything is fine. You can walk upright. The movement is efficient, no energy consumption that is beyond normal. And the stride length is normal. It doesn't walk slowly, it walks normally. But after some time, you begin to see a physiological change in the threshold. So this is the threshold we're talking about. If you look at the intensity zone, when the activity demand is very light, the MET value is between 1.5 to 2. The perceived exertion rate using the RPE scale, that is box scale, you begin to see 7 to 8. And it's equivalent to around, 50%. The other one is less than 50%. But when you come to the very light zone, which is equivalent to 1.5 to 2 metabolic equivalent, or the perceived exertion rate between 7 to 8, it's equal to roughly 50% in terms of heart rate max. And the talk test in such situation is that the person can still maintain easy conversation. But if you come to the movement appearance, you will see slow walking and minimal stress. So the walking has changed. You see how physiological changes, these are physiological thresholds. Are you seeing how they have adjusted and what they reflected in terms of walking? You begin to see slow walking. So when you begin to see slow walking, go and take a look at these physiological thresholds, they have changed. In very slow walking, especially in very light movement activity, the MET is between 1.2 to 2. The RPE is between 7 to 8. The heart rate max is about 50%. And the talk test is easy conversation. If you come to light movement task, you now begin to see 2 to 3 as the MET equivalent. The energy consumption has increased to between 2 to 3. The exertion rate has increased to 9 to 11. And then the maximum heart rate has also increased between 50 to 60%. And if you place that individual on a talk test, it has also changed. It goes to comfortable talking, not easy conversation anymore, but just comfortable. And then what do you see in terms of movement? You see smooth, you see coordinated and symmetrical movement. But when you come to moderate zone, this is the very first ventilatory threshold. This is the VT1. When you come to this particular one, when you come to moderate, you have moved from rest through very light, through light to now moderate. This is a key threshold. You see 3.6. It goes to 3.6 in med value, and then the RPE goes to 12 to 13, and max metabolic, the heart rate shift to 60 to 70%. Now, talk. The person can talk, but cannot sing. Functional reserve has already been challenged at that point. If you keep going down, you will see what happens after you have crossed that threshold. You do moderate hard, or you do hard, where you now have the VT2. In fact, it is in hard, you have the VT2. The other one in moderate, you have the VT1. And then anything below that VT2, you have already changed again. Take a look at the movement. You see compensation may appear. It may appear in moderate hard. That's when you begin to see compensation, because you have crossed the key threshold. And these thresholds are captured in these values. The MET is 3.6. The exhaustion, if you're using the box scale, is between 12 to 13. Maximum heart rate, 60 to 70%. And then the talk test, you can talk but not sing. And if you keep going down, you will see the changes. As these changes are accentuated, if you come to the VT2, you see it's now shifted down to 8 to 13. And then the bulk rate, or the RP exhaustion rate, is now 16 to 17. And then the maximum heart rate has moved to 80 to 90%. Then you have difficulty to talk. You see the physiological reserve, the movement reserve have been challenged. Now, what simply you see there is that you have the technique, the movement technique now deteriorates. You see a deterioration. Are you seeing why I say that deterioration in movement is tied to physiological variation, to physiological changes? Now, if you come to your clinic, how many of you know about these physiological charts, these physiological thresholds? How many of you have measured it? In order to get a sense whether you are dealing with a movement, pathology, or whether you are dealing with a function issue, a movement reserve issue. Because these are some of the issues. So when you begin to see compensation, which eventually becomes consolidated to become a biomechanical problem, and you don't address it, then it can cause other chain reaction. But the moment you begin to see compensation, physiological thresholds have been crossed that may warrant your intervention. But you need to analyze all of this and put them in context before you can make any sense out of them, and because you can now apply these things. So this is the point that we are trying to make. This is the issue. That we are trying to make. So if you look at the key message that I want you to take away from here, remember what I have said, that movement compensation is often a physiological adaptation before it becomes a biomechanical problem. If you look at this chart, that is a normal chart. That is what you see whenever there is a movement adaptation. You will see that movement compensation comes as a physiological adaptation. You will see that all the physiological thresholds have changed. Certain thresholds have been crossed. Before you now, below it, you now begin to experience, if you consolidate and allow it, biomechanical problem. So you don't see biomechanical problem. You don't see movement abnormality. You see physiological changes. You see, physiological changes. As a movement scientist, that is what informs that biological problem. And if until you have that approach, you will not be able to integrate the systems and do an analysis that will sustain an impactful recovery for those who may, in fact, in the process of managing the patient, complications even. And that is why most of you will complain that this person came to physiotherapy clinic. The first day he came, he was walking normally, but we don't know what happened. And we're really treating this patient too. But as time goes on, he was becoming weaker. He became wheelchair bound and can no longer do the things he was even doing the first time. Did he have a second stroke has he ever? No stroke, nothing. Just the condition was deteriorating. It's because you never understood as a movement scientist that there were physiological thresholds, that the physiological reserve, the movement reserve, the physiological demands exceeded the physiological capacity. And you should have been working on that physiological capacity. You didn't do it. So you have compensation. And you cross that compensation, movement compensation came in, and you allowed it, it became a biomechanical problem. And now you are dealing with an issue that has, advanced, complicating the systems. Because you were not looking at multiple system integration, looking at human biology to ask the right question as a movement scientist. You were looking at the symptom, the emergent property, not the actual physiological basis of movement that warranted that condition. And that is what you need to change. And that is what we are saying here. Now, we arrive at one of the most clinically useful concepts in rehabilitation. And that is the point of all of this. We arrive at one of the most clinically important concepts. And it is important you pay attention. Most clinicians, they learn the RPE. They learn the heart rate zones. They learn the talk test. They learn the METs as separate tools. They learn them. That these are all separate tools. This one is this one is that, this one. They do not know that they are not separate, that they are integrated, because they inform all the systems that are relevant for movement to happen. They are simply different ways of measuring the same physiological reality. There are different ways of measuring the same physiological reality. And that is why if you look at the table I have displayed, moderate intensity, RPE is 12 to 18. If you look at that table, 60 to 70% is the equivalent in terms of heart rate marks. And then 3 to 6 is the MET value. And if you apply the talk test, is able to talk but not sing. What does this simply mean? At this level, the body is approaching what exercise physiologists call ventilatory threshold 1, VT1. This is where oxygen demand actually rises. ATP production increases. Carbon dioxide production rises. Breathing becomes more noticeably faster. The conversation remains possible in this setting if you apply the talk test, but singing becomes difficult. This is why the talk test works. It works in using it as a basis to inform physiological changes. And now, I know it will now give you the aha moment. Aha. Let me tell you one thing. When a patient says, I can still talk, but I wouldn't want to sing, they have just given you information about their ventilatory threshold without any sophisticated equipment. When you are working with a patient and he tells you, I can still talk, but I can't sing, he has given you a very formidable information that cuts across all the systems, that gives you insight into the physiological reality. The statement usually generates immediate interest in every movement scientist. Why does it matter clinically? It does, because most activities of daily living, they occur in this range. They occur in the range when you can actually talk but not sing. Brisk walking should be an activity of daily living, and that is why it is measured. Pedometer walking will always measure the brisk, not the slow. Climbing the stairs is an activity of daily living. You must encounter that if you live in a flat, or if you in an upstairs, or you go to school and you have the high-rise buildings, or if you go to shopping malls, you will climb, especially the more advanced shopping malls. Or community mobility. These are things you encounter. Or if you are doing some farming and gardening, or if you are carrying moderate loads, which is common when you shop, when you do things. So these are normal activities of daily living. This is why moderate intensity often determines independence. So those who are able to engage in moderate activities of daily living, who are able to execute these thresholds, function around these thresholds, it determines who is going to be independent in movement and who will not be independent in movement. And of course, which supports activities of daily living. So if a patient cannot tolerate this zone, daily life will become very difficult. It's as simple as that. So movement changes across the thresholds. And that's the point we are trying to bring. And as a movement scientist, you need to understand this. Let us now connect physiology directly to movement. If you imagine a patient with knee osteoarthritis at slow walking, what does it tell you? It tells you that approximately 2 meds is what he consumes in order to achieve that slow walking. He operates at the level of 2 metabolic equivalents. Now, the gait may appear normal for that person, even though he has osteoarthritis. And you will not see any obvious abnormalities, but he has osteoarthritis. You will see no visible compensation, but he has osteoarthritis. Now, ask the patient to walk briskly. Immediately you ask the person to do that, he approximately increases the metabolic equivalent consumption to 4 to 5 meds. Suddenly, what do you observe? The person begins to take shorter stride length. He now has reduced knee flexion, slower speed, and you see a trunk lean, the trunk leaning forward. What has simply happened? The pathology did not suddenly worsen. The physiology changed. That's simple. That's all what has happened. That's what this threshold you're looking at tells you. And that is the true picture. The physiology changed. The reserve was challenged. The movement reserve was challenged. The physiological capacity was challenged. A threshold was approached and movement adapted at that threshold. Let me give you another example. A football player performs repeated jumps. Early in the session, excellent alignment is what you see. Stable landings is what you see. Efficient mechanics is what you see. If you look at football players when they are freshly introduced into the field, they're all over the place. But later, what do you begin to see when they jump? You begin to see knee valgus. You begin to see landing becoming noisy, becoming challenging. You begin to see balance decreasing. What simply happened? The athlete suddenly forgot techniques? No, they didn't forget their techniques. What happened? A neuromuscular fatigue threshold was crossed. Motor control therefore deteriorated. Movement revealed the physiology. The physiological changes that has happened is now revealed in that movement. So the clinical threshold model is what we are dealing with in this context. And it presents some interesting things we need to know. It presents the following. It presents tissue threshold that is important. And when we have tissue threshold or tissue load threshold, what we see is pain and gadding once we cross that tissue load threshold. We see pain in walking. we see guarding. A person walks with guarded, awareness. But we have tissue load threshold. We have motor control threshold before we have the VTI. And that is what this is saying. So when we cross that tissue load threshold, pain and guarding, when we cross the motor threshold, there are subtle coordination changes. When we cross the VT1, there is reduced reserve. When we cross the neuromuscular fatigue threshold, compensation emerges. When we cross the VT2, major movement alterations happen. When we now have failure threshold, functional breakdown happens. What have you seen in all of this? It means that if you take a look slowly, you will see that by the time we begin to engage in very light movement activities, we are pushing towards crossing tissue load threshold. And when we come to the light part, we are also working in that realm. But the moment we keep increasing from that very rest to very light to very to light, we are going through tissue load threshold and through motor control threshold. You begin to see subtle coordination changes, begin to see guarding in our movement as we increase the intensity. But when we come to VT1, we begin to see reduced reserve. And when we go beyond VT1, we are dealing with neuromuscular fatigue threshold. There, compensations emerge. And when we come to VT2, we see major movement alterations. And when we come to failure threshold, we have functional breakdown. What am I saying? Have you seen that this threshold can help you understand the nature of movement dysfunction and diagnosis? It means that when a patient operates within this tissue load threshold, what may be the likely manifestation is pain and guarding. If there are motor control issues, it means that the patient will only overcome. If a patient crosses the threshold for motor control, it will reflect in coordination changes. So coordination changes will appear when we deal from rest to very light to light. In fact, in light movement activities that will warrant a MET equivalent of 2 to 3, RPE of 9 to 11, and 50 to 60% maximum heart rate, you are likely to see in that zone motor control threshold being exceeded. So issues that arise from that are issues that are located, that have to do with motor control system. And they normally reflect in subtle coordination changes. But when you go to tissue load threshold between very light, 2 to 3, 7 to 8, and approximately 50%, you are dealing with tissue load threshold issues. And so, but when you come to VT1 and the patient is operating around VT1, you are dealing with very reduced reserve. Because at that point, when you still have motor control threshold operating around that area, you still have some, that patient still have some reasonable movement reserve threshold, movement reserve capacity. But the moment he comes to VT1, you are sure you are dealing with reduced reserve issues. Neuromuscular fatigue comes when you operate between VT1 and VT2. So any patient that operates between those two have neuromuscular fatigue issues. There will be compensation. It will emerge immediately. And any patient that operates around VT2 has major movement alterations. But beyond VT2, any patient who operates beyond VT2, any individual, he has a failure threshold. All the physiological thresholds has failed. There is a functional breakdown in those patients. Are you seeing that physiological thresholds are tied to movement? They are also tied for you to predict, to diagnose whether this is a motor problem or whether this is a tissue load problem or whether this is a neuromuscular fatigue problem. You can virtually see where the problem is coming and what type of thing you are dealing with. Just using this table and connecting physiology thresholds to movement. How many movement scientists know this? What is the quality of your movement assessment of your patient? Are you seeing that there is a lot we are not doing and there is a lot we do not know? Are you seeing that these tools we think are separate are not separate tools? They're integrated. By knowing the RPE, you already know the metabolic equivalent that is correlational, even without measuring them. Once you know the RPE, you can know the rest. Once you do the talk test, you know the equivalent across the range. You already know what the maximum heart rate is operating in is, what it is. So you can build a table that gives you a sense of the movement dysfunction and the underlying physiology, the underlying physiological threshold. You can build it in any patient. So as he deteriorates or improves, you can know. So where was this patient across the physiological threshold when he came to your clinic? Over time, was he deteriorating in those physiological thresholds or was he improving? If you don't keep an eye on those thresholds, you will better not know what you are doing with movement analysis and movement intervention. And this is why it's important I'm bringing this home. Because when you do biomechanics and do kinesiology, many people wonder what they are. And they think that these are sciences that are different and disconnected, or gait analysis and disconnected from clinical sciences. They are actually the opposite. They are the foundation of physiotherapy. But what we have failed to do is that we are limited in our knowledge of the organization of movement. And therefore, analysis will begin from the wrong perspective. Physiology is the basis of everything. And a movement scientist is well acquainted with them. And that's one thing that I want you to take away from here. I want to go further to give you a sense of what I have been saying in a compartmentalized manner. What have I been saying? You can see what I've been saying, that we have zone 1 and zone 2, from rest to functional independence. This is what you see in those who operate between zone 1 to zone 2. What do we see there? They are able to operate from rest to light activity. They spend merely 1 to 3 minutes. You see their RPE between 6 to 11. You see their heart rate between less than 60%, and the full conversation is possible. You know, they do that in sitting, they do that, they can sit, they can stand, they can do, you see slow walking, you see household tasks, they're able to execute all of them. Oxygen supply normally exceeds the demand in these individuals. Their oxygen supply is far above their demand. Their ATP production is easily maintained, and movement appears very smooth, very coordinated, and very symmetrical. They move their left limb the same way they move their right limb. This zone is the zone of functional independence. Whenever any patient can fulfill activities you have given him and they still remain within 3 to 5 minute zones, they operate between 12 to 13, 60 to 70 maximum heart rate. They can talk and cannot sing. They do brisk walking. They can climb stairs. They can shop. They can do community mobility. All of these correspond to voluntary threshold 1. They are below it. The oxygen demand can rise. CO2 can increase. Breathing can increase. Lactate begins to accumulate, but still remains manageable. The RPE is 12 to 13. And the 6 METs is what you begin to see. 60 to 70% maximum heart rate, and the talk to sing test. They're all showing, these are all different windows that show you the same physiological reality, that speaks to the same physiological threshold. What is the clinical flag that is relevant? Movement abnormalities at 1 to 3, we suggest stroke. So if at that 1 to 3, you still see movement abnormalities, you see that in stroke, it suggests pain, it suggests severe weakness, it suggests balance dysfunction or neurologic disease, but not cardiorespiratory limitation. So anybody that has movement abnormalities within this zone, these are likely to be the cause. When you come to 3 to 4, this is compensatory. And of course, we are dealing at that point with a different type of physiology. So in this compensation zone, 6 to 10 METs, RPE, you are dealing with, RPE of 14 to 17 and maximum heart rate of 70 to 90. Conversation is limited to short phrases, and it corresponds to ventilatory threshold 2. You have lactate accumulation rapidly. You have ventilation increasing disproportionately. You have stride length shortening. You have trunk motion increasing. You have coordination and balance deteriorating. And that is different. This is for zone 3. And those in zone 4 are those in survival physiology. Their MET is greater than 10 METs. So you have RPE of 18 to 20, a Vmax of greater than 20. They're unable to talk. So if you ask them to do brisk walking, you will see that their RPE shoots up to 18 to 20. And that is equivalent to greater than 90 max in terms of the movement reserve or physiological capacity of physiological reserve. And the ventilation is near maximum. Oxygen saturation or extraction approaches maximum. That is, they are almost at the maximum oxygen extraction that the body can get. It can't get anything else. And fatigue becomes dominant. Movement quality often deteriorates at this level very dramatically. And the body prioritizes task completion over efficiency. It doesn't matter how I complete this task. I don't care. I just to complete it, but not to do it efficiently because it's incapable of doing so. You see knee valgus in this patient during landing for athletes, or poor cutting mechanics, or balance errors. You see increased injury risk. Some of them are even at risk of falling. You see, these are not features that are very familiar. And you see skill failures. All the skills they have acquired, they fail in utilizing them to function. They are physiologically they have crossed physiological thresholds that are almost injurious. So what are we saying? You can see that we are tying the physiological thresholds into 4 zones. And I provided you a picture of these zones earlier. I tried to show it here, 4 levels. You see, I have gone further to provide them here, to give maximum expression to them, and to capture them more here, more vividly, and to see the different kind of movement dysfunction that reflects these physiological changes. And in what situation, what you see where, and what you should take from them. So if you look at the MET framework, this is the MET framework, where you look at metabolic demands that is made visible. In different contexts, what do they mean? I have broken it down here. This is a tool for movement scientists. This is a practical tool that you can use, tying physiological thresholds to movement, so that you can explain the type of movement that happens where and what physiological threshold inform them, so that when there is a derangement, you know where to look at. And then you know how to navigate, and you know how to prescribe, and you know what to do and what to track. So if you use the movement threshold model, it gives you a clinical framework that connects the physiological threshold. So the physiological threshold takes you into the movement threshold. And then the movement threshold integrates all of that together. You can see how it is integrated into level 1, level 2, level 3, level 4, level 5, and level 6. What you will do and is not able to do. At level 1, what you have is tissue load threshold. And so you see that local pain may happen, or maybe you may have overload, you may have some of those things that begin to happen at level 1. And if you go to level 2, motor control threshold, look at the RPE you see in those who have that challenge. And the coordination, and subtle changes are what you record in terms of movement. And in level 4, ventilatory threshold 1 is where you have the level 3, and look at the physiological variables, or the threshold that define it. And if you come to level 4, you see neuromuscular fatigue threshold. And these are what defines it. And level 5, ventilatory threshold 2. Look at what defines it. And when it comes to level 6, there is functional failure. And so you begin to see all that I have enumerated. So you can see that physiological thresholds are tied to movement. And having insight of that now helps you to develop the threshold markers and utilize them as integrated clinical reference when you are managing your cases and when you are trying to do your assessment. You see that there are 4 threshold tools. There are 4 measurement tools: the MET, the RPE, the talk test, and the maximum heart rate. They are not separate. They are 4 expressions of the same underlying physiology. So I have tried to bring them up in different ways, saying the same thing in different ways, so that if you don't understand it this way, you will understand it that way. All I need is clarity from you, or clarity for you, so that at the end of the day, you can apply this in order to have a better insight into functioning as a clinician. So you have an insight into threshold conditioning and movement sign that goes with it. So threshold conditioning and movement sign that goes with it. So that is what this is all about. So if you look at the observed movement sign for somebody who limps are slow walking, that person, the threshold implication or the threshold that is implicated is the tissue load. And what is the likely system that is responsible? Musculoskeletal and pain. What is the clinical reasoning pathway that you adopt? You suspect joint pathology. You look at pain guarding. You look at likely structural deficits, not cardiorespiratory at all. And that pathway cannot explain it. If you go to trunk, when you have a trunk lean on stairs, when they climb stairs and they have trunk lean, you look at motor control, and they are approaching ventilatory threshold 1. And what are the likely system you are dealing with? You are looking at the neuromuscular system. Take a look at the hip and the structures around the hip and the physiology of the hip function. You're looking at the hip adductors to look at their weaknesses. You are looking at the proprioceptive deficits, or you are dealing with reserve depletion at moderate intensity. Now, if you go further, you look at shortened stride length at brisk walking. When you add them to do brisk walking, and you see that their stride length is shortened, no longer normal, then they are within that threshold V1, VT1, and this is the MET value you encounter. You are likely dealing with the cardiovascular system, and there is a reserve issue. Movement reserve is being challenged beyond what the system can give. So you have reduced movement reserve, you have stress that impacts the VO2 max, and you have cardiac output issues or musculoskeletal part. These are the clinical reasoning pathway that speaks to this situation. And then when you observe that there's a knee valgus during landing, if the person jumps up for an athlete and you see knee valgus, which should not be, and it is excessive, you are dealing with neuromuscular fatigue and likely have a neuromuscular system implicated. And you see in this that motor unit fatigue may actually be the issue, crossing their threshold at that point, and not a skill deficit, not because the footballer is not skilled, not because the athlete is not skilled, but it's a physiological event that arises from neuromuscular fatigue. And you, as a movement scientist, is also a sports scientist and very key in sports performance. And with this knowledge, you can take a look at the field and see when your players jump and when they land with excessive valgus, there is a neuromuscular fatigue. And you are seeing something others are not seeing. You are seeing the physiology. They are focusing on valgus, excessive valgus. You are focusing on the physiology behind it. And you already know the threshold is about to cross. And you are now going to make interventions. And when you see breathlessness on one, flight of stairs, then the patient is between VT1 and VT2. And the cardiorespiratory system is implicated. And therefore, you need to assess the person for COPD. You are dealing with other heart failure. You are dealing with anemia. You are dealing with deconditioning. These are likely conditions. And you see, step climbing is equivalent of 4.6 meters. And therefore, when you have a patient with 4.6 meters in step climbing, you begin to suspect that this person may have COPD. This person may likely have heart failure or anemia. Are you seeing that physiotherapists can predict anemia? Can predict COPD, can predict heart failure, even without echo. Just by that functional text. You see? That's why I'm tying the physiological thresholds of movement to conditions that revolve around it. Now, if you look at those who use handrail, passing on the stairs as they climb, they probably have VT1, they're operating around VT1, and they have the reserve depletion. Their reserve is depleting. And normally it shows multiple system failure. They are coming to multiple system thresholds that are involved. Okay, the reserve is critically reduced, and task now requires up to 80 to 90% of available capacity. And then when you look at those who have balance errors during running, for instance, they run, but they have balance errors. They are able to run, but they can complete that task. But they struggle with balance as they run. They are around VT2. And their issues are more neuromuscular than cardiorespiratory. And you have, you take a look at the vestibular system and neuromuscular system. These two systems are normally implicated in their physiology, in reflecting in that type of movement. And so fatigue is intensified or is induced. Fatigue-induced proprioceptive failure is what you are dealing with. Fatigue-induced proprioceptive failure. And then you see reaction time that has slowed beyond the threshold. So the reaction time, because you have what you call the reaction time, and there is an instrument for measuring the reaction time, and probably most of us cannot afford it. But can you see that from just the simple physiological threshold, it is matched to reaction time? And if you really go and measure the reaction time, you will see that reaction time, that is the time it takes to generate sensory input and the system to respond to it, it has now slowed down in such individuals. And when you see avoidance of activity, when you see fear of movement, when you see fear of movement because of maybe fear of falling, there is actually a functional failure. And in that situation, you are dealing with a cognitive problem. You are dealing with a psychological problem. You are dealing with a physiological limitation. The reserves in that situation have so depleted that even anticipation of demand is an anticipation of the physiological demand that we place on the system is triggering avoidance behavior. And that is what you are dealing with in that context. Have you seen now that as a movement scientist, you are able to look at different diverse conditions in the hospital? You are able to look at different conditions even in athletes. And you can make a decision. Their clinical reasoning pathway are clear. I took time to develop this, to put this together. You may not see some of the things I'm telling you now in textbooks. But I'm speaking to you based on experiences and research. As somebody who has had vast experience in this field, these frameworks were developed over time in research. And this is solid, and this is incontestable, and has been backed by clinical evidences and evidence synthesis. So you may ask yourself, why is it that the talk test works? What is the physiology behind it? It works because of the common understanding, the common fact that they are tied together. Forget about the misconceptions sometimes that we may have. Many clinicians believe that talk test works because oxygen becomes unavailable and you are that gasping for air, during exercise. That is incorrect. That's not true. The actual mechanism for talk test is that it works because ventilation is increasing, not because you are running out of oxygen. Ventilation is increasing. As CO2 production rises at VT1, the respiratory drive increases to remove that CO2 and bring in, because the demand now rises. So you have ventilatory pressure. Speech requires controlled exhaustion, which becomes progressively hindered, becomes progressively harder as ventilatory, demand rises. So I want you to see that we have 4 tools here, but 1 threshold. You can see how these 4 tools speaks to 1 threshold at a time. You have the MET rise, you have the heart rate rises, you have the ventilatory rise, you have the RPE. So all of these are tied together, and you need to understand why it is so. So the idea that oxygen demand is what drives the talk test makes you to talk, and it's not true. The mechanism is actually ventilation. It's cardiorespiratory, the increase in that drive. So it's important we understand all of this, and we are putting the figures to them so that we now redefine movement. We redefine movement analysis. The old definition of movement analysis is that movement analysis is simply watching movement. But the new definition of movement analysis is that movement analysis is identifying physiological thresholds through movement. The old one is that we are watching movement. So when we watch movement, we are analyzing it, so by watching it. But the new definition takes our mind away from that movement you are seeing. The new definition is that movement analysis is identifying physiological threshold through movement, because movement is the outcome of the physiological process. So even a sign, every sign we have is a physiological clue. A limp speaks about tissue load threshold being crossed. A trunk lean, anytime you see a patient walk leaning forward, it simply means that motor control threshold is being approached. That is, it means coming to the RPE of maybe, the MET value of between 3 to 6, or 6 to 7 rather. And then when you come to shortened stride, it means that reserve is being challenged at VT1. And when you now see a pause on the staircase, it means that functional reserve has critically depleted. Just on a flight of stairs, there is a pause. You can't complete it without stopping to rest. Or when you see use of handrail, then task now requires 80 to 90% of the capacity, of the functional capacity. And therefore, there is so much depletion of the movement reserve. And then when you see early fatigue, it means that there is neuromuscular threshold which has been exceeded. Are you seeing that we are tying movement to physiology and therefore getting better insight? And that is the idea. So the intellectual journey begins in this session 1. And in this session 1, before you now go into hands-on, we have commenced an intellectual journey. This session was just designed to progressively give you insight, to transform how you think about movement, to transform how you think about movement from observation to physiological interpretation. That is the idea. And what are we saying? I wish to recapitulate it again, that movement is the visible output of multiple systems. That is one key thing. And then it is tied to physiology. And in such a way that the internal engine driving movement is physiology. Without physiology, there is no movement. And when physiological changes happen, movement abnormalities arise. In fact, movement changes rises. And it becomes abnormal depending on whether they have crossed certain thresholds or not. And that gives us to thresholds. The first threshold, VT1 and VT2, are tied to neuromuscular and tissue loads. So that with them, we can know that those who operate within those areas have either neuromuscular problem for those around VT1, or for those around VT2, and then tissue loading issue when you are less than VT1. And what does that speak? At what point do we deal with compensation? We begin to deal with compensation when we cross VT1. And therefore, it speaks to intelligent adaptation, not failure. There is no functional failure at that VT1. What you see that the body will physiologically adapt. But if it continues considerably, it will now become a biomechanical problem. And so biomechanics, the forces, the levers, and the load distribution that the body has, we now begin to alter dimensionally into transient, low-dimensional deterministic machine to fulfill the goals of movement task. When we allow VT1 to be crossed without intervention, and it progresses to a point of functional failure, and then you see that that functional failure warrants a rehabilitation intervention. And if you have to give that rehabilitation intervention that speaks to the function at each level of the physiological threshold, then the prescription must be grounded in physiology. It must not be grounded in anything else. It must be grounded in physiology. So you see, what you need to know is that participants who complete this journey with us, who goes through this training with us, will never observe patient movement anymore in the same way they used to do. What you observe is that movement becomes a physiological signal about the physiology of the human body, and not merely a mechanical event in the sense in which you understand it before now. I want to let you know that in the subsequent sessions, when we encounter one another, and beyond it, in the session 2, we look at physiology of movement, dysfunction, and injury. In session 3, we look at biomechanics and kinesiology. And of course, the practical sessions of movement analysis in practice also comes in focus. And then exercise prescription, which are threshold-based rehabilitation that you give as a movement scientist. Because you see, what you do is that you analyze and you prescribe. But if you don't have a good understanding of the basis for your analysis, then the basis for your prescription will also be faulty. When we conduct proper movement analysis, the biomechanics and the kinesiology of it You now, like we're going to do in the next session, you now begin to see that it arises from an integration of these systems. And when we analyze them to give meaning to them, we are also trying to unmask the physiological basis, to unravel it, to delineate the physiological mechanisms, and tie them to the thresholds we have identified. And then exercise prescription becomes more relevant and more targeted, and more aligned to physiological threshold that defines these issues. My final message is to emphasize the issue. Not what movement am I seeing, but what physiology am I seeing? When you leave this workshop and observe somebody walking, observe somebody squatting, observe somebody climbing stairs, observe somebody reaching out for an object to pick it up, or running, or lifting, do not ask yourself again, what movement am I seeing? Always ask yourself, which physiological threshold is this person approaching? Which physiological threshold is this person challenging? Which physiological threshold is this person exceeding? METs simply transforms to the measure of metabolic demand. And heart rate reflects that cardiovascular demand placed on the heart as a result of the movement task. And the talk test reflects the ventilatory demand placed on the system. And the passive exertion, the RPE, reflects the global physiological stress perceived by the person as being exerted on him or her due to the movement task. Movement is the visible expression of all them combined, not of one single one, but all of them combined. And so the central truth in all of it is that movement is not merely motion, as you already know it. Yes, movement is motion, but it's not merely motion. Movement is the visible expression of physiology. And movement analysis is the act of uncovering physiology through movement. This is where I want to land. And this is where you will have in mind as we go into the next session when you start dealing with movement analysis. I want to say it again, that movement is not merely motion. Movement is the visible expression of physiology. And movement analysis is the art of uncovering physiology through movement. This framework itself will provide you with a seamless bridge from physiology to biomechanics to kinesiology to movement analysis and exercise prescription. This is the complete clinical science of human motion. If you do not have a fundamental knowledge of physiology, you will never understand biomechanics. And if you do not have a fundamental knowledge of biomechanics and kinesiology, movement analysis will become impossible. And if you don't have all of them, that knowledge, your exercise prescription will not be targeted at the right issue because your clinical diagnosis will be wrong. Therefore, the clinical science of human movement, which defines physiotherapy as a clinical science of human movement, and enables us to provide interventions where there are malfunctions, or promote movement where there is tendency to do so, or enhance performance of movement where it is required. That thing that is tied to physiotherapy as the clinical science of human movement is central to our calling, central to our profession, but we do not seem to understand and harness it. There are obvious limitations in doing so. And so it makes us, when we come to our classes, when we come to biomechanics class, we listen to biomechanics taught to engineers and not to clinical biomechanics, which is biomechanics taught to clinicians who have the relevant information that applies and derives from physiology and connects to human movement. It also affects our knowledge and behavior towards kinesiology. The two are not the same. But because we are not trained the proper way, we don't even see the value of them. But I am going to take you, by the grace of God, through those values, starting from the basic, which is the physiology, that connects and defines these other ones, and on which these other ones are built. And if we have this at the back of our mind, then it is difficult for us, it is now easy for us to progress into other dimensions. And that is the information that you need to have. I want you to take your mind back that, everything we have said so far has a key message. Everything we have said so far, there is a key message to all of them. And I don't want you to be oblivious of those key messages. There is a key message to everything we have said. What is the key message? What are we communicating? What we are communicating is that there are things we need to know that is fundamental than what we already know. I would like you to challenge the common misconception that clinicians have about movement analysis. It is not observing posture. It is not identifying gait deviation. It's not describing compensation. It's not documenting abnormalities. These activities are important, no doubt, but they are not movement analysis. They are movement description. They are not movement analysis. They are movement description. True movement analysis begins when we ask, why? Why is the patient moving this way? What physiological process might explain this observation? What system is limiting performance? What threshold has been challenged? What reserve has been depleted? So if you suppose a patient demonstrates a trunk lean during walking, if you use a descriptive approach, it will simply say that the patient demonstrates a trunk lean. That's all. And that is what you will see in most patient folders. The patient walks demonstrating a trunk lean, or the patient walks leaning forward. It is not analytical. It is just a description. An analytical approach will ask why. The possible explanations will be, why is he leaning forward? And it can either be because there is the hip abductor weakness exists, or there is pain avoidance, or there is fatigue, or there is reduced balance, or there is reduced confidence, or there is reduced reserve, or there is compensation for joint loading. Any of these things could be it. The trunk lean itself is not a diagnosis. The trunk lean is the clue that gives us an insight into what is happening. So the new definition that you need to know is that when you are dealing with situations like that, movement analysis is the process of using movement observations to generate physiological hypotheses. So movement analysis, I want to define it based on all we have said so far as the process of using movement observations to generate physiological hypotheses. This is the shift that you need to have from observation to reasoning, from mere observation to clinical reasoning. The clinical reasoning pathway is therefore clearly defined before us. Every movement observation should trigger a structured reasoning process. Every type of movement observation that we have should trigger in us a structured reasoning process, which I have shown you in the tables before. I call it, based on my works, movement to physiology clinical reasoning pathway. Movement to physiology clinical reasoning pathway. You must be conversant with movement to physiology clinical reasoning pathway. Everybody must. It simply means that movement observation will take you to physiological hypothesis. And physiological hypothesis will lead you to impairment identification. Then impairment identification will lead you to threshold determination. So you know which threshold is being challenged or exceeded. And then it will now lead you to the rehabilitation strategy that you will design. You cannot make prescription without understanding this pathway. So you must be grounded in movement to physiology clinical reasoning pathway. That is what you need as a movement scientist. So you make observation first, and everything comes from it. If a patient, for instance, pauses while climbing a stair, what are the physiological hypotheses you can derive from that? Based on the threshold you already know. The physiological hypotheses are something like cardiovascular limitation, ventilatory limitation, quadriceps weaknesses, pain, reduced confidence, which has to do with cognitive dysfunction. All of these are physiological hypotheses that will arise just by mere observation, a movement observation, that a patient could not climb the staircases without pausing. Once he begins to pause, these are the physiological hypotheses that will arise. Now, further assessment determines which of them is the dominant factor. Only then do we prescribe intervention, and not otherwise. Why does this matter? Too often, clinicians prescribe exercise before even understanding the physiology. Whereas exercise itself is based on physiology. That's why you have exercise physiology. Exercise physiology should also tell you that interventions are based on physiology. And therefore, the movement dysfunction for which you are making the exercise intervention should also derive from physiology. But we rarely pay attention to that. So movement analysis helps us identify what is limiting the movement, why it is limiting that movement, and what must be targeted. So movement should not merely guide diagnosis. Movement should also guide intervention. That is the point we are trying to make. That we have to use movement to identify physiological limitations. So you have to examine how different movement patterns may point towards specific physiological limitation, because movement is the end product of something happening at the background. And that thing happening at the background connotes to a physiological alteration or physiological changes, which could include also physiological limitations. If you look at the movement pattern 1, where we talked about the various levels, step 1, step 2, step 3, step 4, you see a patient shows dramatically, when the patient slows dramatically after several minutes of walking. Even individuals who are normal, they slow after several minutes of walking. Like I have given you example, those who have gone shopping. What is the possible physiology when you see that? Reduced aerobic reserve is one of them. Low ventilatory threshold 1 is one of them. Cardiovascular disconditioning is one of them. You may even see that in cancer-related fatigue. When you come to movement pattern 2, where patients demonstrate increasing trunk sway. The possible physiology or physiological hypothesis that may arise is sensory impairment, vestibular dysfunction, reduced motor control, or neuromuscular fatigue. If you look at patients who have movement pattern 3, the patient develops a limp, for instance, during prolonged walking. What is the possible physiology? Pain threshold is reached, and that's why that happens. Or tissue loading threshold is exceeded, and then you have protective compensation. If you look at movement pattern 4, you see that, for instance, an athlete who demonstrates deteriorating landing mechanics late in training or late in a football game. What is the possible physiological hypothesis? Neuromuscular fatigue threshold has been reached, or there is reduced motor control, or there is declining coordination. What is important in all of these things, these 4 categories of movement, and I brought them into 4 zones, which I showed you before, is that the same movement pattern may have different causes. That is why movement observation must always be combined with physiological reasoning. And so you have to move from movement analysis to rehabilitation decision making. You can't rehabilitate movement without doing an analysis. And when we talk about this in practical questions arise, how does movement analysis improve rehabilitation? That is a practical question we ask ourselves, and it is very simple. Movement analysis helps us target the correct physiological limitation. But when we begin to look at movement analysis as range of motion, as a short stride length, stride frequency, and that is it, we lose sight of the physiological basis and the physiological hypothesis, the physiological limitation that warrant it. Therefore, our intervention will not be targeted at those things. Our prescription will target at symptom, not the cause. If the problem is reduced aerobic capacity, then your intervention will be aerobic conditioning, and then walking programs that will enhance aerobic capacity, and endurance training, and you will see a change. If it is reduced strength, then intervention will be resistance training and progressive loading. If it is reduced motor control, then intervention will be movement retraining and neuromuscular exercises and task-specific practices. If it is reduced tissue capacity, then intervention will be graded loading of the tissue, or tendon rehabilitation itself, or tissue adaptation programs. If it is fear of movement, then the intervention will be education, graded exposure, and confidence building, which directly applies to the cognitive centers. What are we saying? Different physiological limitations may produce similar movement patterns. Therefore, treat physiology. Do not merely treat movement appearance. Treat the physiology. So 2 patients may walk slowly. One requires strengthening, one requires aerobic conditioning, but because they 2 walk slowly, but the physiology is different. You may need to give one strengthening, whereas the other one, the physiological hypothesis involved is aerobic conditioning. So movement analysis will now help you to determine which one is it, which of them, where, and you apply the threshold, the physiological threshold, to determine that. And you apply that and couple them up with your other analysis of the biomechanical function. So I want you to have a final reflection on the future of movement analysis. Let me conclude this session. And I would like to leave you with a challenge. Tomorrow morning, when you observe a patient walking, when you observe a patient climbing stairs in your clinic and in your hospital, standing from a chair, a patient you are observing, or reaching for an object, I want you to think differently. Do not begin with what movement am I seeing? Begin with what physiology am I seeing? And then ask, which physiological threshold is this person approaching or challenging or exceeding? I want you to follow me as I recapture and recapitulate the key concepts which we have been discussing since morning. And these key concepts are just simple. Movement is not simply motion. Movement is biology made visible. Movement reflects physiological reserve. Movement changes when physiological thresholds are crossed. Movement compensation often represents adaptation rather than failure of function or failure of physiology. Movement analysis is therefore the science, the acts, the ability of identifying physiology through movement. Therefore, for me, whether an individual has a shortened stride, whether an individual has a trunk leaning forward the trunk when walking, or pauses on the stairs when climbing it, or walks with a limp, or it has an inability to squat, or a need to use handrail. These are not merely movement abnormalities. They are physiological messages communicated by our system. The body is communicating to us. The clinician's role in this context is to simply interpret those messages that the body has communicated. That is what movement analysis is all about. I would like you to remember one sentence from today. Remember it all the time. Never forget it. Movement is the visible expression of physiology, and movement analysis is the process of identifying physiological thresholds through movement. If we truly understand that principle, our assessment will become more insightful. Our exercise prescription will become more precise, and our rehabilitation will become more effective. Thank you so much. This concludes my section 1 for this workshop. I will want to ask you to write down the following questions, and I will want your answers to them. What movement compensation do you most commonly see in your practice? What movement compensation do you most commonly see in your practice? Based on what we have been discussing now, what physiological explanation might underline or might underlie these movement compensations that you see? Number 3, which threshold do you think is being challenged in that context? Number 4, how would you or how would that change your rehabilitation approach? How would that change your rehabilitation approach? Now, I want to have response from you. If you have written down this, I want us to have that conversation. Because it will help.
Bro, they say you should repeat the question again, sir.
The question I'm asking, number 1, what movement compensation do you most commonly see in your clinic or in your practice? What movement compensation do you most commonly see in your practice or in your clinic? Number 2, what physiological explanation might underlie these compensations that you see? What physiological explanation might underlie it? Number 3, which threshold do you think is being challenged? Which physiological threshold do you think is being challenged? Number 4, how would that change your rehabilitation approach? Yes, can somebody talk to us on the basis of these 4 questions? I want to hear different people's perspective. You will speak to 4 of them, depending on what you observe. Based on what we've been discussing now and the new understanding you have, let's share insights together. Yes?
Hello, sir.
Yeah, go ahead.
Good afternoon, sir.
Good afternoon.
Yeah, I think based on the question, the movement compensation that I do commonly see has to do with trunk leaning to one side while walking. Then the likely physiological system that may be affected is the nervous system. And then the threshold being challenged is most likely tissue load, fatigue, and then cardiorespiratory system. Then the approach in terms of rehabilitation likely has to be with motor education, then cardiorespiratory conditioning. Thank you, sir.
Thank you so much. Now, what are you speaking to? Are you speaking to the movement itself? Is your intervention prescription coming from the movement that you have observed? Or is it coming from the physiology that you are observing?
It's coming from the physiology, sir.
Good. And so when you have trunk leaning, what does it tell you? Based on what you have said now.
Hello, sir. I didn't get.
You have been seeing trunk leaning. That is people who lean forward on their trunk. Yes. So what does it tell you again? Let's look at your physiology that you have provided. Yes.
Leaning to one side while walking.
Good.
Leaning to one side.
Yes. What could be the physiology?
The physiology has to do with the problem with the nervous system.
I agree with you. Yes. What again? Because it cannot just be only one.
Okay, then the musculoskeletal system also.
It's possible.
Yes. Then the cardiorespiratory system.
Leaning to one side. Why would you think that the cardiorespiratory system will come in?
Yes, because of the fatigue.
When you are now dealing with fatigue, does fatigue affect the trunk leaning in that sense?
It seems to.
If there is fatigue, what will be the first sign?
As the patient started working, he become restless easily. He
the
cannot achieve long.
We slow down, isn't it?
Exactly.
And when the patient begins to slow down, you are dealing with movement pattern 1. And the possible physiology for movement pattern 1 is that there is reduced aerobic reserve and there is low ventilatory threshold, and you are having cardiovascular deconditioning and possibly some kind of fatigue. You can see that in cancer. But what you are actually speaking to comes more under movement pattern 2, where you have patients demonstrating increasing trunk sway. Their trunk can sway, their trunk can lean, and you are dealing with sensory impairment, and I agree with you. You could also be dealing with vestibular dysfunction, and that's another sensory part, balance issue. You may be dealing with reduced motor control, and I agree with you because neuromuscular system, neuromuscular fatigue may come in. And I also agree with you in terms of fatigue, but it's neuromuscular fatigue. It has to be defined properly. So now you can see that you have defined the likely physiology. What intervention do you think you will give?
Cardiorespiratory conditioning.
Good.
Then motor education.
Good.
I think those are the two I can easily say.
Good. Now, are you seeing that before now, if you see somebody who has a trunk limb, what would you have prescribed?
I will have just prescribed maybe positioning.
Very good. Now, is there a difference in how you see it before and how you see it now?
Of course, sir.
That is the essence of this workshop. To make you, and I'm happy because you did very well. It's a journey. As you now begin to imbibe this clinical reasoning pathway, the physiology to movement clinical reasoning pathway, you become more of an expert. And you are going to have more of the right working tools. The moment you see a patient, already you have categorized the movement pattern. And you are already looking at the physiology. You are already looking at the thresholds. And you're making your prescription in the proper way. You will see a better response than what we normally used to do before. So thank you so much, Suleiman. Thank you so much. Is there anybody else who may want to share?
Yes, sir.
Yes, Silas, please.
All right. Mostly we see circumduction gait after stroke. That is due to perhaps weak hip flexors, knee flexors, or ankle dorsiflexors, or it could also be due to impaired motor control. I think threshold that is being challenged are the motor control or limb clearance threshold. And in the rehabilitation phase, I think I'll integrate gait retraining, neuromuscular education, dorsiflexion strengthening, and the likes of them. Sir.
Okay, let me ask you, in those patients who do circumduction,
yes, sir.
Is there a tissue damage?
Yes, sir. Neuromuscular tissue mostly.
Is it tissue damage that led to tissue damage of the lower limb that led to the problem?
No, sir.
Are you following me now?
Yes, sir.
Very good. So what physiology do you think we are dealing with here?
I'm confused now, sir.
No, you don't need to be confused. You are doing well. Because now, this limb is normal. Where the problem has happened in stroke is in the brain, isn't it?
Okay.
Good. And when we begin to give interventions, there are interventions we give to also target the brain, and there are interventions we give to the lower limb, isn't it? Because, yes, I mean, we are seeing circumduction, isn't it?
Yes, sir.
So what movement pattern does it fall under? To me, it falls under movement patterns that we are dealing with, movement pattern 3. We are looking at maybe those who also work with a limb during prolonged walking, or those who have a mismatch in their loading. So we are dealing with possibly the physiology, like you did mention. You could also have, if you do it over a long time, because of loading in that. So we are going to be dealing with maybe pain threshold is being reached. Maybe you have the tissue loading threshold being exceeded because the person is not able to control the loading anymore because of that problem he has. So the loading of the upper limb, how much weight he carries on one side and the other one, is not as he should be. So he has to adapt a protective compensation and also a functional compensation. And therefore, the way to do it is to now begin to secondump, So if he doesn't do secondunction, that protective compensation, if he doesn't do it, the way the tissue loading will be too much because it will exceed the load requirement for the muscles of the lower limb, and they will collapse. So if they will cause more injury. So there will be a misrelation between load and the available muscle strength to influence it. So if you have that at the back of your mind, that tissue loading is the issue, it means that when you are now, so that compensation you are seeing is not the main issue. That compensation is a protective compensation. And so what you need to now prescribe is how to manage that load. You have to improve the muscle strength, and you have to also redistribute the loading in such a manner that the tissues are not overloaded on that side. And you have to bring in the activity of the muscles that need to carry that load. And once they come into kick in and carry the load, the joint that is supposed to be squeezed and compressed is relieved. And therefore, you can now have the patient move in a better way than he was doing before. This is one of the story, but it's a multi-system thing. So you have to look across the system, across the physiological system, to see which part plays a role in that loading process, starting from the brain, the sensory system, to the motor system, to the... Are you getting the point I'm making?
Yes, sir.
But you see that now your assessment and your integration becomes more profound, and you will now be looking at specific physiological thresholds, and those thresholds will be those that are before VT1. So you are looking at the person operating before VT1. The issues happening there are before VT1. They are likely to go into motor control issues. I don't know if you're getting my point.
I'm getting it, sir. Loud and clear. In
fact, are you seeing the beauty of movement analysis? But we get so scared of it. We get so uninterested. We get so, oh, this thing is too abstract. It's not. It's not. More mellow. I can see you raising your hand. Solomon, you can go ahead.
Yeah, good afternoon.
Good afternoon.
Sorry to disturb because we are still answering questions, but let me proceed.
Okay.
My field is prosthetic and orthotics.
Yeah.
And during my training in Tanzania and South Africa, we do more of gait training analysis with a patient with a prosthetic limb, either prosthetic or orthotics. We try to do the analysis of the gait pattern, even though not in detail as it's supposed to be, but we're exposed to that as early as possible. So the point I'm trying to make, because I've been listening to your topic, your presentation, how do I channel this to my practice as a prosthetist and orthotist? Because I know that an individual that might have a stroke, physiotherapists, mainly you guys work on an individual that the body is intact. Maybe due to one problem, he has a disease condition. But in my scenario where somebody is amputated, and what led to that amputation is just maybe something like trauma. It's not, it doesn't have any neurological problem, just the trauma occurred to the person and the limb is amputated. How can I implement or apply this Keinovo practice in my profession?
Okay. That if you listen to me, you see what I said.
Yeah.
What we have is multidisciplinary practice.
Yes.
So that you come in from the aspect of your profession, and then the other one comes in from the aspect of their profession. Now, if you look at the things I've been saying as a prosthetic and orthotist, you will see that you will be challenged very severely. You'll be challenged if we go deeper, because the foundation, your physiological foundation is a bit different. Just like you mentioned, the physiological insight you have is a bit limited. It is just sufficient to enable you see the patient, design the orthotics, the CAFO unit that matches properly, and have an understanding of the biomechanical forces that are at play and how they can be distributed to have a functional CAFO system. That is knee ankle foot orthosis. That is functional and that meets the biomechanical demands of this patient.
Yeah.
But you will have limitation in the clinical sciences. Because in the clinical sciences, that is where you now begin to deal. Remember what I said about physiotherapy is the clinic, it deals essentially with the clinical human movement sciences. That is essentially what physiotherapy is all about. Yeah. So they are able to integrate the anatomy, the physiology, the biochemistry, and the molecular basis, and then align them to form. But in this case now, we're dealing with the physiological theories. So they do a lot of physiological theories. They deal into neurophysiology, the physiology of systems, and they can do system integration because of that wide variance. And then, of course, exercise physiology. Yeah. And then also grounded in clinical gait analysis, because your own clinical gait analysis, your own data analysis may not essentially be clinical gait analysis, it may just be biomechanical gait analysis.
Yeah, very correct.
Yes, but that is different from clinical gait analysis. So, and in the realms of biomechanical analysis, you are able to put the CAFO and see whether it is able to align and whether the forces are distributed. You look at the kinetics and the kinematics, and then you are able to say, okay, that's fine. But then a physiotherapist will integrate that into the clinical output that is desired for activities of daily living and calibrate it with clinical tools that reflects those functionality, and then put them under a model, either the ICF model or the biomechanical model or integrated system models that speaks to those functions that he desires, and then trains that patient to achieve that. And because he already has clinical outcomes and outcome measures that are pre-designed for those, he makes the necessary physiological hypothesis, and then based on the hypothesis, make his prescription, and then chooses the appropriate tool that marks, that speaks to those prescriptions applicable in that context to help the patient back to form and function.
Okay.
If you use your approach, you will provide assistive devices. But those assistive devices will now be turned from biomechanical instruments into instruments that has capacity to be utilized to restore the patient back to form and function in the clinical scenario. So you see that when you do your bit in your laboratory or in your workshop, then the physiotherapist comes in from the clinical sciences to do the other bit. So, but what I am doing now will help you to understand what the physiotherapist will do next. And it will also help you to understand whatever you are designing, how it will impact the physiology, and then how the physiotherapist will pick it up from there to channel it in clinical sciences to achieve form and function restoration, which is the key and ultimate aim of both groups. So you now, knowing that what you do will limit or will project into what the physiotherapist will do, means you need to know that you need to do your own part well, and the physiotherapist also will pick up from what you have done and complete the cycle. The patient is at the center. So what we are saying now will benefit you. so that you no longer begin to see patients who present with movement dysfunction, because yes, they are normal in the sense that there is no pathology before that time to you as a biomechanist. But for a physiotherapist, somebody who has been amputated is not normal. There is a movement dysfunction which speaks to abnormality. However, what is the change in physiology that has resulted? He now begins to look at the central pattern generators of motion. You know, the central pattern generators are oscillators. We have them. They are a network of neural structures in the spinal cord, and they are capable on their own of independently generating movement depending on the pathway that is stimulated. They are centers of automatism. You have those that are delta and you have the alpha, stimulating the extensor and then the flexors. But when they do, they are able to move the limb and then through the prospinal neurons impose their reading on the cervical generators you find in the upper limbs, which are slower oscillators, and then send ascending signal to the primary motor cortex. And from primary motor cortex, you have signals going down to the cerebellum and also triggering activities of the basal ganglia and the substantia nigra. The substantia nigra pars reticulata and the substantia nigra pars compacta. The two now relay, after processing the information through the agency of dopamine, dopaminergic pathways, now relay the output to the globus through the fenestra ovalis, which is a round window in the thalamus, which is a relay station. And from the projections of the fenestra ovalis, they go to the primary motor cortex and they form the corticofugal system. And then trigger the emboliform nucleus, which are deep nuclei you find in cerebellum, and the interpositus, the dentate and the globus. And then the descending trackway from the red nucleus through the pons, that is driving centers, the pons, the subthalamic nuclei, they now go down again to influence and fine-tune these centers of automatism, which we call the central pattern generators. And you now begin to see a fine-tuned movement, working pattern emerging as a consequence of this neurophysiology I have defined. These are neurophysiological processes. But they now define the ultimate movement. And if I don't have an insight of the neurophysiological configuration of the body, I will never be able to understand the emergent property, movement as an emergent property of the physiological system. So I need to calibrate these systems at different points as a physiotherapist. But as a biomechanist, you only understand and work within the area of the assistive technology. But do not think that it does not matter. It is very key and important, because if you put the wrong autosis, then how will we fine-tune it by feeding into the system will not give the exact result. And if we conduct clinical analysis of the basal gait parameters, we will not be having anything close to normal. The two limbs will not be symmetrical. Distribution of forces between the two limbs will not be the same. The kinematics will not be the same. And in a symmetrical human gait, the two should be the same. Therefore, there will be some element of asymmetry. But that will be because the P&O did not do a good job. So what you do in that laboratory impacts what the physiology of the human body. And the physiotherapist will have a limitation on its own, just as a result of using your own orthotic devices. Therefore, sitting through this lecture, you begin to see that physiology is key. And what we do can impact it. The environment that it interacts with it also can impact it. And if you know that physiology is the key that we need to work with, to define, to understand, and to target in the interventions of the physiotherapists, and you, as an orthotist and prosthetist, can make a difference if you do the wrong thing, then you see that the physiotherapist output will rely on your own input, and at the end, the patient will either benefit or lose out. But everything is a teamwork. I don't know if it makes sense. Solomon, does it make sense? I can't hear Solomon. I don't know if he's still here.
I said that I can hear you, sir. Your answers are very clear. Because I know that, like in my place now here at Orthopedic Hospital Enugu, I work very close with the physiotherapist. In fact, before I can treat a patient that has a neurological disorder, who has been prescribed an ankle, any form of orthosis, especially knee ankle foot orthosis, I usually consult physio to guide me on the muscle grading for each muscle of the lower limb. That will give me an insight on the type of component I'm going to select. So, and I know that when if I get the proper assessment when it comes to muscle grading, I'll be able to select an appropriate component that will meet the need of that patient. And that will also guide the physiotherapist after their exercise, physical exercise or therapy. You will still put on this device to the patient for them to continue their life. So that was the area. But I know that when you have an amputation, the individual is, I hate to use the word not normal, but the individual is deficient in some area because of the loss of a limb or whatever it is that occurred to the person. So that was where I was trying to link up what is it that I'm picking up now and how am I going to imply it in my practice. But the direction you have taken me on this is clear. It's clear. It's quite clear.
Thank you so much. Thank you. This is why I love to have this kind of multidisciplinary workshop. So everybody is on the same, you begin to see these things from your perspective that enhances your operation and your function. And then you also see that no one skills or component answers it. It's a multi-system thing. And therefore, rehabilitation professionals are better off when they think in the same manner and from the same their original perspective, knowing how this blends into this and how the other one blends into that. And so I'm quite happy that this is a multidisciplinary workshop and we are all here together looking at it. But the beautiful thing that we have done today is that we are now beginning to think differently. That whenever we are considering movement, which the orthotics devices or the prosthetic devices will assist or will enhance, we should be looking at that movement not from the position of the biomechanical parameters that define it, rather from the physiological basis that inform it. Because whether in health or whether in the compensatory zone or when there is complete failure of the physiological thresholds, in which case there is a serious functional deficit or functional collapse, you begin to see that physiological thresholds are tied to movement. Physiological thresholds are expressed in movement. And if you use assistive devices, it has implication. It means that it can actually feed into the physiological mechanism and it can strengthen those mechanisms, the way they behave. It can change the way they connect. It can change the factors that weigh one way or the other at different thresholds, either positively or negatively. But the idea of assistive mechanisms is to make sure that the physical parameters that support the locomotor system are as near normal as possible, so that the physiological mechanisms, when they express themselves, can leverage the locomotor system to bring the emergent movement that is as near normal as possible to allow for functioning. Because the key point is that most of the movement challenges we have are not as a result of movement abnormality, but as a result of functioning, movement functioning. These are two different things, or what we call movement reserve. And so, the impairment or lack of a limb will affect movement reserve one way or the other, because they pose a lot of challenge to the physiological threshold. And with the assistive devices, we help to remediate and that is just the point in all of it, So I'm happy that we are all looking at it from those perspectives. For somebody who walks with a pair of crutches, for instance, you will see that the physiological thresholds are challenged. And even if he walks without those crutches, it is even worse. So the crutches are now assistive, but they are modifying the physiological threshold. The physiological thresholds now interact differently in the presence of the assistive device. And therefore, the physiological demand on the metabolic equivalent, which translates to perceived exhaustion on the Box scale, and which also transmits to the talk test, and which have implication for the maximum cardiac output, and eventually the movement output. You see that there is a change and variation. Just because you have now used an assistive device for somebody who may have polio, or somebody who may have some of these deficits in terms of the structural challenges they have. So you see, even those who have injection palsy and so on, or who have some form of ataxia and so on and so forth. So you see that, or even those who have amputation. So you see that those situations, the physiological thresholds that are expressed in those situations, they vary. And the way they affect the functional reserve, which these people function around, the functional threshold, the physiological threshold they function around, can be altered just by the assistive devices, by P and O's you give them. The physiological mechanism will change, and the emergent movement properties will also change. And it changes for better or changes for worse, depending on what we have done. But having this understanding now makes the P&O person to now see the need to make sure that everything comes as near normal as possible when designing these instruments, and knowing that they have repercussion on how the physiological mechanisms are reorganized in the presence or in the absence of those assistive devices. So in the next segment, we'll conduct an analysis of motion to now see these physiological thresholds expressing themselves in movement, and then interpreting those movements to know what they mean, and then linking them up to the physiological thresholds again to see where a need for prescription arises and what type of prescription you may need. But if you follow very well, the foundation has been laid. You see how we're able to categorize these movements into four and what they speak to. And you see the framework we have also developed that will help clinicians and also help movement scientists generally to have an understanding of certain expectations as driven and defined by the physiological mechanism. So the bottom line is that movement is just the visible biology. And that is the key take home. And so whatever we do, we be affected by whatever we do, will be determined. Whatever we do, the efficacy of it will be determined on whether we have made the right diagnosis or the wrong diagnosis. You see what Solomon said when he wants to build a CAFO, he wants to get the feedback from the physiotherapist on the appropriate charting of the muscle strength, because without that, anything he does in order to address the challenge the patient have will be a mismatch. You see? So the physiological system which expresses itself in muscle strength, and that is key. And eventually it will express itself in movement, and that is key. So we begin to see movement not as the cause of a problem, but we see it as the end product of the physiological process. All right. If there's any question, there's any comment, then we can take it. Otherwise, we can take 10 minutes break and then come back, and my assistant, Dayo, will introduce you to Kinovia. And we're going to use Kinovia to drive, do some kind of analysis. You will see how movement is now recorded. But remember, when you are seeing this movement, what you should be seeing is not the movement. You should see the physiological thresholds that inform it. You see the biology behind it. Always think biology. Always think physiology. Do not think the movement. Think the physiology. All right. So, what's the time now? Yusuf, are you there?
Okay, Prof, I don't think he's actually online now. So the time is 2:37. So by 2:47, we'll be starting the second segment of this. And then probably after that, we might finalize, and then we'll now wait for the hands-on and the physical components of this workshop. So we'll come back by 2:47 for the second part. And I beg our indulgence, and I also plead with us that we should join the meeting early so that we can actually won't miss track of the details. So we won't be lacking behind when we start. So it's better we start from the beginning than actually joining in the middle, because when you join in between, you might actually be confused. So thank you so much for staying from. I can see almost 70 participants still online. So thank you so much, and with that, you'll be taking like 10 minutes break. So this is 2:38 already. So by 4:30, 2:48, we'll come back. Thank
Please,
you.
I want to plead with everybody who has been here to please do not go away. Please do come back, because you are going to learn a lot. And if you are not here from the beginning, you may have difficulty learning and building on the other ones. And I hope somehow that what I have said so far would have helped you, and what you will hear in the next segment will even help you more. Our journey, our belief is that rehabilitation scientists, movement scientists, working together can create an impact and a difference in the hospital, and we can unlock the potentials that we have by virtue of belonging to our professions in the rehabilitation sciences to make an impact in the hospital setting, that we make our services more desirable and our impact more visible, and fulfilling the mandate for which our profession was actually created. And so that way you find fulfillment, and it transforms our practice. And believe you me, when we have the depth of the scientific knowledge, when we have the grasp, other health professionals will respect what we do. And our practice will become less of technicians and more of scientists. And so we begin to speak in the language that the human body understands, basically speaking to the physiology and linking it into the multi-system expressions that we now define in the context of movement. So please do come around in the next segment. It's going to be very exciting. And I want to also have your feedbacks from this first segment. You can drop it on the chat room, and it will help us to recalibrate the next segments. Sometimes I feel bad when I'm called to teach movement science in a one-day workshop. Sometimes I don't know, because you can't teach movement science in one-day workshop. You know, we have just touched one of the few, in fact, one of the basic, not even everything basic, just one aspect. And it has lasted from morning till almost 2 p.m. Now, by the time you finish this other one that Dario will be coming in to give, you may almost hit 6 p.m. Then the next one that I should come to build on is gone for the one day. So, but never worry. There will be various phases of it. How I wish that those who are here will also be in the next one whenever MROTB calls for the next workshop. Then we can start from that. But the challenge you have is that you may have two almost different persons attending at that time. And when you start from where you stopped, they will be confused again, and they want you to start from the beginning. And so this sort of thing is always good when you are having this sort of workshop. You know that it's going to last for maybe 5 days. then you can build. You see the beauty of it. You can see what was done yesterday, how it builds into the next one, how it builds into the next one. And, we try to make it very easy to apply in our clinic, in our assessments, and then people can take something away from it at the end. But then I'm happy that this is recorded via YouTube, so you can have some of these things, you can revisit it, and you can watch it again. And maybe the next time I will not go back to this one. I will not teach it again. I'll go to the next phase. But let's run with the Kinovia and see the movement analysis per se, and then we interpret it, and then before we can come back again to now begin to link it to these physiological thresholds that we have been discussing. So it will be exciting. I'm just saying this to spice it up and to encourage you not to run away, but to come back at the end of this session. Thank you so much. 10 minutes. Dayo, what's the time?
Thank you so much, sir. So this
Thank
is
you.
2:42.
Okay.
Yes, sir. We'll come back by 2:52. Thank you,
Okay.
sir.
All right.
For those just joining us, please, we are going on a break for 10 minutes. So we'll be back by 2:52.
Thank you, sir.
You're welcome. Oh, no, you're welcome.
Thank you, sir.
We've had a very impactful session with Professor. We're so grateful for everything, sir. And for those that are joining us now, there's no problem with the audio. We're just on a break. So we'll be resuming by 2:52. But you don't have to log off. Just stay on, please. Stay on since it's just some few minutes left. So we're coming back by 2:52 for those that just came into the meeting.
Wanda ɗan kwana kira ne ban je ba ɗaya da. So I wanted to. Na ce kwana biyu. One like you. Ashe Abuja ne. After the signal, the illness, you decided to stroll to. Ko kuma in the midst of the illness sai kin yi karfin hali don kada ce ina irin wannan mama na warke ni zan iya zuwa.
Mr. Edward, we can hear you. Please mute yourself.
Please, are we back?
It's time, but we're waiting for the presenter.
Okay, thank you.
Okay, distinguished colleagues, thank you so much. As we come back to the second session, I hope we have been able to stretch our muscles, been able to freshen up a little bit, take a sip. I wish we could give longer time, but because of the nature and the time constraint, it's better we start also to catch up. So, like I did mention, this second section will involve a hands-on, and I hope most of you are with your laptops, because now we are going to demonstrate. We're going to straight up download the Kinovia software. I hope some of you have been able to download that before. I hope that information has been passed on your WhatsApp platform. And then we're going to have a demonstration of the analysis. Unfortunately, the recording of the movement will be done in the step down workshop that is coming up, because you need to be physically present to use just your ordinary phone, your Android phone, and they stand to record the movement. Normally, I want to set the tone by saying that we normally analyze movement in 5 speeds, and these speeds are self-selected speeds. The mistake most instruments make when they analyze speed is to analyze speed only analyze movement only in one speed. And some of them will say walk normally, and as you walk normally, they analyze the speed, and they use that to make clinical decisions and the prognosis and even diagnosis that encompass the functioning in all activities of daily living. Activities of daily living are executed at different movement speeds. Some are executed in very fast, some in fast, and some are in slow, very slow, and normal walking speeds, or sometimes even in running. Therefore, if you measure and design a tool that can only capture capture normal walking speed, what happens? How do you now project that when people in their activities of daily living walk very slowly, in the context when they walk fast or when they walk very fast? You will see that we have a blind spot there on what is happening with the neuromuscular configuration, which are driven physiologically, because the neural drive is a physiologic process, and walking is is actually under a neural drive. Human walking is programmed in the spinal cord. The basic program is located in the central pattern generators, the CPGs, which I spoke about a while ago. And if it is a neurally driven process, which is explained using the reflex chain hypothesis postulated by Sir Walter Sherrington, even that reflex chain hypothesis is giving a clear event, even though the way he explained it seemed to suggest that only sensory input from the environment is what actually results in the movement. However, it has been beefed up by the works of Greiner, Ballesteros, Weber and Weber, Ekokoro et al., and so on. But what they simply said is that there are a network of neural structures which are intrinsic and located in the spinal cord that is responsible for walking, and which stepping is the basic unit of walking. And this network of network of neural structures with the CPGs are 4. That is a pair called the lumbosacral generators, located around S4. and a pair called the cervical generators located in the cervical vertebrae. But they communicate with one another, and they are also entrained by the drive centers. The drive centers are located in the brainstem. They are the ones that entrain the central pattern generators. But the central pattern generators communicate with one another via the prospinal neurons. And so what simply happens is that if you calibrate the neural system, then you can also effectively determine the emergent movement that arises from it. That is just the bottom line. So in essence, movement is an expression of the physiological processes that arise from the activities of the central pattern generators. And if we have that at the back of our mind, so when we now analyze walking, we analyze walking in that sense. But these activities, which involve, of course, you know, the basic neural processes, involves action potential. When you attain the threshold, there is a discharge, a depolarization. And then after it has depolarized, it will now repolarize again to discharge in the next cycle. This is the basic physiology. And of course, for muscles, you are looking at, I think, minus 70 millivolts. And then for other tissues, you even have up to 120 millivolts. But the point I'm trying to make here is that if you understand that there is a connection between this neurophysiology and the movement, you will see that movement, when you increase the frequency of firing, the frequency of discharge of this neural activity, the vigor of movement is altered. And then it weighs heavily on the locomotor apparatus. The lower limb, the upper limb, these are just apparatus. These are just the structure, the frame that carries the movement, executes the function. If this frame that executes the function, the human frame, the musculoskeletal system and all the supportive structure that execute this movement, if they have challenges, those challenges, there are some challenges that will be obvious in slow movement, but not obvious in normal movement. They feel more challenged when you move slowly. And there are challenges, the system, there are circumstances, depending on the physiological threshold we are talking about, that becomes more challenged in very fast motion. Because the behavior of the physiological system are different. Do we have what we call applying the laws of mechanics to human body? The limb length, you know, all of us have pendulum clock. The pendulum have a length designed on its own. Once you for every specific length under the gravitational force field, the pendulum will keep swinging. Once you have a natural pendulum length, it will keep swinging at that rate endlessly without a battery. The human body is like that. The limb length will determine the pendulum rate of swing, the natural pendulum rate of swing. And the natural pendulum rate of swing of each limb length differs. But when you attain it, the energy demand, the energy consumption is minimized when you attain the natural pendulum rate of swing that is suitable for that leg. And you can calculate it using the laws of mechanics applicable to pendulum. So it is the same thing for the human limb. The implication of that is that when you now make the movement more vigorous by discharging the firing from the nerves, more energy is consumed beyond this natural pendulum rate. So when you pendulate above this rate, you consume more energy. When you pendulate below this rate, you also consume more energy. Because if I ask you to walk from here, from where you are now, to a shopping mall, you will work at your natural pendulum. That is why you are comfortable. So you burn little energy. So you can walk there and come back. But if I ask you to walk very fast for 1 mile, at a point, you will begin to get fatigued. The physiological reserve, the movement reserve, there will be a change. You begin to, the thresholds will change. You see, just like I have explained in the previous session. And what will your system do? Your system will begin to resist. Naturally, you walking at that rate, we want you to revert back to what is more comfortable. Because that change in the way you and manner you walk under a neural drive, under a physiological mechanism that encourages you to do so, creates problem for the system. They can't sustain it because of the energy demands. And so the tendency for the system is to revert to always that which consumes less energy to achieve to realize the tax demand. So the system will always revert back to whatever makes it to spend less energy. Now, if I ask you to walk slowly below that natural pendulum rate of your leg swing, you will be doing a false, it's artificial, because you are now going to use your muscle contraction to deliberately hold your limb from swinging the way it should naturally swing. You want to reduce and retard it so it swings below that frequency. And that's what happens when you see these advert people. You will see them dressed in green, white, green, and some chalk here, white chalk here and there, and you see them walk in in slow motion. If you have tried that before, trying to walk very slowly, you will see that in the next 3 minutes of doing it, you get exhausted. Yet you are not walking very fast. Why are you exhausted? Because you are now using so much muscle contraction to hold your limb in the air, so that he swings very slowly at your desired slow speed. But that speed is artificial. It is below the natural pendulum rate. You are the one creating it. But it exposes something to you. It exposes that your system cannot support it. Now, there are conditions, there are sicknesses, there are illnesses that make us walk below that natural pendulum rate. What happens to the system in those illnesses is that they consume too much energy, and therefore they are unsustainable. Therefore, the physiology, the threshold, the physiological threshold tells us that in such illness, that patient may collapse. If we stretch them for too long, there may be a system failure, complete. And this is something we have to guard against. Therefore, always we try to explore movement at the full spectrum of human walking, so that we see how the system behaves when we force it to swing below the natural pendulum rate, and when it swings at the natural pendulum rate, and when it swings above the natural pendulum rate, it will unmask neural dysfunction. It will unmask where they exist. And therefore, you are able to better calibrate the system and prescribe interventions that will address such types. And that is why time up and go test, which is designed to measure balance, is not really effective, because it is sensitive, but it is not specific. Therefore, it's not a good discriminator of those who have balance dysfunction. Therefore, what seems to have a better, and which we demonstrated in our publication, based on the physiological threshold knowledge and understanding, what seems to be a better balance is what a better predictor is stride length and stride frequency, because these two parameters create a product we call velocity. When stride length is multiplied by stride frequency, we have velocity. And when you now use velocity as the product of the movement output, so the entire movement is reflected in velocity of walking. They create the output, totality of output is expressed in movement velocity. For instance, if you have a stride length of 2 meters and a stride frequency of 5 strides per second, you are going to have a velocity of 10 meters per second. That is 2 times 5. But if you have a stride length of 5 meters and have a stride frequency of 2 strides per second, you will still have a velocity of 10 meters per second. But have you seen that what informed the same 10 meters per second are 2 different things? In one, stride length was 2 meters. Stride frequency was 5 strides per second. But when there was a change in the physiology of the body now increased the stride length to 5 meters. The stride frequency compensated by reducing to 2 meters in order to give you that same 10 meter. So it means that under constant velocity, the 2 variables can compensate for one another. The stride length can compensate for stride frequency, and stride frequency can compensate for stride length. But when you have functional failure, these 2 parameters will experience a physiological limitation. They are not able to compensate for one another. And how do you know you have experienced it? You use what we call the stride ratio. The stride ratio is the ratio of stride frequency over stride length. And if the stride length increases relative to stride frequency, then the stride ratio will not be the same. But the neuromuscular configuration that underlies the entire drive from very slow to very fast is always the same. That stride ratio is always the same. Whether you are running, whether you are walking very fast or walking very slow, the ratio of stride frequency over stride length is always the same when you approximate to the nearest whole number. But the moment the physiological configuration changes, they will no longer compensate for one another. And therefore, that stride ratio will not be the same. What you have in stride in slow walking will not be what you have in fast walking, and will not be what you have in normal walking. There will be divergences. And that speaks also to your prescription and gives you an insight into what is wrong. So you will use the emergent property, the emergent movement property, to understand how the system, the neural system, the physiological system was calibrated or recalibrated under different movement task demands. So the physiology that informs them are different. And the language the body speaks to us is expressed in the parameters of human walking. The basic parameters, when you hear parameters, it seems as if we are saying something big. Don't mind these languages I speak. I am sorry. Sometimes I speak the language of movement scientists because that is something I've been doing for quite a while. But please don't be carried away by them. Don't think that I want to use simpler language so you can relate to what I'm saying. What we call parameter is just variable. I'm sure most of you are researchers, so you know variable. Or you will just speaking to those quantity that make us that explain human walking. Human walking is explained by velocity. That is the speed of walking. It is the ultimate thing that explains the nature of human walking. So when you are walking very fast, when you are walking very slow, when you are walking very normal, it means that 2 key variables are defining it. Those 2 key variables that define it is stride length and stride frequency. That's all the grammar I've been saying here. 2 key variables, and we will calculate them. You will see them now. The 2 key variables that define them is stride length and stride. What is stride? What is stride length? You will understand that when you walk, you take a step. That your step has a length. What is a step length? When you move, when you place your foot on the ground, if you place your right foot on the ground and then move your left limb and place your left limb on the ground, the distance from the heel strike of your right foot to the heel of your left foot on the ground, that distance is your step length. Now, if I ask you to walk over a distance of 100 meters or 10 meters, and I count the number of steps you have taken over that distance, I can also time the time it takes you to cover that distance. If you cover, for instance, a distance of 10 meters, you took 10 steps, and you covered 10-meter distance, and you covered it in 10 seconds. It means that I know the number of steps you have taken. I know it took you 10 steps to cover 10 meters, and you did it in 10 seconds. Therefore, it means that I know your step frequency. Your step frequency is number of steps you took you to cover that 10 meters in time. So 10 steps over 10 seconds. That means that your step frequency is 1 step per second. However, when we discuss, we escalate it to stride because we look at gait cycle. Gait happens in cycle. Human movement happens in cycle. We repeat the same cycle over and over again. If you place your right foot on the ground, placing it on the ground gives you opportunity to shift your weight onto that right foot. You shift it from the left foot so that left foot is free to swing in the air. You now swing the left foot and put all the weight on the right one. And then you swing the left one forward and in front of the right foot, and then you place it on the ground. Then you move your body weight again from the right foot, you put it on the left one, and then swing the right one. So it means that when you no longer is able to move that weight from one foot to the other, you can no longer walk. There is a system failure. But once you can move it and sustain it in order to enable you swing the other one, there is no system failure. You keep on advancing and you keep on making progress. Then the supportive structures that make it happen, we call them the locomotive structure, the musculoskeletal system. But they are driven by the physiology of walking, by the neural system that calibrates it. So we now begin to see the interplay of this system. What do they consider? If you are walking and the structures are not able to carry it, it means you are not safe. And so you may wobble when you put all your weight on one foot. It means that safety is compromised. In such situation, it could be because of muscle strength. It could be because of vestibular dysfunction. It could be because of cognition, not processing the information properly. It could be because of fear of falling, which also has to do with cognitive deficit. Are you seeing that different physiological mechanisms may explain why one limb may not carry the weight as the other one begins to advance? When we understand that physiology, we're able to deal with the problem that will lead to collapse when you are walking. However, if that tendency exists, it means that as you walk, safety is a concern. Then, if safety is not a concern, it means also that as you walk, you can increase the speed. So as you increase the speed, safety is compromised. As you emphasize safety, speed is compromised. Because whenever you observe that if you walk too fast, that you may fall, you reduce the speed and you enhance the safety. And when you think you can walk very fast, yes, sure you will. But then safety will be compromised because as you are doing this, you remember that the base of support has been reduced from 2 feet being on the ground to 1 foot being on the ground. Therefore, balance becomes a problem when you transfer all the weight onto one. So there is always a pull of the system, the physiological system, to find a balance between safety and speed anytime you are walking. And these things are organized in the motor planning. Remember, I told you about motor planning, how the brain plans it and how it is executed through the transmission from the spinal cord to the effector organs or the muscles. And the neural system plays a role, the muscles plays a role. The muscles are tied to the tendons, and tendons, the muscles, they tail into the tendon, and tendons are attached to the bone. And that the ligaments, you see them at the joint, bringing the joints together, binding the joints together and helping these forces to be transmitted. Ultimately, what are we saying? What we are saying is that we can picture how the neural system drives the entire structure to achieve movement. In doing so, two things come to mind: safety and progression. It means that if we understand these two things, we begin to understand how the physiology works. What defines safety is the stride length, but what defines progression is the velocity. Stride length needs to interact with stride frequency to determine the velocity. As the stride length is increasing, stride frequency is reducing, because in that equation, stride length times stride frequency is equal to velocity. It means that when we increase stride length at constant velocity, the stride frequency must reduce. So if we say, for instance, that we maintain constant velocity of 10 meters per second, however, we want to reduce the stride length because we want to walk very fast. It means that when we reduce the stride length, we reduce the stride length to 2. For instance, it used to be 5. We have reduced it to 2. For us to walk at the same velocity of 10 meters per second, we have to increase the stride frequency to 5. Before it was 5 and stride frequency was 2. And so when we reduce the stride length to 2, stride frequency will increase. And when we increase the stride frequency to 5, stride length will decrease to 2 if we want to maintain 10 meters per second. So that is the way the system is configured. There is always a compensation. The stride length will compensate for stride frequency if we want to walk at a constant velocity. Now, when we ask people to walk at 5 self-selected speed, at slow walking, at very slow walking, at normal walking, at fast walking, at very fast walking, what are our expectations? Our expectation is simple. We are expecting that the system at every point in time, if we wish to maintain a constant velocity, then we will have the same configuration. But the moment we say walk normal, it means we are walking at a specific speed. Therefore, the behavior of stride length and stride frequency will be constant for that speed. But when we say walk very slowly, it means the speed output has now changed. We expect that stride length and stride frequency will also change in order to correspond to the new speed. It will be according to how the brain interprets it and gives command. And when we say walk slowly, which is above very slow, is a speed faster than very slow, we expect that the brain also will change. We give a different command to the structures to enable the way stride length is created and stride frequency interacts to give us that speed. When we say walk very fast, we see the same thing. And when we say walk very, very fast, we are bound to see the same thing. So what is key in the two of them is that safety and progression will change. That is what stride length stands for. It stands for balance. It's an indicator of safety. So if we are emphasizing safety, stride length will begin to increase. Even when we are asking you to walk very fast, you find out that you cannot beyond a specific point. There is a limit to it. And this is tied to the physiological threshold, depending on the movement category pattern. The 4 movement category pattern we have already described. Okay? Now, when we study the stride length and study the velocity, it gives us an idea of the type of physiological behavior that informs the physiological mechanism or the physiological interaction across the systems that now presents itself in that movement. So when we see these movements, we think of the physiology. Is the physiology of the system leaning towards safety? Or is the physiology of the system leaning towards progression? When the physiology leans towards safety, it means that the system has recognized that what you possess is unstable and cannot sustain progression. Therefore, it will begin to put in place everything to compensate. You can go beyond compensatory mechanism to adopt other mechanisms, but everything it will do is to force you to emphasize and prioritize safety rather than prioritizing progression, even when we have given you instruction to walk very fast. You will still see that that is not possible. And when you now begin to look at the neuromuscular configuration across the entire spectrum of walking, in those who have this challenge, it is not the same. Because the systems, the safety and progression cannot compensate. So when we now define velocity, once we define velocity, the body will choose the proper nature of safety mechanism that can match that velocity, and also determine the proper nature of progression that is required to achieve that velocity. It expresses itself in the stride frequency and in the stride length. Understanding these two alone helps us to have an insight into the preferences of the physiological system that informs the movement pattern that we are witnessing. So what movement analysis does is that it will define and quantify this key variable. And once it tells you that this is the movement, this is the stride length, that the stride length on the right side, for instance, is shorter than the stride length on the left side, it tells you a story. It means maybe that on the right side, for it to be shorter, it is shorter because the system is avoiding putting load on it for too long. If it does, there will be instability. Therefore, the system wants to spend less time on the right and more time on the left, which is more stable. You see, you still advance, but the amount of time you spend on the two limbs are different. And the stride length tells us how much time you spend on that side in one phase of your cycle, and on the left side in the next phase of the movement cycle. They tell different stories, but these stories in themselves speaks to a physiological hypothesis. So what we think is no longer the movement that we see. What we think is the physiology that informs it. So you see some patients who walk with antalgic gait, that is, who walk with painful gait. When they walk with a limp. What does it tell us? If you measure their stride length, on the side they limp, you will see that it is shorter than the stride length on the side that does not limp. Stride length is a measure of balance control. It's a measure of an indicator of balance control, of postural control, a measure of stability. So it means that when the body begins to avoid the right side and spends more time on the left side, it is because there is instability on the right, and if there will be a fall at all, it will happen from the right than on the left. The physiology, the physiological drive of walking will change to suit the movement apparatus. So when there is a problem in the movement apparatus, the physiological language which is expressed in the movement itself will be different. So we need to understand that. And once we understand it, it means, oh, which category of movement is this? Does it have to do with tissue load? If it has to do with tissue load and threshold load of the tissue loading, then it means that we have the necessary prescription that suits it. And we begin to intervene in that wise, using the prescription suitable for that physiological threshold, as you have seen in the slides and in our previous session. So it makes meaning now to understand the nature, what the stride length and stride frequency is saying, and what the stride velocity, which we call the gait output, is saying. For us to understand what we is saying, we need to analyze it and then quantify them. And with that information, we can now raise a physiological hypothesis to know what the physiological system is saying and communicating to us, what is wrong, and how we can now solve it. So what you are going to see now is an analysis of movement and how we can use Kinovia to quantify this movement, to measure stride length, and may perhaps gain insight into even the angle of movement, which speaks to so many things. And then we can integrate all of these together to form an opinion of what the physiological system is communicating under different conditions and make prescription that speaks to them. Before, we normally simply go on to analyze. And after analyzing, we interpret it without recourse to the physiological basis, which is the key thing that we need to know in order to know the type of prescription that we suit. Now it is different. So we haven't done the first session in the morning. I expect you now to be thinking physiologically, thinking biologically. You don't look at the movement as the cause of the problem, but you look at it as reflecting and representing the cause of the problem. So you need to interpret what it is communicating so that you understand the root cause of the problem as expressed in that movement. Then you can now prescribe the appropriate intervention using these physiological thresholds we have discussed and how they tie up to the movement patterns. And so once you have that in mind, you are home and dry. Your prescription will be on point, your analysis will have meaning, and your prescription will be on point and it will be effective. This is something that we lack in the hospital, and that's what we want to do. So now you will see a recorded video and how you can use the Kinovia to quantify movement. And then we now use the same Kinovia to do a plot, to plot this movement and then interpret what we have plotted using the physiology, which enlightens us. And then we can categorize it based on the movement categories we have dealt with and use these thresholds to inform our diagnosis and then prescribe our intervention. I don't know how else I can say it. I wish I can say it in Hausa, in Yoruba, and in Igbo in order to make it clearer. But I'm available to continue explaining. And I know the hands-on session you will have, the trainer workshop that will be coming up next week or so, we even give better and more insight. But I'm available in the course of this demonstration to do this. So what you are going to see is Dio now doing the analysis. And so those things we have been saying in the morning, we go a step further. And so stay put and cooperate, use your system, and where you have issues, ask questions. We track back again to carry everybody along from beginning to the end. And then at the end, you will see what we will have achieved. And you can now, re-emphasize what we said in the morning using the parameters we can generate. We can interpret them, and you see how we interpret them and see how we can apply them to make for a better clinical outcome. So I invite Dio now to come on board and to present. Okay? Stay put, everybody. Dio, please share your slides and then come to the Kinovia platform.
Good afternoon, Prof. Good afternoon, everybody. Thank you, Prof, for this for that enlightful and resourceful presentation. I really appreciate that. And before I proceed, those that have been in the previous workshops, during the trainers workshop that took place in Abuja, will bear me witness that what Prof just gave today was entirely different from what he taught in Abuja. And I can actually assure you that over the past 1 year, we've been giving out different informations. Like, it's more like a prerequisite. Like, if you know this, it will link you to the other. So don't feel disconnected at this point. So wherever, whichever point or place you met us, you can actually join and connect, and then you can now start sourcing and start building on the ones you already know. Thank you. So I will be sharing my slide right now. But before, okay, my slide is up. And before I even mention this or go, can you hear me?
Yes, we can.
Okay,
Yes, we can.
Okay, thank you so much. So before we even go into Kinovia proper, we really need to actually understand the basis, because most times people will say Kinovia for gate analysis. Now, if you now mention and start taking them to other gate analysis softwares or how to actually analyze, most times they tend to actually feel lost and all. So gate analysis, probably like Prof actually mentioned in the morning, is that it's just like a complex, how to actually study the complex interaction between the musculoskeletal, neurological, cardiovascular, and sensory system. Now, this and most times clinicians often depend on just on observation and what they actually see, without looking at the subjective and how to actually quantify the value. For instance,
I'm sorry for the interruption, sir. There's a problem. Those on YouTube, apparently they can't see the screen. They can just hear the audio. I don't know if you can try to share the screen again once again. Thank you.
Just a minute. Okay, sorry.
So stop sharing and reshare, Dio.
Okay, you can try now and see if it's up.
Yes, it's showing in the YouTube. It's showing now.
Okay, thank you so much. Thank you so much. So like I mentioned earlier, most times we actually depend on just...
Your slide is not showing on this other side.
It is showing.
Is it showing on your... Is the slide showing on YouTube and Zoom platform?
Yes, it's showing both in both.
But yeah, I don't see that on the Zoom platform. I don't know about those on the Zoom platform. But if it's showing...
You can stop
showing, sir.
Yeah.
Okay, that's very good. Very good. Okay.
Okay, and the issue is that most times, just like Prof actually mentioned in the morning, is that most times we just depend on objective assessment, what we see and what we see, without actually looking at the objective subjective information. Sorry, they just depend on subjective information without actually objectifying and then quantifying those values. For instance, now you can see they can actually describe that this person is working with antalgic gait, hemiplegic gait, and other. But then, can you be able to actually quantify what is the degree of knee angle? What is the degree of flexion? What is the degree of extension? Then, what is the stride length? Because these are like the parameters that tells you if there's actually a true improvement or not. Just like most times you say, okay, there's a change, but now you don't know if the changes you are seeing, if it's clinically important and meaningful to this patient. It's just like, okay, there is a change. The person can walk like this. What if the changes you are seeing is just based on
normal physiological changes without actually having a true meaning to what the patient can actually feel or do. So that is why we actually started researching and started looking out for other easy softwares you can actually use for gait analysis and assessment, so you can be able to actually quantify whatever you're actually doing. And then one of the things we also found out, like, because one of the studies that we are currently doing, we found out that this gait analysis has been in existence even as far back as 30 years ago. Now imagine that in Nigeria, we are now still talking about quantifying gait analysis when probably has been in existence for almost 30 years. Now you see that probably we now studied, and then we are now trying to actually find it difficult to actually catch up with the technology and the recent development in healthcare and science. So in modern analysis depends widely on biomedical and functional parameters, which includes, and these are the parameters we'll be assessing to actually be able to actually quantify the level of improvement in this patient. So which includes the joint angle. So we'll be looking at the joint angle, even if we don't analyze it right now. Now at the step down workshop that will be coming up, practical workshop that will be coming up, these are the things we are expected to actually do. To analyze the knee flexion, extension during gait, hip abduction, during balance activities. Then if there is time, they can also do like shoulder flexion and all that. Then there is need for them to actually assess the temporal parameters, which includes the gait cycles duration, the step time, the stride time, the stance duration, swing duration, because all these things actually speaks to something. They all have what they're actually speaking to. So in analyzing them, you have to actually, there are some things you're looking at for. So then the most important is the spectral parameters, which includes the step length, the stride length, the walking distance, and the base of support. Now, and then velocity and the speed measurement, which includes the walking speed, the running speed, and all. Then postural assessments. So we have different categories of this gait analysis. So we have the 3D based motion.
Sorry, we are still in the first slide, though. We are not seeing the remaining slides.
This slide is not moving. I'm just trying to introduce the Kinovia. So when we start, the slide will start moving. So we have categories of this motion analysis now, which includes the 3D motion capture systems, where we have the Vicon system. Now, one of the reasons why we didn't actually look for or how to actually incorporate this kind of Vicon system in gait analysis is that to set up this Vicon system lab, it costs like millions of dollars, not naira, millions of dollars. So you see that it's very difficult for low resource centers like Nigeria and other to actually set up. So we also have like 2D video analysis softwares where this Kinovia actually comes in. And then we also have the Dartfish. Now, Dartfish and Kinovia also do the same thing because they are just video analysis software where you have to actually upload a video and you actually use the video to actually analyze these basic gait parameters. Now, but Dartfish is actually a paid software that you have to actually pay. And then most facilities will still tell you that they are still waiting for management to release funding for them to actually access or actually buy this or subscribe for this software. Now, but this Kinovia software we are talking about now is an open source software, free, and is available online. Just once you go to the Google Chrome, now you type Kinovia, which is Kinovia. So if you type this Kinovia, you see that it's open and it's free. You can easily download it, more like you're actually downloading any file online. Now the advancement of technology have advanced further, not just in this 2D video analysis. Now, the technology have actually advanced further to this markerless artificial intelligence, where we have the OpenPose, OpenCut, Deep Lab Cut. I'm now speaking to all these tech buddies in our midst now that are actually looking for how to actually develop applications and softwares. Now, these are the simple way you can actually get an API and then configure it. You just upload the video online. So it simply gives you an output where you see the stride length, the step length automatically without even looking at it. You just upload the video. So it's now more advanced than Kinovia, but I believe that with time, the advancement of technology in Nigeria will still give us the room to also flow with this technology. Now, let's look at the Kinovia software itself, because I wanted to just try to actually throw more light that Kinovia is not just the only software that analyzes gaits. So we have so many softwares that analyzes gaits. And one of the reasons we also choose Kinovia is that the reliability and validity has been done. Because most times, it's not just about actually using an instrument, or you see a software online and you want to actually use it and then you adapt it and you start using it immediately. Now, if you check online, you see that the reliability and this validity of this particular Kinovia has been done since 2004. So it has been adopted both research-wise and clinical-wise. So you can actually use it as a clinical instrument for gait assessment. You can also use it as an instrument for your research purposes. So it's actually available for you to actually use, and then without it's reliable and it's also valid. So the instrument, what the value is giving you is also an accurate value. So you don't have to start doubting, am I getting the wrong value? Am I getting the right value? So the validity and reliability has actually been tested and actually been published and documented properly. Now, this Kinovia software is actually an open source software, a digital software. Now that you upload your video on, so once you upload the video, you can be able to actually analyze the step length, the stride length, the speed, the gait speed, even the joint angles, and so on and so forth. And then you can also use it because most times some people will tell me, will say, is it for just physiotherapists? No, this Kinovia software is not meant for physiotherapy, and it was actually, they didn't have physiotherapy in mind while designing it. It was actually open to actually accommodate different professionals like the prosthetists and orthotists, the occupational therapists, the ergonomics design for your ergonomic design, workspace design, and so on. For those in sports as well. Now, I also want to divert a bit. Now, if most times you see that a player they're actually a football match is actually ongoing. Now you see that a player that is performing, all of a sudden you see that probably the speed drops. You see that the performance have already dropped. How do you think that these coaches and all these analysts are being able to actually identify what the issue is and how to actually change the player immediately? No, you see that most of these softwares now that has been made available is being incorporated to these cameras now that is being placed in the stadium, because this camera now tends to actually pick, analyze, and say, oh, this person's speed has truly dropped. It's not just by saying the speed have dropped, but now they tells you that the actual value that this speed have actually dropped from this point to this point. Now it's either you change the player or you bring the player backward and then put a striker that goes forward to actually go for attacking. You see that this is not just help us in clinical management, it also helps those in the pitch or in the sports facility too, to be able to actually say, oh, this player has actually have an injury, and this injury is actually affecting this particular player, and it's actually time for us to actually change it. Not necessarily for just you, for those in clinic, and then you now see a patient, and now say the patient walks in, this is the stride length, this is the step length. No, it's actually an open source for every commodities on every individual out there to actually adopt for their analysis and all. Now, for you to now analyze, like I mentioned before, you need a laptop. Now, the phone version for this software has been having issue for quite some time now. I don't know why they've not really done the update. So if those that will be trying to actually download this software with their phones might find it difficult to actually install it. You might be able to download, but installing it in your phone now will be difficult. But the laptop version is widely available. You can actually click Kinovia and download this software and install. Now, I'll walk us through on the interface. But before then, one of the things you need to do before you start analyzing, because before you analyze, you must actually prepare your environment, get the video ready and all that. You don't just pick an ordinary video and you put on Kinovia and you want to start analyzing and so on and so forth. Now, before you analyze, you have to prepare a walkway where this individual will walk. So I'm actually I will be speaking to some parameters that I might not be able to describe. No, but when they now start practicalizing it, it will now start making sense. So don't just feel disconnected. Don't feel disconnected. But when we start the practical demonstration during the hands-on session, you also understand these parameters better. And I also believe that they will still throw more flesh to whatever I'm saying right now. So you need to actually have a walkway. You need to prepare a walkway, either a 10-meter walkway, 7-meter walkway, 6-meter walkway, but the normal walkway you need to actually, for a normal individual, is 10-meter walkway. Now, in that walkway, you need to actually use a tape rule to measure 10 meters. Now, where the 10 meters starts, you use a marker or a masking tape to make a measurement. I think let me share a video and use it as a demonstration to demonstrate.
Just a minute.
Nigeria. Mama J, continue.
So can you see my screen right now?
Yes, it's showing.
Yes, you can see.
Yes, we can see.
So this is more like a walkway, but this camera was not properly positioned. So probably our facilitators will also share we also have other videos in the group they can also share with us for us to also see. Now, let's assume this is a 10-meter walkway. Let's assume this is a 10-meter walkway. And now this is where so this is where the initial step, the person was actually standing. This is where my hand is. I'm finding it difficult to actually bring a marker. Let me see.
We can see your cursor.
Okay. I wanted to get a marker so do for. Okay. Just a minute. Let the marker come up there. Okay, let's just continue. So this is where the initial step begins. So this is where you have to actually use a masking tape to draw. This is where, like, let's say if this place is 0, so you make a masking tape here, 1. Now this is where we have 10, where the 10-meter walkway. I'm just giving an illustration. This is where the 10-meter walkway will end. So I will also use a masking tape, draw 10 meters. Now, but another thing you have to understand is that you don't tell the patient to actually you don't bring the where you made the marker to the consciousness of your participant or the patient working on that individual or that working on that walkway. Because now you see that most times if you are walking now and you see a wall in front of you, you might actually tend to actually slow down or increase your step to actually because of the obstruction. Psychologically, it affects your speed. So you have some environment as a way of affecting speed. So if you make that initial mark on the floor, you ask the person to start from there. Now you make the second mark there, like where the 10 meters will end. You also make another 10 meters. Then you probably extend like, okay, 4 meters away or 2 meters away and make a mark again. Now, what you need to do is that you ask the person to walk from where the marker started and then to where the last marker, probably 4 meters away from that initial 10 meters. Now, by doing so, you've actually calibrated, because now the brain might has a way of calibrating. Now, if you ask the person to walk normal now, if they walk normal and you ask the person to walk very fast, you see that the brain will be using that normal as a benchmark or as a reference point. That, okay, this is my normal, so this is my fast. So if you ask the person to walk slow, see that they will also be using that normal. The brain will also be using that normal
as a reference point or as a marker to walk very slow. So by doing so, for you not to reduce the risk of bias of environment playing a role in your reading or your recording, actually contributing the change in movement pattern of your patient, you simply ask the person to, you make that adjustment. So you ask the person to just walk. So as they are walking, you already know where the 10 meters within, you already know where the 10 meters started and where the 10 meters ended. So if you want to now analyze, you're just analyzing from where the 10 meters started and where the 10 meters ended. So you won't now include or actually bring in the other parts again into the system. So because now the person has been able to actually express its normal working gait within that 10 meters. So for individual with neurological conditions and pathological conditions, 7 meters is enough for them to actually start expressing their normal working gait. So the 7 meters now for individual with abnormal conditions, 7 meters is enough for them to express. But now for a normal individual, you use 10-meter walkway. So 10 meters is enough for me to actually express my normal walking gait. Now, you're also setting up the system. Now you also identify the landmass, because this is where you place your reflexive markers. So most times, because we find it difficult to actually getting reflexive markers around there, is available.
No audio. Hello, we can't hear you anymore. Uche, is he still talking?
Okay, hello, can you hear me now?
Yes, please.
Okay. So I don't know if you actually get a point where I was talking about the landmarks and markers. Did you get that point?
Yes, please.
Yes.
Okay. So now, what I was saying in essence is that if you analyze now and you feel like, okay, what you are doing, you're not getting it correctly, or you want someone to also, you need a second eye to also look at it, you can actually pass it over to another person to analyze for you. Now, you can actually pay this in the first visit. Now, if the person comes back after 4 treatment session and you want to analyze again, all you simply have to do is just ask the person to walk on the walkway, you record, and then you analyze again. So you can also record it at 4th treatment. You can also label it 4th visit or 8th visit again. So you're able to actually document these videos for this particular patient. And then you also know that if you're not able to actually document the first working pattern, you see that most times you won't be able to actually describe appropriately or with appropriate details how the patient walked into the treatment cubicle. But if you feel like you're actually missing the first point, you can still go back to the video and rewatch it again. So the video is always there for you to actually bank on and watch. Now, another instrument you need for this setup is you need a tripod stand. Now, tripod stand in the sense that this is where you place your camera. This is where you actually position your camera so that the camera is not supposed to be moving. So now, if you look at this, just look as I play this video. So once I play this video, you see that the camera is not actually moving with this individual. Rather, this individual is walking past the camera. So the camera must be in a fixed position. So you don't have to now use the camera. You're not a photographer, neither are you a videographer. So you don't have to follow the person with the camera and be chasing the person. Now, in advanced country, what they do is that they use 3 or 4 cameras. Now, one camera will be at the left-hand side, one camera will be at the right-hand side, and then one will be behind, and then one will be in front. And as the person is walking, the person walks at once, and it takes the recording immediately. So they get the videos, and then probably most times they superimpose and they analyze and they compare the result for the left and right, back and forward. So you don't necessarily have to now start waiting for. You don't necessarily have to start waiting for you don't necessarily have to start waiting for the left to finish before you switch to the right. So most times they just do the recording at once, and this is what the Vicon camera does as well. So the Vicon camera, which is an advanced camera, they place it records the gate at once as well. Now, for us in low resource setting, what we do is that we get one camera, not a next camera. If I'm mentioning camera, I mean phone, your Android phone, which is a very good camera, and not the Nokia 310. So you get an Android phone or iPhone with a very good camera to record. Now you place it at the tripod stand. So let the camera be in a horizontal position, because if you place it in a vertical position, you won't be able to actually get this 10-meter walkway. So, but if it's in a if it's in a horizontal position, you will be able to actually get that 10-meter walkway, just like the way my screen is. I see that this camera was positioned in horizontal position, but as is other way around. You see that I won't be able to actually get this 10-meter walkway as the person is actually walking past this screen or this frame. So you get a tripod stand, your phone, and then you also make sure that
your screen, sir.
Can you see my screen?
No, we are not seeing.
No, sir.
Is the screen showing now?
Yes.
Okay. So you see that you see that as the camera is positioned, and the camera is actually positioned horizontal, not vertical. So you see that you'll be able to actually get enough walkway for this individual, for you to actually get this exact 10-meter walkway where this individual will walk on. But if you tend to actually place it upright, you see that most times you will be getting 3-meter walkway, 2-meter walkway, or 4-meter walkway, which will not be enough for this particular individual to be able to actually express his normal walking pattern. So another thing you also need to also understand is the environment needs to be well lightened, in the sense that so that you can be able to actually see all these joint parameters. So there is no guesswork here. You don't have to start guessing. Is this where the marker is? So if you can see on my screen, you can see where you can see the masking tape on this at the knee joint. Can you see it?
Yes.
So you can see the masking tape. You can see the masking tape at the knee joint. So you don't have to start struggling to see the masking tape or see the reflective markers where it is being positioned. So that is one of the things you need to also understand. So you don't have to start guessing or start struggling. So all you need to place that and then position your camera properly, so you can be able to actually, when you import into the system, you can be able to actually analyze your movement properly. So like I mentioned before, we have your digital camera, digital devices, which has to do with smartphone. Now, for those that have, if you have enough funds or capital, you can now go for digital camera. Now you also get measuring tape you should use to actually for you to be able to calibrate your environment. Now you also use get plumb line. So plumb line is when you now want to start doing postural assessment, start looking for postural deviation, hip tilt, and all that. Now you can also get your goniometer. Now most times goniometer is very helpful because it can also use it for you to actually analyze the joint angle in passive position, probably in lying, in sitting. Now, but this Kinovia will enable you to actually analyze your functional gait, your functional movement gait parameters. Now, in the sense, there is a difference between passive and functional. Now, passive is probably you are lying down, you ask the person to flex, you are the one that is flexing. Active, you ask the person to flex and all that. But now, functional is that when you have already loaded the system. Now, because the system is being loaded, that is when you now start seeing the true expression of the working pattern, the true joint angle, the true step length, not the one you are seeing when the patient is lying down, or when you are the one that are just flexed. So you see that the functional parameters are the true values that you need for you to actually make the appropriate diagnosis and plan the best treatment for this patient. Now, you also need your laptop where this Kinovia software is being installed. Now, stopwatch. I will also say that most times you don't need this stopwatch because this Kinovia also comes with its own timer, in the sense that you can be able to actually time the speed and you know the time it took this patient or this individual to walk the 10-meter walkway. You know the time it took this individual for this 6-meter walk test, 6-meter walk test. So Kinovia itself also came with its own timing and calculum and stopwatch. Now I also want to actually describe the step length and the stride length for us before we proceed, because you need to actually have a true understanding of what step length is, of what stride length is, because these are just the two parameters I'm analyzing now. Now, if you look at my screen, so you look at my screen, now you see can you see where I made the initial marker?
Yes.
And then where you see the second marker. Now, yes, the distance between this place, the distance between the first point and the second point, where there is the initial contact, where we recorded the initial contact is the step length. So I come again. The first place I made where the movement started, where the movement started, and the second, and where the heels make the initial contact on the floor is the step length. So if you want to analyze, so you take your readings from this point so from this point to this point is your step length. Now for your stride length, and then also have to also understand that the step length for the right, you have to separate the step length for the right from the step length for the left. Now, there are two different things. So if I should take this reading now, from this point to this point is the step length for the right. So whatever I'm doing at this point is I'm actually taking cognizance of the right. Now, if I want to take the step length for the left now, using the single video analysis, now I'll have to wait for this particular limb now to move from this point to this point. So I will now know that the left lower limb have advanced. You understand? So I will now know the distance from this point to this point is now the step length for the left. So if I also want to take another reading, if I want to take another reading for the right lower limb, I will still wait for the right lower limb to actually ambulate again.
before I can actually take the step length for the right. And then we have 2 step lengths equals to 1 stride length. Now, the step length for the left and the step length for the right makes 1 stride length. So if automatically, if you divide the step to the stride length, you have 1 step length. But most times, where this particular analysis is very tricky is that now, if you record this, if you actually say, okay, I'm combining the step length and the step length for the left and step length for the right, and then this is the stride length. Now, you won't be able to actually identify the lower limb with issue because now you've actually merged the 2 movements together. So you won't be able to say, okay, this is the one that has the shorter step length, or this is the one that is actually have the problem. Now, that is almost times if you take the step length for the right, you also take the step length for the left. Now, you analyze. Now, we have so many things that can actually affect the step length. We have limb length discrepancy. If the limb lengths are not the same, you see that the left will be making a longer step length more than the right. So this is what Prof was actually saying in the morning, that you need to actually understand the mechanism so you can be able to actually link it when you start talking about these basic gates parameters. So when we start talking about these basic gates parameters, so if you just come and take the stride length and you record the stride length is this, the stride length is this at first assessment, the stride length in this at second assessment, the stride length. So you won't be able to actually identify the individual lower limb that is having issue to actually focus on. Now, if there is pain at the knee joint, when there is reduced knee angle, you see that the step length you also reduce for that particular limb. See that the lower limb will not be actually activating or utilizing its maximum knee angles, either in flexion or in extension. So these are like the person would, because there is pain at the end range. You see that the person will just flex and drop, or the person will drag and drop. So you will be seeing that the step length will keep on reducing. Now, another thing you also need to understand is this. Now, in older adults, as individuals tend to actually get old. So I'm just trying to give us a clinical scenario or clinical implication. So as individuals tend to start getting old, you see that the step length starts reducing as a result of muscle weakness as a result of old age. You see that the muscle strength will keep on dropping. The energy reserve will start dropping. Now, a point will come when you don't encourage the person to ambulate, you start prescribing assistive devices. When the step length is less than 0.2 meters, so this is when you start prescribing the step, because the person is actually on a very high risk of fall, because any small thing, the fall will occur. Any little thing fall will occur. So you tend to actually discourage. There is no Superman here or Superwoman here. You advise the person, at this point, what you need is an assistive device. You don't have to start forcing yourself to walk. Even when you have a normal patient, now you see probably a patient that you want to start walking from standing to walking. And you now notice that after we wait behind, you notice that the step length is reduced. You don't encourage the person to start ambulating without assistance. You encourage assist, probably you walk the person or with a Zimmer frame and all. Then you also at home, you tell the person, don't walk alone without someone holding you, or you prescribe Zimmer frame. Now from your Zimmer frame, you prescribe you move advanced to cane. So these are the things that inform your clinical decision. You don't just come and start saying, please, I will need an assistive device. You then ask you see that the person is working somehow. Now, what informed your decision in working somehow? Now, you cannot just objectively say this is the reason. But now I can say that there is reduced step length because it's less than 0.2 meters. And at this point, I won't allow this patient to ambulate independently. So with this, I'm actually confident in what I'm prescribing. So this person has a need for it to go for an assistive device. So imagine if you come to my documentation, you see like after analyzing, I export the results and I now say step length less than 0.2 meters. And you now put a pointer, assistive device needed. So you see that I have a reason for actually prescribing an assistive device, not just me saying, and there is a working gait. Doctor will now start asking you, or all these other health workers will start asking you, why did you prescribe assistive device? This person is working perfectly well. Now you can tell the person, statistically, this person is not fit or not. You don't have the confidence for this patient to actually ambulate. So you cannot actually ambulate this patient alone. So they need an assistive device. So this is one of the things that also inform your clinical decisions when trying to actually prescribe or tend to actually advise them on what the available instrument to actually go for.
Now, I think in the next segment, Prof might try to throw more light to the stand phase, swing phase, single support duration, and double support duration. Because in some conditions, you discover that the single support duration with the double support duration will disappear. Now you now start seeing single support duration. Now, probably for instance, now if a normal individual is walking, you see that a time will come when the 2 feet or the 2 lower limb is on the floor. So that is this double support duration. But in single support duration is when the person is trying to actually raise that limb up to make the next move and drop it on the floor. So that's so you see that the single support duration have actually occurred within the double support when I'm trying to actually ambulate. So when the foot comes in contact with the floor, the 2 feet is on the floor. You see that there is a double support duration. Just like on this place now, you see that from this point to this point is the double support duration. So now from this point to this point is the single support duration. Now, from this point now, the double support duration is supposed to start from here because the 2 feet is on the floor to this point. Now, the single support duration, this is the single support duration. This is double support duration at all. Now, in some condition, you see that the patient is running, whereas you think that they are walking. You see that most times the double support duration has disappeared. What you are now seeing is a single support duration. So as if the 1 feet is coming, they are making the boom, 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 boom. So you see that there is no double support duration again. And then with that, when there is no double support duration, the risk of fall is very, very high. So you can see it in some conditions. Now, you see that this single support duration is expected to be seen in athletes, those that are running, because they are running very fast. So they have a longer stride length. So 1 foot is touching on the floor, bam, 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 bam. But when you are not seeing, when you are seeing what you are supposed to see in a runner, in that individual who is walking, you see that there is an issue happening. There's something is actually happening. So it's that the person is no longer, there is no time for the person to actually readjust and then ambulate again. Whereas the person is running very fast. And not just that the person is running, some metabolism is actually happening. Now, the energy expenditure at this rate is very, very high because the person is actually overloading the system. The person is, now you now be seeing the person will walk small, the person will start panting. You now start screaming cardiovascular. No, the issue is not cardiovascular. The issue is that the double support duration have disappeared in this gait cycle. Now, the person is walking. The person thinks that he's walking, but no, he's not walking. The person is running. Whereas everybody is assuming that this person is walking, probably because of the distance he has covered. But whereas he's spending so much energy walking because the double support duration has disappeared entirely. Now, when you have this picture now in your brain or in your mind, so when you start analyzing, you don't have to start struggling with what you're analyzing. You will now start, when you analyze, you'll be able to actually, oh, this is what is happening, this is what is, let's focus on this, let's focus on this. Now, if the person is walking very fast, you will be the one to advise the person. Be conscious of your movement. Now, make sure that you touch this feet. You don't just leave the 1 foot on the plan. You are now digging deep as if you are jumping from one point to another with a shorter step length. No, you consciously educate your patient on or train the patient on the appropriate walking gait. So to avoid the risk of fall, because if they are being walking that way, any external force, external impact will cause the person to fall, which most times in older adults or in a normal in a pathological disease individual or patient, we try to actually discourage anything that will have to cause fall. Because once fall occurs, a lot of things will start coming into play. A lot of things will start happening. So probably when Prof comes on board, it will also throw more light on this stance phase, swing phase, and then the clinical implications. It will also throw more light on that. So let me just utilize my time and then do 1 or 2 practical before my time elapses. So this was the energy conservation and energy utilization I was trying to actually talk about during the working pattern. But Prof will still throw more light on that if there is time. So let me now show us how to download this software. So once you type Kinovia on the search bar, so it will take time. It will also, so we have to, for those that have actually tried to access it, you'll be seeing two different this thing. So you see that in fact they did an update in March at 21st March 2026. They just did an update for this particular software. So you see, if you look at this, we have two different files here. We have .exe and .zip. Now .exe is just like once you download it, you click on it, it will start installing. So first of all, it will download. After downloading, it will now start installing. But for the fact I already have it in my system, I will just go straight to the software. So once you are done installing and so let me close. Once you are done installing and you come to your search bar to type Kinovia, it will appear here. So you double click or you open it, it will load. So we have different interface. Let me explain the interface of this software before we. So let me just quickly explain the interface for this app before we proceed. Now, once you open your Kinovia software, now it will first of all show you this screen. This is the first thing that will appear. Now, don't mind this. This particular successful will not be there. Now, if you click on File, a dialog box will appear. So in that dialog box, now we have open video, open replay, observer, load annotation, recent, save annotation. So all these things will the step that facilitators will throw more light on that. So we have open video, open replay folder observation, load annotation, recent, save annotation, export video, export image, export document, export spreadsheet. So now the first one is open video. As you already have a recorded video. So all you need to do is just to bring it to your laptop, and then you go to open video, you bring it in. So I have a video I want to analyze. So, okay, this was even the video I was looking for, Abination. So I bring the video, let me import this video. Or let me import this video named normal. I'll click open. So I allow it to load. So once I open, so can you see my screen?
Yes.
Yeah, it's showing.
Okay, this is the proper gate analysis lab I was actually describing before now. So you see that there is a masking tape here. So if you look at, there is a masking tape here at this point, at the starting point. So you see that there is a masking tape here at the starting point. So you see that there is a masking tape here at the starting point, and also there is a masking tape here at the ending point. Now, don't make the mistake we made here by actually placing this walkway close to the wall. Now, because if I play this video now, you notice that when this person start getting to the wall, you see that the step length will start reducing. The person will start reducing. Just look, just observe. So you see that the step length have started reducing because the person have actually seen or sense an obstruction in front. So don't make the mistake. Make sure that we have enough walkway so that the ending places wouldn't be close to the wall and there will not be any obstruction where the patient will end. And you don't have to start telling your patient that you have to end there. So just tell the person to just walk straight. So within you already know where the recording will start and where the recording will stop. So that your environment will not actually influence the working pattern of this particular individual. So the person will be able to actually express his full working gait or his full working pattern. So like I was saying, so we also have a under edit. So if you come to, let me go over to the interface before we start talking about that. And I just wanted to show us what the environment looks like. So if you go to under edit, if you click on edit, you can actually undo or redo what you've done before. So you can also cut, you can also copy, you can also paste. So we have view. Under view, if you click view, you see that this explore panel will disappear. Where you have dots, the drop down used to come down. So if you go back to view again and you click on the explore panel, it will come back again. Now, in that particular view, we have full screen. If you want this screen to be full, now you click on full screen. You see that every other thing will disappear. So if I come and click again, let me change it back. Just a minute. So if I come and click view now, you see that the full screen enables you to actually have a full screen of your working environment. So you come and close it. So you come also see, you also have that particular arrow, that 4 arrows that where you click before that made the distance to disappear to go into full screen. So if you click on that arrow again, you see that the view panel button will also reappear. So you also go back to your video. Now, also have what under that same view, we have one playback screen. So what you're currently working with is one playback screen. Now, if you want to have 2 playback screen, if you click on this view and go to 2 playback screen, so you see that we have 2 different screens now. And then what this entails is that I can import the video for my left lower limb and the video for my right lower limb, in the sense that as the person is working and the right is facing the camera, I can record it. As the left is facing the camera, I can still import it, and then I will be analyzing it too simultaneously. And I can still export the results export the result and then bring it together. I will still see the output. So you can actually analyze 2 different videos at the same time. You don't necessarily have to now start analyzing left. After analyzing left, you remove it and you can now start analyzing right. No, you can actually analyze the 2 at the same time. So under that same view, we also have what we call capture screen. Now, capture screen is when you want to work with a digital camera. You know, I mentioned before that you can actually use a camera or you use a recorded video. Now, if you want to do a live recording, where you have to connect your cameras to the system directly. So as the person is walking past the frame, the system is capturing it immediately. So you don't have to start uploading and then transferring to your system and all. So the system captures it immediately. Now, but you know what we are looking at is how to reduce costs and expenses. So we simply go for, most people cannot afford camera of 600,000 and all. We can easily use our phones that we use to do normal phone calls to record. So basically you have the option of getting a capture device, which is the camera. You can actually use the capture device for you to actually record. Now, we also have option of 1 capture device and 1 playback screen. Now, 1 capture device and 1 playback screen is that as you are capturing, you are playing back, you are rewinding. So if as I do 1 capture device and 1 playback. So this is my playback. This is my capture device. So in my capture device, you see that there's something like camera and all. There's webs like camera where I can actually import or set up the camera, the video device here. So, but I don't have a video device, so I will still opt for only 1 play screen because I still have 1 video that I'm analyzing. So we also have the option of, this is the image. If you want to actually rotate, then they interface the video. So now, as time goes on, we'll still get to actually understand these parameters. So we also have video analysis. This is when you want to now go into your video analysis proper. When you want to start doing the kinematics analysis as the person is working, the thing is analyzing. So all these options will still have to actually explore all of them. So we have tools. We have import image. If you want to import image. Now, like I said before, you don't just necessarily analyze only step. Most times you can also decide to actually look at this person's posture. Because most times people tend to start analyzing gait without looking at this individual posture, the individual or the patient posture first. So most times, if you look at this posture gives you an insight to what the gait pattern will look like. Now, assuming the person you come and the person is actually, you see the person walking in a Trendelenburg pattern. Now, you don't have to now start analyzing and all that. All you need to do, you've seen that this person posture is deviated either to the left or to the right. You understand? So all you have to do is ask the person to stand straight. You actually capture the person in the person. You bring into this synovium, and the person will the synovium will tell you the degree of deviation. You don't have to now start saying there's a Trendelenburg, now there's a deviation to the left. Then what is the degree of deviation? You don't know. Or you know that there's a deviation. Now, if you start giving treatment to this particular individual, now you now give for like 12 weeks treatment, and you now come back again to analyze. You see that, okay, the deviation is improving. Now, you don't know the point at which this deviation started improving. You don't know. You can't even say that, okay, it's at 4th week, it's at 6th week, it's at 8 weeks, or it's at 12, that particular 12, that is when this particular condition started resolving. So you can see that you won't be able to actually tell the degree or at what point without just describing and start telling stories. Because most time, Prof will say, whatever you say, you are just telling stories. And it's just like there's nothing to differentiate you between a market woman to what you are saying. So most time you have to actually speak like a clinician and then back up whatever we are saying with values. And that will also make us to have more respect and more grounded value, because it shows that you know what you are doing. You don't just say there's a Trendelenburg this thing. Walking pattern, the hip is defeated or tilted to the right or tilted to the left, without actually saying this is tilted to the left with this degree or tilted to the right with this degree or percentage. So you need to actually ascribe value. So if you now imagine, like I come into the world now and I see your documentation, wow, initial assessment, pelvic tilt, this is the degree. You turn again and now start look at the pelvic tilt, this is degree. I now discover that this degree, this has started decreasing, and there's an improvement, Now, this is like evidence. You might decide to like put the spreadsheet and attach. Now, when you as your summary sheet, when you want to actually discharge this patient, now this is what the patient came in with, and this is what the person is living with, without you describing or start telling stories. Because someone that knows that was not there when the patient walks in will not be able to actually say that this is what the person, because what the person is saying might not know the effectiveness of your intervention. But when the person starts seeing these values, okay, it has started decreasing from 60 degree to 40 degree to 20 degree to 10. Most times you don't get 0 degree, but you see that there's a level of improvement and there's a trend that this thing is good following. You can actually argue that there is need for us to actually be in this particular treatment cubicle, because with this you can actually make a better intervention that is evidence-based, that can actually help this patient to actually recover. So not just saying that we can actually help this patient without actually coming up with a fact or with an evidence that will back up whatever we are saying, without backing up our claims. So we also have options. So under these options, we have language, we have time, we have workspace. So if probably you actually you don't want to actually analyze in English, you want this thing to be in Espanol, you might come and change it to Espanol. If you want to leave it in English, or so you decide to actually choose, because like I said before, this software was not just designed for Nigerians alone. It was made open for every low and middle income countries who can now actually afford a Vicon camera to actually access and use to analyze their. So that's that with the first bar. Now when we come down to this bar, so you have what we call the color palette. So I will be fast here because I still believe that the facilitators at the local chapter, that the respective states will still throw more flesh to this. We have what we call the color palette, the magnifier. So color palette is, assuming I want to actually draw a line. If I choose my color palette to actually be in yellow, I apply. If I want to draw any line, I pick my line too. So it automatically comes in yellow. So I choose my color palette and apply. So I draw a line. So I say it automatically comes in yellow. So this is where you just decide to actually use different colors or assign different colors to whatever you are doing. Because most of you might have different lines on the screen. So you now want to actually differentiate it with different colors. So also have what we call the magnifier. So magnifier is used when you want to actually, just a minute. So magnifier is used when you want something, when you want to actually magnify something. So magnifier is used when you want to actually magnify something. For instance, now let me play this video. So I want to actually magnify this knee joint now. So all I need to do is just to click on this magnifier, come to this knee, click on this magnifier, come to this knee, drag it, or place it. So if you look at the top left corner of my screen here, you see that there, the knee, this thing is there. The knee angle has been magnified. So imagine if I want to draw anything on that particular joint now. Just look at. You see that the marker is there. I can see it. In as much as on the big screen is very small, but on the magnifier, I'm able to actually see it very well. So this is what the magnifier does. So we also have a spotlight. So as me, you want to put something on the spotlight. For instance, you want to put like the lower limb only on the spotlight. You want just to focus on the lower limb. So if you click on this spotlight, the lower limb only will always be on the spotlight. So we also have this perspective grid. So this perspective grid, most times you bring it in on the screen. If you want to, most people use it to actually for analyzing the. So I drag it, but you use it to actually analyze if there is asymmetricals. Probably if the left hip or the right hip, as mean you are actually observing this person from behind. Yeah, you are looking at the hip level. If the left hip is actually at the same line with the right hip, so this line will also assist you. Or if you are looking at the shoulder level, this line will also help you to actually do that. Now, as me, you also want to look at, like you ask the person to stand straight. So this line will help you will help and tell you that, okay, this person is not actually standing erect. This person is tilting to the left or tilting to the right, or the person is moving out. Okay, as me, you want to use like you want to use this point and this point. Now you see that the lower limb are in these two, whereas the upper limb is going to the third one. You see that there is actually an issue, or there's actually an underlying condition causing that. So you also see that more often in individual with scoliosis, where you see that the lower limb is somewhere and the upper limb is the trunk is also located somewhere else. So this can also help you to actually make a straight line, more like a pendulum. Now that will make a straight line to actually tell, okay, there is a deviation at this point. Now we also have this is now the stopwatch I mentioned before. So if I place the video and I see that. So if I come here and I right click, and I say show before this time point, and I click and I just say start. So and I click start. See that if I pause, it will pause. So now, one thing you need to understand is that this, let me take it backwards. So let me take this video backwards so you see. So now, if I increase this speed, it does not have effect on this particular individual walking speed. It does not have effect on this individual walking speed. So it will not affect this timer. So now this speed I'm increasing now is just to actually to fast track this movement or slow it down. So if I slow it down, just watch. It started and then just observe. It stopped at 1.13. Now, if I increase this speed, and I play this, you see that it's still the same. So if you observe it will still stop at that 1.13. Now you see that the speed of this video playing does not actually have a role or does not actually affect this individual walking speed. So they are independent. So I can decide to increase this person's speed or reduce the speed. So they are two different things. Please, can you hear me? I'm seeing no audio. Can you hear me?
Yes, we can hear you.
Loud and yes, clear. We can hear you. Clear, we can hear you.
Okay. Thank you. Because I saw no audio. So you see that this speed I'm increasing here, that I'm increasing or reducing, does not affect the individual walking speed. So there's no way you can actually manipulate the walking speed. So if you take this person 1 minute or 0.50 seconds, 0.1 seconds to make this step, discover this distance. So you see that if I increase the speed on this video, it's still the same speed that I will still be getting. So it does not actually have any connection with one another. So as for those that will now start increasing the speed and then they will put timer, they will now be saying, seems like I'm manipulating this person's speed. No, you're not manipulating. So their speed is still the same. So also have this, this is the angle. So if you want to actually make a marker on the angle joint, so if you click on this angle, you can actually get, if you click on this angle, you can actually get, so if I click on this angle now, you can actually use it to actually measure the knee angle, either in flexion or in extension. So this is like also a marker, if you want to place a marker at any joint. So this is also an arrow that you can use for direction of movement. So this is the line 2. So this is also a woman model. So as many the person is facing, this individual is facing me. I click on this woman model and I draw it. It can also tell me, so you see that in this woman model, there is in this woman model that you can see the shoulder level, you can see the hip level, you can see the knee, you can see the ankle. So this can also help me to actually, though if this individual, if the two shoulders are actually on the same plane, or if the knee, hip is also on the same plane, or if the knee is actually on the same plane. So we now have the pencil. You can, this is like for a free hand tool if you want to actually draw anything. So it's just for a free hand tool. So we also have the label tool or text tool, which you can actually use. Okay, for instance, you want to now put a label. You can come and say, after analyzing or drawing whatever you want to do, you can say, okay. You can say FOT analysis. You leave it inside the video. Whoever sees this without even naming the video, we know that this is a FOT analysis. You can also use it to make a comment inside the video. For instance, you want to comment, okay, look at the knee. I might decide to say, write, look at the knee. And then export this video. Anybody that sees this thing, this person is trying to actually make a comment. It's asking me to go and look at the knee. So I can decide to actually use because of that and then go to the knee joint and then look at the knee. So this is the move tool. So if I want to move anything, if I want to move anything, but all I need, as mean I click this color palette now, or click this magnifier now. So if I want to now drop this magnifier, after dropping it, I want to now move it around. I can decide to click on this move tool. I'll move it around. I can decide this move tool allows you to adjust more like a free hand tool that you can easily use to actually navigate or move things around. So let me just quickly analyze the step lengths of this particular individual on the screen. So please, if you know, I'm pleading on us, on begging, nobody should actually capture this or take it to the individual. Please, let's protect his integrity and this thing. So let's not circulate this particular video. So whatever the video will be using for analysis will also be taken at our respective states. So that's what we'll be using. So our individual coordinators will also tell us guide us properly on how to actually record this, how to set up the environment or the lab. Now, like I said before, it costs us little or nothing for us to actually set up this lab. So as you can see that we just have the work with, there's already a marker on the floor. All we need to just get a camera stand and the camera and we'll record. Now, before you analyze, there is one principle and one important thing you need to actually do. Now, if you look at this place, there is a marker, there is a masking tape that runs from this point to this point. So I'm going to move the line, the yellow line, out, and so you will see the masking tape. Can you see the masking tape?
Yes, you can see.
Can you see the line that ran from this plate? Now,
yes.
Why this line is very important is that you know that videos, recordings, or the capture or camera recording comes in pixels, whereas our gate parameters comes in degree, meters, and centimeter. I don't know if you agree with me.
100%.
Yes.
100%.
So you see that our video recording comes in pixels, HDs, and all that. But then our working gate parameters, like the step length, the stride length, comes in centimeter, while the angles comes in degree. Now there is need for us to now convert these pixels to centimeter or to degree. Now, so what you have to do is to calibrate this video or calibrate the video you want to analyze. Now, what we normally do is this, or what we advise is this: you don't have to now start preparing your environment for calibration. Like most times, some people will say, bring a meter rule. You have to actually get a known measurement. For instance, if you have a meter rule, you can actually place it inside this video. Now you use this measurement that you already know to calibrate. Now that measurement is now a reference point for you, whatever you are doing, for the analysis you are doing. So once you calibrate, the system uses it as whatever you are doing. You don't have to now start calculating anything again. Now for the first time, you must calibrate. Now, but what we normally do is this: if we get a lab or get an environment that, okay, this is our normal working environment for gate analysis. What we normally do is that we just get that to come to this place. You measure it from this point to this point is 2 centimeters or 2 meters. So as from this point to this point is 2 meters, we just measure it out 2 meters, and now it's already in the video or in the walkway. It's different from that line the individual is walking. But anybody that does not understand will not know what this line signifies. But for those that was present in Abuja, already know that this line is actually a calibrating instrument, and they already know a known measurement. So you don't have to now start telling the person calibrate. Once they see the video, they already know. They just say, okay, they just take their reference, calibrate the video, and then they will start their analyzing. So in your lab, you always have to, instead of bringing a ruler, keeping a ruler, because someone might remove it tomorrow. So just the way you are measuring your walkway, also either use your pens. So you measure like, okay, 2 meters, 2 centimeters, 2 meters, 1 meter. It won't be as long as this 10-meter walkway. Now you might decide to use 2 meters, 1 meter, but let it be a known measurement that you already know. So you can even decide to use this your 10-meter walkway as your calibration tools. But now for the sake, because if individual is working on this, you might not be able to actually get the exact measurement. So you just have to make a measurement out of the main line and you calibrate it. Now for me to calibrate this line now, so if I come now, I will bring my line to. So let me restart this video because I've drawn so many lines. Because once I export, all these lines that I do will appear on the export and the spreadsheet. So let me re-upload another video, fresh video, so that the output will not be confusing so fast. No, don't save. Now, so this is a fresh video. So this is a fresh video. Now, the first thing I will have to do is, after setting up my camera, arranging my walkway, and now this place is not well lit enough. That's why you are seeing that some places are dark, because assuming that there was a proper lighting, so you will see that everywhere will be well lightened enough. So the person, you won't be struggling to see anything. But I know that so many of us are struggling to even see the markers where the masking tape is. So now you make sure that the place is well lightened enough. So after setting up your environment, arrange your 10-meter walkway, make your masking tape. Now you draw. You already measure this particular place, this particular point. You say, okay, this place is 2 meters, or 1 meter, or 1.5. So once you are done, you import the video. You click on this line too. Once you click on this line, so from this point, you just drag it, and then where the line stop, you drop. So once you drop, so you pick your move tool, right click on the line, So you will see configuration, set as default, visibility, tracking, calibrate, label, cut, copy, and delete. So if I delete, I'm deleting the line. If I copy, I'm copying the line to another place. If I'm cutting it and then replacing it somewhere. So I want to calibrate. So I'll click on calibrate. So now if you click on calibrate, now you will now be seeing 100 centimeter. So once I click on it, you see that now you are no longer seeing the pixels that I mentioned before, but what you are now seeing is millimeter, centimeter, meters, inches, yards, and percentage. Now this line now, I will be giving it 2 meters. So I will be giving it 2 meters. So you measure your own distance, then you know what it is, and then this is what you now be used as a reference point to measure. So I'll be using 2 meters. So I'll click meters. So I will now come here, 2 meters, apply. So you see that automatically gives the label, which is 2 meters. So I already know that this thing is 2 meters. So if I want to now analyze, now I've already calibrated this video now. So if I want to analyze the step length now, so let me bring in my magnifier. So if you look at the upper screen, you see that this thing will magnify the lower limb. Now, if I want to now play this video now, like I mentioned before, I said that the step length is the distance between 2 different foots when the opposite limb make the initial contact on the floor. Now I play. So you see that the video is very fast. Now all I need to do is to come back to this speed. This is the speed, and then drag it backward to reduce the speed. So if I drag it backward, so you see that, and we also have this preview to move from one frame to another. So I might not be able to actually control using play button for some of us that are still learning. So you can just use this back. So you see it's going backward. So if I want to go front and forward, I will use this forward. It will be going forward, and I'll be advancing the movement. So if I go backward, what I want to now get is the initial contact to the floor. So if I keep playing this, so let's just observe the initial. Let's just observe when the heels will come in contact with the floor. So you see that this is when the heels of the right lower limb came in contact with the floor. Now I'm doing this analysis now in respect to the right lower limb, because now the limb that actually made this advancement is the right lower limb. So let's not forget this. So I'm making this now because the limb that advanced or that moved forward is the right lower limb. So I will now pause. I will pick my line 2 again. Now pick it from this point. To this point and leave it. So now you see that I did not calibrate again, but now it's now giving me the measurement, the reading for that advancement or that limb advancement. So no, you don't have to now start calibrating or start repeating anything again. Now it's giving you the exact step length for that limb. So you are seeing 0.86 meters. Now I'll play again. I'll play the video again. Now you see. Now, one thing you need to understand is this. You see, as the person walked past the frame, the measurement and everything disappeared. Now, don't be confused. Now, once the thing disappears, now that doesn't mean that the recording have actually disappeared. The system is taking note of it. Once you export, you will see all those readings. Now, but if you still want to keep seeing the readings, so all you need to do is just go back to that particular frame where it appears. Now, use your line to highlight on right click. So once you right click, come to this track and come to this visibility and say always visible. So once you keep it always visible, even if you walk past this frame, it won't disappear again. So let me play the video. See that as the person walks out of the frame, it didn't disappear again. So that's another way for you to still want to have the value with you. So I take it back Now, like I mentioned before, this is the step length in respect to the right lower limb. Now, I'll play this video. Now, watch. Now, I have to, it has actually ambulated again. And now, this time around, it is the left lower limb that actually make an advancement. Now, if I bring this recording here, this magnifier here, now I will go backward because I want to get the exact time. So this is when the EOS make the initial contact. Now, you see, while we're analyzing, we're able to actually see so many faults that you have to start avoiding when you start your own analysis. So because assuming this place is well lit and well lightened enough, or there's enough lightning on this environment, so that you won't be struggling to actually see when it made the initial contact. Everywhere will not be dark like this. And this video was recorded, I think, in the evening or in the afternoon, I don't know, or in the morning. So there was no enough lightning for this. So it's that this is like one of the reasons why you need to actually have the place to be well lightened enough. So you won't be struggling to see when it was make the initial contact on the floor. Now, this is when he made the left made the initial contact on the floor. I'll pick my line tool again. From here, I will drag it and stop it here, and then stop. Now, without anybody telling us anything, now, if we look at, without anybody telling us anything, if you look at this, without anybody telling us anything, if you observe this movement now, even without looking at this value, you see that the step length, when the person made the initial advancement and the step length with the left lower limb advancing are not the same. So you need that, you see, and these are the things, if you come, you won't be bending down and be looking at the person's leg to know if the left is shorter or if the left is longer. So without the person making that, without you being told, by merely looking at this now, you already know. So this value now will now tell you, okay, this is the actual measurement now, without you guessing if it has reduced or if it has increased. If it has increased. So I play again. I pause. So now I will go back again, and then, like I mentioned before, I right click, always visibility, always visible. Now you play, you pause. Now I take it backward. Now I will bring my magnifier down. Now I will take it backward. So I will now be going forward. So this is when it makes another advancement. And now also bear it in mind that this particular point now is now for the right lower limb, not the left. Now, because assuming we did a record, all I need to do is just to focus on the left, without even bothering myself with the right. So when the person is walking on the right limb facing the camera, I will also take my recordings and compare. Now, I'm just trying to actually compare two different limbs at the same time. Now, I will pick my line 2 again from this point to this point. Again, now I'll right click. I will change the visibility to always visible, and then I will play again. Wait. Now, this time around now, I will bring this magnifier back. Now, I will take this thing backward because this is not the initial contact. So this is the initial contact with the floor. So now I'll pick my line 2. Now, I will draw my line from this point to this point to this point. Again, I will right click. Now I will play the video again. So this is what I will be doing now. So this person gets to the last. Now, I want to tell us something. As we are looking at this value now, if you want to now see the full expression, now this person is a normal individual, and the gate is actually not symmetrical. The left and the right are not the same. Now, imagine when we now have an individual with a pathological condition, either circumduction, that is stroke patient that comes down with circumduction. You now be seeing the person circumduction or dragging the foot on the floor. You see that most times the step length for that particular limb will be reduced. The knee angle will be reduced. Even the hip activation and the hip angle too, both in extension and inflection will also be reduced, because the person will be avoiding to actually bear weight, avoiding to extend the limb forward. So these are the things you now be seeing. All those things Prof was saying in the morning, you now be seeing it being expressed in these basic gait parameters. And you now be understanding, wow, is this what is actually happening? So I drop my two, move my magnifier backward. Now go backward a bit, because this is not, so this is, so I will go forward. So this is the initial contact. So this is the initial contact. So I will pick my line 2 again. From this point to this point. So this is 0.85. Now I will play again. So now I'm going to go backward. So I will draw my line 2 again. So let's not just go over the magnifier over and again, but I've explained that. So because of time. So still have to, so this is 0.5. I will play again. I will go backward. I'll go backward. So I'll draw it, then I will play again. I will draw it. So now I want to now show something. Now, if you look at this place, you see that at every point I draw a line. This particular, the software developed a snapshot of each point. Now, I might choose to actually export this particular thing as video. I might choose to actually export this particular thing. Now, export this particular image, this particular point as image. Now, you now be seeing it as image. Now, I can now say at this point, this is the gate. At this point, this is the gate. So it's creating a snapshot for each individual point at each point where I made the recording or where I drew the line. So also take note of that. Now, if you now come over to the file, if you click on file and you click on export, come to export spreadsheet. See export as Excel. So if I click on export and as Excel, I will label it. Now I've labeled it. Let me now go over and open the file. Open it. So if you can see that I've actually exported something. This is what, can you see my screen?
Yes, sir.
Okay. So if you can see my screen, you see that the first thing you see is the keyframe. You see that there is a keyframe. So this keyframe is this point. At which point did I make that recording? At which point, the time, at what point did I actually record this thing? Now, if you now come below it, under it, you now see the actual distance recorded. Now, hope you remember, do you remember the first line I drew, which was for calibration? Now, the first line I used for calibration was at 0.0 seconds, and it was 2 meters. So this was the reference point that I used. Now, after that, I made the right. Now, I said, most times, if you want to make things clear for you, you can do the left separately and do the right separately. Now, you can see that you now see line 2, which is the, sorry, you can see the line 2. Let me go over to this screen. You see that if you come over here, the first line on this movement is the right that made the ambulation. Now, which is the second on this expression on the Excel sheet, which was at 0.33 seconds, and the time the length was 0.68. So you see that this particular line now is for right. So I might decide to copy it out, because why I'm copying it out is because I did the two of them together. So as soon as I separated it out, there is no need for me to start copying out and start separating it. So you see, and I believe that the facilitators for this, when they will start the actual practical this section, we will throw more lights on it. So you see that this line 2, this is the line 2 for the right. Now the next line that will be for the right will be line 4. If you remember, when we were doing the analysis, so the next line that will be for the right is line 4. The next line again will be the line 6. Will be the line 6. The next line again will now be like line 8. Will now be line 8. Now, for the, and then this is for the right lower limb. Now for the left lower limb, the first line there was line 3. The first line there was line 3. So I'm trying to separate the left from the left from the right. So now the second line there was line 5. Then the third line there was line 7. While the fourth line there was line 9. So as you can see I've actually separated both the left lower limb from the right lower limb. Now, if I want to run my analysis, now you see that this particular point, this particular place now is the time series. The time. This particular point is the time. Now, this point now is also the step length. Is the step length. Is the step length. Is the step length. Let me shorten it. LT. Now, this one is the right. So this is the left. Now, if you want to now analyze now, and if you look at this step length, let's look at the step length first. So if you look at the first step length for the right lower limb, the first step length made the initial ambulation of 0.86 meters. And then why the left made the initial ambulation of 0.68. Now, as time progresses, you see that this particular limb now is slowing down. Now, this particular one started increasing. And then what you are now trying to see, what is happening here is that the left lower limb is trying to catch up with the right. And as they are trying to catch up, the system is now calibrating, telling the left to actually increase your step length, increase your step length. Now, you can see that this one started increasing from 86 to 82, 85, and then went dropped to 72, because this particular one is dragging it backward and trying to make it reduce the step length. Now, this is what you see is also in the normal pathological conditions. Now, for instance, now, if the affected limb is the left, most times you see that the person will actually try to avoid ambulating the other unaffected limb longer, or try longer, because he's trying to actually compensate to make sure that this particular left is actually meeting up with the gap. Now, also another thing you also notice that as the left is weak, the right too at some point will also become weaker, because it's now the right that is bearing more weight. Now it's that the muscle and the energy expenditure for that muscles. Now, as the energy increases, you see that at some point you start reducing, because it's that particular limb that is the active, that is always active. So the energy, the step length will increase, and then you start dropping. And if care is not taken, you see that a lot of other things will start happening. Probably wear and tear will start happening at that unaffected limb. Now, if care is not taken, you see that the unaffected limb that was unaffected before will start having osteoarthritis, muscle weakness, other pain at the hip joint because of overload and wear and tear. Not necessarily because of stroke, Now you see that if you don't resolve the affected limb, see that the unaffected limb will also come down with another issue. The person will start telling you, the left limb is paining me. I'm having pain, joint pain. I'm having ankle pain. Because what is actually bearing more than the expected body weight it's supposed to actually carry. So you now start seeing it playing out in the step length. The step length will start increasing. As time goes on, you start the step length, which is supposed to be normal, will start reducing. You now be wondering, what is this particular limb is normal? Why is it now been moving into collapse and all that? Why is it now been behaving this way? It's not because there is actually stroke on that particular brain or that particular. Now the issue now that's affecting that particular limb is no longer in the brain. Now it's now actually at the muscle because of overload, muscle overload. Now I still believe that Prof will still talk that I'll talk more on muscle overload and then wear and tear and also on shear stress that actually comes upon on unaffected limbs as you tend to actually progress. Because most times you see some people with stroke. Now, if they are not attended to, you see them drag, they will not be dragging that feet up and down. Before you know it, you now start hearing that the person is no longer able to walk. Whereas you now be worried, I thought I saw the person walking before. What happened? Now it's not that the stroke came down on the unaffected limb. No, but the unaffected limb has been overloaded. So it's now reacting to overload, not necessarily to stroke. So I don't know if my explanation actually makes sense now. Makes sense. So if I want to now run a proper analysis here, so this is the left. I bring the left here, paste it. Now this is the right. So this is the right lower limb. I paste it here. Let me paste it here. Let me use this particular place as copy it. Now, if I decide to run analysis, I might decide to like, okay, I like the two separate cells. Now come to insert. Then come to charts. So I might decide to use this line or use this particular line. So I will insert line. Now, this chart now tells me how this movement is being expressed. Let me move it out. Now, if you look at this chart, you see that the red here is the right lower limb, while the blue here is the left. So you see that you don't have to now start looking at this value for you to be able to interpret. But for me, I can actually interpret based on the value. Now, you don't necessarily have to now start looking at the value. Almost I said, if you want to now confuse all the people in the world, now all you need to do is just print this sheet, this particular sheet now. If you print it and attach it to your documentation, now you might decide to say, I want to analyze, if you want to analyze the care pattern. And it's part of the reason why you can actually increase the cost of care, because you're actually introducing new things that will be beneficial to these patients. So if you bring it, you see the behavior, see that the distance between this left and right, you see the distance between the left and right when it comes to step length. See that the left started low, and as time goes on, it now started increasing and started increasing. Now at this place, both of them plateaued for a very long time. So there was more like both of them was actually working almost at the same pace. Now you see that at some point it started reducing. And now when you see this reduction is because now the brain has been programmed. Now most times you start hearing brain, or expression of gait movement. Now this is what we mean. Because now, when we talk about expression of gait movement, that 10-meter walk way is enough for this individual. Now, you see that the brain will not be able to mask, even if you are trying to form. 10 meters is enough for you to describe or actually express what is happening in the brain unconsciously. So the person will not be able to form. Just what you'll be looking at it, you'll not be seeing that at this point it was the left reduced and then it started increasing. Now at this point, now both of them plateaued. Now before you know it, they started reducing because a lot of things will now, they're now accelerating because we're actually meeting our expected end. We are hitting the wall. Now they start slowing down their pace. Now, even as they are trying to slow their pace down, we see that the step length is not still the same. Now, this one now is just for a normal individual without a known pathological condition. Now imagine what will now happen when we have a individual with stroke, osteoarthritis, hip replacement, and total hip replacement, knee replacement, and all that. Or when you want to now, when you prescribe your orthosis or you give or your prosthesis for an individual, you now ask the person to walk. Now you now start seeing that the one limb is longer than the other, or probably the person is struggling to adapt. You understand? Or you now ask the person, okay, go and walk with the person training. After training, the person came back again and now start telling you that this thing is not working. Now you might decide to ask the person, walk, let's see. So you're not observing what you are just seeing, because that day someone might have blown you on your eye, and you will now be saying something with a little star attached to it. You won't be able to actually see clearly, or probably that they might actually be having a family problem and all that. So it's actually affecting your visual process, thought process, and all. So you see that it actually affects your decision. But as you recorded the video and you bring it in and analyze, so you see that you have a clear picture without looking at what the person is working or what the person is working. Because if you ask someone to work now and ask the person to work again, you see that the first step, the first speed, the first pattern of working, and the second pattern of working will not be enough for you to actually will not be the same. Because you see that both of them, the person will not be able to replicate what he did in the first instance. So this is like how you can be able to actually analyze your step length and stride length. And I was notified that the meeting is supposed to end by 5 p.m. today. So I think we'll give time for Prof to take over. And I believe that our facilitators in our respective states will still throw more light and throw more flesh to this. So this is just more like a motivator for us to know that we actually going somewhere. We don't just lose touch now. Know that we have a lot to cover. We have a lot. We have a lot to actually cover. And I can still tell us that this is more like a challenge to the young physios or young process and orthosis practitioners in this meeting, for us to also go back to our private room, our inner room, our prayer room, our working room. Let's all start thinking of which other ways can we also better these movement sciences. Now, let's not just depend on what we know. And now, because now, like I told before, like technology have actually advanced to like a place where you can actually upload a video, and without doing all this, it gives us this individual. And then probably we have a project ongoing that I believe that very soon it will also be visualized, but we have not actually done the validity. But with that, let's just be working with this and try to actually expand our knowledge. Now, one of the things Prof used to say is this: if you don't know the foundation of how things come into play, now if technology brings in something more like those using ChatGPT now for writing assignments and all, now if ChatGPT takes you to main market, now you will be thinking that you are in Obuete without knowing you are in main market. Now, but if you know the foundation and you know the routes to Obuete, if it's taking you the wrong way, you'll be able to actually say, no, I'm not going this route. I want to go back. I'm going to Obuete. So that is where I'm going to. Take me back. So now, so when we start manipulating this technology, this AI, this API software, this backend, for us to start using to analyze, so we'll be able to understand what this particular thing is analyzing for us. What this step length entails, what this stride length entails. You know, just we'll start screaming stride length this, step length this, without knowing the implication or the reason why we're actually using this step length. And I can tell you that if you still go back, you know that we have a lot of indications of using step length, stride length, and joint angles, and so on and so forth. With that, I will actually end my little demonstration here. Thank you so much, and thank you for listening. God bless you.
Thank you, sir.
So that brings us to the end of this workshop. I hope that you've been able to see that you can quantify movement, and therefore you can actually characterize any movement pattern using these variables, the stride length, stride frequency, or velocity. What happens thereafter is, after you have now converted all the movement characteristics to quantifiable values, you now have to ask the question, what are the physiological foundation? What are they telling me? What are the physiological processes that resulted in this movement? What are they saying in the context of this individual and in this time point? So your ability now to apply the physiological hypothesis makes the movement analysis relevant. And I have been doing this since morning with you. We have been working on this together, tying the physiological thresholds to the emergent movement characteristics. It's only when you do that that you are able to understand the language of the human biology system behind movement, understand what it is communicating through this movement, and then be able to also address the issues it has elucidated and make prescriptions that will support or that will help and improve the system. And it will make it clear to you what is pathological and what is movement compensation, what is simply within the realms of physiological reserve issues, of movement reserve issues, and not necessarily pathological issues. So you have seen how we have quantified it. By the time we start interpreting these diagrams you are looking at, it takes a new dimension. And if we had the opportunity of having subsequent meetings, we dive into interpretation. Interpretation is a separate workshop of its own. But it makes it interesting when you're able to add all of this together. So I want to thank you for participating, and I want to believe that this workshop has created a new dimension to your understanding of movement analysis and has given you possibilities and skill sets you can pursue to elevate your practice and improve the quality of our intervention. Most importantly, the clinical reasoning processes that we've been ignoring, the potentials that we have to develop ourselves and also put our professions, the rehabilitation profession, where it should be in promoting healthcare, in preventing diseases, promoting the health of our people, and of course, in making the necessary impact and providing leadership in this area. So thank you so much for attending. Let the conversation continue beyond this platform. We'll address a few questions if there are any. And at this point, we pause for those questions. And if there is none, then we hand over to MROTBN to continue.
Thank you very much, sir. If there is any question, so Prof is around.
Hello, Dr. Yusuf. I have a question, sir.
Okay, sir, you can go ahead.
Yes, please, sir, with respect to stride ratio that you made mention as the very slow and very fast. It's usually in the high side. I try to analyze. I tried to check it in an individual, and I realized the trend of the stride frequency and the stride length, whenever from normal to slow to very slow, it started reducing, or even from fast to normal to slow and very slow, it kept on reducing. So also the stride frequency kept on reducing. But at very slow and very fast, it just shoot up. You were explaining it at some point in time. Please, I don't know if you can come again over it, sir. The reason why it usually shoots up at very fast and very slow. Thank you, sir.
Sorry, can you come again? So are you discussing this diagram, or are you referring to something I said before?
Yes, the under observational analysis, the one that you made mention of the stride length, stride ratio, and stride frequency and the velocity.
Okay.
So you explain, I think you explained the reason why at very fast and very slow, the stride ratio usually shoots up. So is that explanation that I didn't get, please? If you can come again.
Okay, what I'll say is this. The neuromuscular configuration that defines the movement health is the same across all movement types. The way and manner the components of the locomotor apparatus combine to produce movement, they do so using a motor program. The ratio of their combination is the same across all movement types. They only tend to vary when there is a dysfunction. And this dysfunction normally challenges and imposes a physiological limitation. And if you look at the thresholds, I made it clear that it's only when these challenges get to VT1, beyond VT1, that is when compensation begins to arise. And then if you go beyond VT1 to VT2, the system can no longer compensate. But ordinarily, you will see a consistent mechanism. But once it exceeds VT1, you begin to see compensation. Compensation in itself is not pathology, but it's a protective mechanism of the body. But once there is a physiological limitation, such that the thresholds, the movement reserve, is, you are shooting beyond 60 to 70 movement reserve, definitely you're heading towards a failure of the system, functional failure. And that is when you begin to see that the configuration, the stride ratio, which reflects the neuromuscular configuration that produces movement, will no longer be consistent. For instance, in an individual, the ratio of stride frequency over stride length may be 0.8. And if you approximate the whole number, it becomes 1. In some instances, it may be 1.45. If you approximate the whole number, it becomes 1.5. And if you come to maybe speed type 2, that is, if you come to maybe very slow walking, the ratio of stride frequency over stride length may be 1.45. The ratio at slow walking may be 1.47. The ratio at very fast normal walking may be 1.46. The ratio at very fast walking may be 1.78. The ratio at very fast may be 1.49. If all these values I've given you, it will give you 1.5 to the nearest decimal place or to the nearest whole number. It will just give you the same values across. That is the consistency of the neural system. But once there is pathology, that is, once you have exceeded the thresholds, then you begin to have problem. If you take a look at that stride ratio, at very slow walking, it will not be the same. What you will see, you may see a similarity of the stride ratio at very slow walking and at very fast walking. But then at slow walking, fast and the normal walking, they will have a different configuration. In that sense, there is now a physiological limitation imposed by the challenges that warranted that movement pattern. So you need to now understand, what are those challenges? Are they arising from neuromuscular fatigue? Are they arising from motor control issue? Depending on where they fall in, using these thresholds, the thresholds have categorized movement into 4 distinct patterns. And you have given you also options on how to theorize about them, how to raise hypotheses about them, in order to find out what physiological hypothesis better explains them, and then you rule out using the parameters you have developed. So what we are saying, and what I was trying to say, is that if you look at it in that sense, you will see that the neural system is consistent. However, I did also mention that the implication of the gate output arising from international stride length and stride frequency is that it gives us multiple degree of freedom. And the compensation that drives that degree of freedom is expressed mathematically in that equation. That velocity is always expressed as stride length and stride frequency. So if you maintain the velocity to be constant, as when you say, I want these patients to walk at constant velocity, or a patient that walks at constant velocity, what options does the neural system have? Because the neural system is very flexible and it will always adapt itself. It has a zone of adaptation and then compensation and then failure. So when there are physiological changes, it expresses itself in movement changes as well. And so, but the point is that these physiological changes that may express itself in movement changes must also express themselves in the equation that defines gate output, that defines the ultimate gate output, which is velocity. And that equation is stride length and stride frequency. I told you that stride length is a measure of safety because it's an indication of postural control. It's an indication of stability. Therefore, it's an indication of safety when you are walking in upright stance. When stride length increases on one side compared to the other, it means that the side in which it increases, that side has instability. And therefore, to compensate for that instability, it increases. That is to say, if it increases beyond the normal range, then it means that it is a response to instability and it is still compensating. And it means that we have exceeded the VT1 threshold. But there is a point where it refuses to compensate. In that sense, there is a failure. You are approaching system failure, and that happens around VT2, beyond VT2. And I also gave you other physiological threshold that also characterizes that across both the RPE, both the HR max, and the values, that characterizes them, so that you also can profile your patients appropriately and define these processes. Now, since stride length is a measure of safety, two things actually combine to provide a balance. The desire to progress, which is characterized by velocity, and the desire for safety, which is characterized by stride length. Stride frequency contributes to that progression. Because what does stride frequency mean? It means the rate at which your limb is pendulating, the rate at which your limb is digging into the ground to push you forward, therefore to progress. So stride frequency aligns with stride velocity. However, if you want to maintain a constant velocity, assuming you want to travel at a constant velocity of 10 meters per second, it means, for instance, that if your stride length was 5 meters and their stride frequency was 2 strides per second, it will give you 10 meters per second. Should there be a situation that arises because of a physiological challenge to your movement reserve, to your physiological capacity, you may begin to see a shift where that stride length that used to be 5 meters decrease from 5 to 2. And if it decreases from 5 to 2, within that VT1, you will see that the stride frequency will also adjust upwards. It will move from 2 to 5. If it must remain, if it must create a movement output or gate output or velocity output of 10 meters per second. So as the stride length decreases, the stride frequency increases in compensation. And as stride frequency decreases, the stride length increases in compensation. Both of them compensate for one another at constant velocity, except where a physiological limitation is imposed on them. And that happens when the movement reserve begins to deplete. When you are now beginning to exceed 60%, when the physiological challenge begins to exceed 60 to 70%, you are definitely going to end up in compensation. In fact, beyond 50%, you are driving into compensation. And beyond 70%, you are driving into failure. And those are some of the things you need to understand. So I was trying to bring to you that physiological limitation can be captured and characterized using the parameters of human working. And you can connect it after you have quantified it. You can connect the interpretation to the physiological basis that informs movement. So movement analysis in itself starts from understanding the physiological basis, the physiological mechanism, the physiological hypothesis, the integrated physiological systems from the neural system to the muscular system, to the skeletal system, to the cardiorespiratory system, to the cardiovascular system, to the cognitive system, to the visual and sensory inputs that come from the Golgi tendon organs, to the muscle spindles for proprioception and direction, and to the vestibular system that provides balance through the otoliths and the circles, and the auditory meatus that takes the sound into the tympanic membrane and transmitting through the ossicles, and down to the brain through the auditory nerve. All these things are all input that are integrated, and then they plan the movement. And in planning the movement, allowance is now made by the brain when it plans this movement for a neurally driven compensatory drive, where a threshold, the VD1 threshold, is exceeded. But once the movement reserve have not really exceeded that, you can see that the system will flow on its own. But as it is coming towards that VT1, compensatory drive is initiated in order to compensate for, and it is a protective mechanism to retain the efficiency, which is the key, because velocity is a measure of efficiency, it's a measure of metabolic equivalence, it's a measure of metabolic cost of locomotion, it's a measure of energy expenditure. And you want to move from one place to at least cost of energy expenditure, because when the cost of energy expenditure rises drastically, the system becomes inefficient. The individual easily goes into fatigue, and the system cannot be sustained. And you begin to see beginning to pause. And it reflects neuromuscular fatigue driven by very serious compromise of the cardiorespiratory system. The ability to release oxygen is overwhelmed. The production of carbon dioxide is increased. Lactate builds up. And of course, metabolites builds in the system. Blood flow becomes impaired. Everything you need in order to ensure efficient movement is distorted. But those things you need in efficient movement are not in the muscles alone. They are in all the systems that integrate and provide the supportive structures in order to execute the plan drawn by the brain. And so what we have simply done today is to open your eyes to the bigger picture and to bring you to the basics, to let you know and to let us all know that everything that has to do with movement, both abnormal and normal movement, are traceable to the physiological foundation. This is the mark we have missed in the past, and this is a mark we are going back to. Without it, your prescription will have no value, little or no value, because you are going to be prescribing based on one system alone, the musculoskeletal system, without consideration for the cardiorespiratory, for the cardiovascular, and for the cognitive. And all of these systems should be examined when a patient comes to your clinic. And you can actually tap into all of this system by looking at these thresholds, which are connected to the other. There is a question somebody asked, whether these thresholds are connected to something. Dayo, what was that question? Whether these physiological thresholds are connected to...
Yeah, that's a minute. I think it was on YouTube. Just a minute. So let me quickly check.
Yes, it is important because I found that question very interesting and very helpful. And the answers are very obvious. But the point I'm trying to make is that we are, by this, reawakening you know, the proper approach to movement analysis. And so that it's not abstract anymore, something that you conjecture in the mind, something that is so biomechanical. Biomechanical issues only arise after compensatory drive have been consolidated for too long without any help coming to address what actually elicits that compensatory drive. Then it now consolidates and distorts the system, dovetailing into biomechanical issues. And once you go into biomechanical issues, you're approaching system failure. You're approaching physiological failure. You're approaching the point where the thresholds actually fail. The individual, you know, passes that point where that indicates failure of physiological system. And therefore it becomes a worrisome development. And the point we are trying to still make is that we just by looking at these physiological thresholds and linking them to movement, you can predict who has anemia. You can predict who has, low oxygen consumption, or who has low oxygen production, or whose blood is having, where you have a buildup of CO2, where lactate is building. You can predict a lot of things that are systemic, because before you even have the imaging results, before you even have the laboratory blood works, the physiology of the system through the emergent movement actually connects those developments and reflects them in the visible biology. Movement is the visible biology, and it gives you insight into the changes in the biological system. No matter the type of change, it reflects in the movement of the individual. And this is what we are tapping into. And by the time physiotherapy is tapping into it, you will see that by simply getting your parameters together and applying these thresholds, you can come to the ward, look at a patient, take your assessment, and say this patient is likely having anemia, even before the laboratory scientists can do a test. You can say this one is going to have a cardiovascular failure, even before it comes. You can make those predictions, and you will base it on pure science. This is what makes us superior. This is what makes us distinctive. However, that knowledge is not known to us. That is what this workshop is trying to unravel. We have it. It is our area. We must work on it, and we must build it. We must perfect it, and we must actually drive the process. This way, our practice will not only entrench itself as a thoroughly scientific profession, but also our patients. We gain the most because our diagnosis will be more precise, and our prescription will be not just precise also, but adequate. And we're going into precision medicine, and this is part of the pathways that drives us in that direction. So I am there. If you see that, you can ask, and then I can deal with that. Otherwise, I think I have spoken.
I'm done, so I can't find it.
Okay, that's fine. So if there is any other question, we can deal with it. Otherwise, MRTBN, we are good.
Hello, please, if you have any question, even if you can't move, just raise up your virtual hand. Then I'll mute you so that you can ask your question. Any question? So first, I think there is no any question from the participants. So in the absence of any question, on behalf of the foundation, I'm saying a very big thank you, sir, for finding time despite your tight schedules. Thank you so much, sir. We really appreciate, and we know it will really benefit this generation and the generation to come. So thank God that all the workshop was recorded on our YouTube. So for those of us that want to revisit it, you can just search for MRTB Clinical Pathway on YouTube. Then you can watch the lectures. Thank you so much, sir. We really appreciate it. Thank you so much, sir.
Thank you so much for having us. And always feel free to engage. All the participants, feel free to engage, ask questions from myself, from Dayo. You have our contacts. Definitely, we will be happy to provide as much guidance as we know. Thank you so much, and see you in subsequent series.
Thank you so much, sir.
You're welcome.
Thank you, Prof.
You're welcome. You're welcome.
Once up with that, the procurement will reach out to you.
Thank you, sir.
Yeah, you're welcome. You're welcome.
Thank you very much, Prof.
You're welcome. You're welcome.